Good evening, everyone. Welcome to the examination prep series. At the outside, I would like to thank Dr. Gurudatt sir for instantaneously accepting the invitation for doing this. Sir, thank you so much. We are always in debt, and you have always been there for students. Really appreciate, and we always look forward to learn from you, sir. Thank you so much. Today we have two students, Dr. Vinod and Dr. Harish, who will be presenting a case on ischemic heart disease. And at the same time, would like to thank the backend team from Merinit, Mansa, and Jordan for hosting this and taking all the pains for doing that. So thank you once again, sir. Regarding Gurudatt sir, sir is now presently working as the professor and head of the department at JSS Medical College, Mysore. Sir has numerous publications, both international and national. Sir has been awarded good teacher as many times as one can imagine. And sir is the examiner for DNB students, DMD students, and DA students. So, sir, thank you so much, and we'll hand over the mic to you. So, thank you so much.
Thank you, Dr. Azam. And first of all, I'd like to thank Badinit and also Dr. Azam for this opportunity to interact with students, because I always like to interact with students. And this has been an opportunity because, always the physical interaction would be much better as such. But nowadays, that we do have problems in physical interactions. Because I always used to conduct classes for DNB students almost every 6 months.
Yes.
But I'm now missing that particular opportunities. Anyway, now on virtual platform, and I can reach more number of students. So that is one thing about the COVID has given us an opportunity. So ischemic heart disease, when Dr. Azam asked, I immediately accepted, because ischemic heart disease and anesthesia is very commonly asked question, even in theory also, for MD DNB students in many of the universities where the 20 marks question is there. Usually it's a long question. And for DNB students and in Rajiv Gandhi University, now the theory question is only 10 marks question. So 10 marks, usually it will be there. So another thing is, invariably, it will be a long case for, the practical exam. So it is better we, as students, all of you should know about the details about the ischemic heart disease and anesthesia. So today we have two students from Mahavir Jain Hospital, Bangalore. Dr. Vinod is there and Dr. Harish is there. So they are going to present the case, and we'll be discuss about these cases for 1.5 hours today, and also we are going to continue that the same discussion tomorrow also from 9 to 10:30 for another 1.5 hours. So we will start now. I think the students are going to present the case, and we will discuss along with once they complete their presentation. And over to Vinod and Harish to present the case.
You can share your.
Good evening, sir. Myself, Vinod. I'm going to present ischemic heart disease case. Here is a patient named Mr. Sar with age of 55 years, female, occupation by housewife, address near post office, Bank Colony, Chikballapur. She came with the complaints of swelling around the umbilicus since 10 years. Coming to the history of presenting illness, the patient was apparently normal 10 years back when she noticed swelling around the umbilicus. The swelling gradually increased in the size to attain the present size. It is associated with the pain. The pain is intermittent, on and off, dull aching, non-radiating. Swelling reduces while in the sleeping position. There is no history of nausea, vomiting, constipation, loss of weight or appetite. There is no history of dyspnea on exertion, chest pain, orthopnea or paroxysmal nocturnal dyspnea. There is no history of palpitation or syncope. There is also no history of recent upper respiratory tract infection and lower respiratory tract infection. Coming to the past history, she is known case of hypertensive since 10 years on treatment, and also known case of IHD 1 year back post PTCA status. No details available. No history of diabetes mellitus, bronchial asthma, pulmonary tuberculosis, cerebrovascular accident, or epilepsy. Also, no history of previous surgery. Coming to treatment history, she is on tablet amlodipine 5 mg OD and tablet metoprolol 25 mg OD and tablet aspirin 75 mg OD and tablet pantoprazole 40 mg OD and also tablet clopidogrel 75 mg OD, which I stopped 7 days back. She has no history of drug allergy. Coming to family history, there is no similar complaints in the family and no significant family history. So coming to the personal history, it's a mix. She is a mixed diet. Appetite is normal. Sleep cycle is normal. Normal bowel and bladder habits. And menstrual history, menopause attained at 8 years back. Coming to obstetric history, P3, L3 with full term normal vaginal delivery. It was uneventful. Coming to summary of the case about the history. So a 55-year-old female with a complaint of swelling around the umbilicus since 10 years with history of hypertension on tablet amlodipine, tablet metoprolol, and also history of IHD 1 year with post PTCA status on tablet aspirin and tablet clopidogrel.
So, okay, just
Yes, sir.
We will discuss regarding the history, because what is very important in ischemic heart disease, most of it is the history itself.
Okay.
So examination findings are not much will be there, but history itself will give you almost nearly 75 to 80% information regarding how to manage these patients as far as the anesthetic management. So history is very important. So let us go from the first slide itself. Go to the previous slide, the first slide. Now you know that at the end of your history, you have said that this patient is a known case of ischemic heart disease and also a known case of hypertension.
Yes.
So can you get any positive information from particularly the first slide where you are trying to introduce the patient to the examiner? Because she's a female patient, she's 55 years. And the ischemic heart disease is more common in males or more common in
more common in males, sir.
More common in males after what is the age?
After 60 years of age.
So it's more common in males after 40 years, and postmenopausal women, it is also more common. And it can be more severe in postmenopausal women than the males, especially after 55 years. Now here is a female patient who is 55 years. She is now postmenopausal.
Yes,
Isn't it that already you said that she has attained menopause? So that is one positive findings in her history. Suppose if she was only 40 years, so then probably it is less likely that she can suffer from ischemic heart disease. That is always there. So one is, though she is a female patient, but because postmenopausal, so that is a positive findings in your history. So the other important thing here is, the occupation of the patient will be very important, isn't it?
Yes.
So whether if it is a stressful occupation or a non-stressful occupation. So you think that housewife is a stressful thing, or it's not a stressful?
Non-stressful.
No, because don't think that housewife is. There are so many, women are also listening to our discussion. It's quite stressful, especially managing children, managing the husband, and especially here, one thing you have not asked is the economic status of the patient or financial status of the patient.
Yes.
Socioeconomic status of the patient is very important when you are introducing the patient to the examiner. So whether the patient is poor socioeconomic status or moderate or very high socioeconomic status. So that is very important. A housewife with poor socioeconomic status, managing the household with a little amount of finance definitely will be more stressed. So that's why here that is one thing which is lacking. And another thing I just want to tell every one of the students when they are presenting, also give the mobile number of the patient. Ask the mobile number, and also when you are introducing the patient to the examiner, write down the mobile number there, because nowadays everybody will have a mobile number. And why mobile number is important is for following up the patient. Our job will not end by you just send the patient out of the OT. Our job will not end. We'll have to follow up the patient. So if you have your mobile number, especially for example, if a patient develops intraoperative myocardial ischemia or infarction, so you would have sent the patient to the ICU later, and many times you may not do the follow-up. So it's very important you also note down the mobile number of the patient. Okay. Now with this, I just want to ask you one of the questions to Vinod.
Yes.
So there are certain factors which are called as the modifiable factors and non-modifiable factors, risk factors, I mean,
Yes.
for ischemic heart disease. Can you just name some of the modifiable and non-modifiable risk factors for ischemic heart disease?
The non-modifiable are gender, age,
Okay.
ethnicity.
Gender, if you say again, males above 40 years and females postmenopausal females.
55 years above.
Okay, right.
And genetics.
Yeah.
These are non-modifiable.
Familial. You don't say genetics. It can be familial. Isn't it? So the same kind of environment, and many of these brothers or sisters or even parents, they have had myocardial infarction or myocardial ischemia, ischemic heart disease. Many of the other siblings also may have, isn't it? In this, which history is very important as far as the family history is concerned, yes, which you say that it's a non-modifiable history.
So age and gender.
No. You said that family history, isn't it?
Yes, sir.
So what family history will be asking? What particular family history will be asking?
Sir, any her father or mother does have IHD?
No, usually you see once the patients are
cardiac deaths
very old patients, they may even have IHD, and they may, because the age-related changes. Atherosclerosis is very common in as geriatric patients are there, like 80-year-old or 75-year-old. So they may die of ischemic heart disease. But do you think that this family history is very important, or something else you will be taking regarding the family history?
Any sudden death in the family?
Yes, any sudden death in the family in a younger age group.
Younger age.
And any younger age group of patients developing a myocardial ischemia or infarction or even ischemic heart disease, especially between 40 to 50 years. So this history is very, very important, which can make the other siblings also prone for ischemic heart disease. So you always ask any brothers or sisters or even parent who has had an myocardial ischemia or infarction at the age of between 40 to 50. So this is one of the important histories. Okay. Then any other non-modifiable history you will be taking?
Ethnicity.
Pardon?
Ethnicity, sir.
Ethnicity. Okay. Personality. That is very important. Usually the personalities are classified as type A and type B personality, isn't it? So type A personalities are the ones who are very anxious. They keep on thinking about little things too much. And, such type A personalities are the ones who are more prone for ischemic heart disease. Whereas type B personalities are very, very cool, people. They're not bothered about even, even big problems, big troubles. They can face very easily. They have a nice sleep in the, in the night. They don't bother at all. So they are type B personalities. So usually such personalities are less likely to develop ischemic heart disease. So the personality, which is again usually a non-modifiable thing. Of course, you can definitely try to modify your personality by doing meditation, yoga, and all those things. That is there, but it is also considered as one of the non-modifiable risk factor. Okay, so Harish, can you just talk about the non-modifiable risk factors for ischemic heart disease?
Non-modifiable risk factors are lifestyle changes, sir. Diabetes, hypertension, hyperlipidemia.
Okay.
And
most important, which can produce
smoking, alcoholist habits,
smoking.
like smoking.
Smoking is one of the most important modifiable risk factors. It can affect all the arteries and arterioles in the body, like diabetes. So that's why smoking is one of the very important the modifiable risk factor you should always think about. Stress is another modifiable risk factor, isn't it? So that's why, if there are driver and conductors are there, so who is going to have the ischemic heart disease early?
Conductors.
Not conductor. No. Conductor, you must have seen in the night buses and all, he sleeps off.
Driver.
The driver has to concentrate on the road, and so that's how. And again, anesthetists and surgeons.
Yes. Anesthetists.
Surgeons.
Again, you have dilemma between yourself. It is always the surgeons, because during surgery, you are this thing, taking off. We are always compared to pilots, isn't it? Taking off, it is very stressful. Again, landing is very stressful. That means induction is stressful, and recovering the patient is stressful. But throughout the surgery, before surgery, after the surgery also, the surgeons are definitely stressed. So stress is very important, a modifiable risk factor. And another thing is, dyslipidemia, you said, that is again a risk factor for ischemic heart disease. What do you mean by dyslipidemia?
Elevated LDL, sir. More bad cholesterol.
LDL, okay. Which is more important? Triglycerides?
HDL.
Elevated triglycerides and reduced HDL.
HDL.
So actually in males, the HDL should be above 40, and in females, it should be above 50. So if it is low, high density lipoproteins, again, you can say dyslipidemia, and chances of ischemic heart disease is more. And triglycerides are very, very important. If they are very high triglycerides, again, chances of ischemic heart disease will be more. Okay. No, these are some of the modifiable and non-modifiable risk factors, which you should always be knowing about. Now, let us go to your second slide.
Yes.
Now, here you have this patient has presented with swelling of the umbilicus. So it is an umbilical hernia, and you have taken a detailed history regarding the umbilical hernia. So why you should take a detailed history of the umbilical hernia itself? You can answer.
So we have to elaborate the chief complaints. We have to rule out any negative history, positive history like any strangulation or obstruction.
Yes, very good. Very good. So that is the most important thing here, isn't it? Whether it is you are taking up this case as an elective procedure, or you have to take it as an emergency. For example, if it is an obstructive umbilical hernia or a strangulated umbilical hernia, so you may have to take it up as an emergency. So suppose if you have to take it as an emergency, what are the problems for you? Yeah, Harish, can you just tell me what problems you expect? For example, now it has to be taken up as an emergency. So definitely, or will you have enough time to optimize the condition of the patient?
We don't have enough time. We won't
you
get
won't
enough
have enough time to even evaluate the patient.
Yes,
isn't it? No time to evaluate the patient, no time to optimize
the patient.
And always you think that it is a full stomach patient.
Yes.
And we don't know what about the electrolyte imbalance. We don't know about the fluid imbalance.
Dehydration.
And multiple problems we can have. Even the patient may be having a severe ischemic heart disease, which you will not be knowing, isn't it? So if you just go with the algorithm of 2014 ACC/AHA guidelines, so in that algorithm also, patients with cardiac condition posted for an emergency surgery. So definitely, and it all depends on how emergency is the surgery, and you may have to take up without much evaluation. So that is always a problem. So that is the reason why probably you have to go into details about her presenting complaints. So here, one more thing I want to ask Vinod.
Yes, sir.
So how do you classify these surgeries as such?
Like high risk surgery, intermittent surgery, and low risk surgery.
No, I'm not talking about surgeries regarding ischemic heart disease.
Yes.
Routinely, because of the time you have.
Emergency surgery.
Time you have, how do you classify the surgeries?
Emergency surgery.
Okay.
Urgent surgery.
Very good.
Elective surgery.
No, between that. Between urgent and elective. Something called the time-sensitive surgery. Time-sensitive surgery. So, Harish, what do you mean by emergency surgery?
Emergency surgery is life-threatening to the patient or limb-threatening to the patient.
Very good. So it has to be done
within 6 hours of.
Ideally within 1 hour. As early as possible. For example, now let us say abdominal aortic aneurysm rupture is there, or a cesarean section is there, the patient is bleeding, APH is there, or a fetal distress is there. So they are all emergency surgeries. Urgent surgeries are the ones where you have about 6 hours. Any surgery wherein you can have 1 to 6 hours, they are all urgent surgeries. And time-sensitive surgeries are, you can have almost up to 6 weeks. Can you just give an example for time-sensitive surgery?
Oncosurgeries.
Yes, very good. So oncosurgery. So why? And in elective surgeries, you can even postpone for 1 year, absolutely no problem. It is like that. So why it is important for us to classify these surgeries as such? For example, now a time-sensitive surgery is there. A patient with ischemic heart disease has been posted for a oncosurgery. So you have maximum, you can postpone for about 4 to 6 weeks. So Harish, why it's important to know about this particular time-sensitive surgery as far as ischemic heart disease patient is concerned?
Meanwhile, we can evaluate the patient during that period.
No, especially we know about these, interventional procedures, isn't it? Revascularization procedures. So, you have to have, we'll discuss about these things later. So you have to have a gap of certain periods.
Yes.
And even if the patient has had an MI, and again, when to take up the patient after MI, the earliest. So you have to think about this particular period, isn't it? So that is the reason why you have to classify these surgeries into, emergencies, urgent surgeries, time-sensitive surgeries, and elective procedures. Okay, now we'll go for the other things. Whenever a patient with cardiovascular disease is there for you in the exam, let it be a mitral valvular disease or any cardiomyopathy patient or even ischemic heart disease patient. So you'll have to go into details about 5 symptoms. And very important about these 5 symptoms, you have to go into details. One is the chest pain. Second is dyspnea.
Yes.
The third is, any palpitations. Fourth is syncopal attacks, and fifth is edema. So these 5 things, you have to go into really in depth and then get maximum information from the patient. Okay, here you have written about chest pain. There is no history of chest pain.
Yes.
So at present, there is no history of chest pain, but the patient must have had chest pain for which she has had a revascularization procedure, isn't it?
Yes.
So if you think that the patient gives you a history of chest pain, first of all, you'll have to rule out cardiac chest pain, isn't it? Or you have to decide whether the chest pain is due to a cardiac origin chest pain or a non-cardiac origin chest pain. So you know that cardiac origin chest pain is called as angina, isn't it? So, can you just describe an angina? How the patient will present?
So patient will present with a retrosternal chest pain.
Retrosternal chest pain, right?
Feeling heaviness in the chest, sharp or throbbing pain, which is radiating to the left shoulder mainly till the little finger.
Okay.
And also the lower jaw.
Okay. And any aggravating features?
Generally, it will be aggravated on exertion. It gets relieved by rest or nitrates.
Okay. Yes, aggravating emotional exertion or physical exertion, it is always there. So radiation, the site of pain that you already said, and any associated symptoms also will be there.
Nausea, vomiting, sweating.
Nausea, vomiting, sweating. Yes, why nausea and vomiting can be there? Why nausea, vomiting, sweating, syncopal attack also can be there?
Because of sympathetic stimulation.
Sympathetic stimulation will produce actually the sweating. Palpitations and sweating can be due to sympathetic stimulation. There can be a decrease in cardiac output because when a patient has angina, what happens to the myocardial contractility?
Dead.
Decreases, isn't it?
Yes.
So once the myocardial contractility decreases, cardiac output also decreases. There can be a sudden decrease in the blood flow to the brain. So a patient can have nausea, vomiting, syncopal attacks. Associated features are also very important to ask about. Okay, so this what you just discussed is about stable angina, isn't it? So usually the angina is classified based on Canadian Cardiovascular Society classification. Can you just briefly, can you just tell how the angina staging or grading is done?
There are grade four grades, sir.
Okay.
Grade 1 is a patient will get angina after exertional work of more than normal physical activity. And grade
you
2,
you can say, like, NYHD classification, just like that, you can always talk about angina for ordinary, no angina for ordinary
activity.
Very good.
Grade 2 is angina for ordinary activity.
Yes, very good.
Grade 3 is for angina for less than ordinary activity.
Yes.
Grade 4 is at rest or very minimal activity.
Yeah, so that's how you can always classify. Now, Vinod, why should you classify the angina grading? Why should you do this?
So because we can know that it's an unstable angina or an stable angina. It will get reduced by its own, or it will not reduce.
So when you say the angina has become unstable,
when the pain will be more than 10 minutes, 10 to 15 minutes, which not relieved by rest or by nitrates.
Okay, very good. And what about the exertion?
Grade 3 and grade 4.
So minimal exertion also, because before it was not producing angina when the patient probably was walking maybe about 1 kilometer or 2 kilometers. Now even if he walks for one block like 100 meters also, he may be getting, and rest angina, isn't it? Even at rest he may be getting angina, and also nocturnal angina. Yes, that is also one of the unstable angina. Harish, what do you mean by nocturnal angina?
Nocturnal angina, when patient sleeps, there will be increased in the venous return to the blood to the left ventricle. So left ventricle cannot cope up with increased volume. It increases the left ventricular end-diastolic pressure, which causes the pulmonary pulmonary edema and causes the pain.
So what is the importance of this? Pulmonary edema means you are talking about probably, paroxysmal nocturnal dyspnea, isn't it? So that also we will discuss later when we discuss about dyspnea. Here, what is happening is, as you said, left ventricular end-diastolic volume increases, left ventricular end-diastolic pressure also increases. So in a ischemic heart disease patients, when left ventricular end-diastolic pressure increases, what happens to the supply of oxygen?
Demand will increase and supply will reduce.
Supply will reduce, isn't it? Because we'll come to that, the factors influencing the supply. One of the most important factor is coronary perfusion pressure, wherein diastolic pressure minus left ventricular end-diastolic pressure. So during sleep, the blood pressure usually comes down. So the diastolic pressure may be on the lower side, but left ventricular end-diastolic pressure is increasing. So perfusion pressure is increasing. So that itself will reduce the oxygen supply to the myocardium. Second thing is, LVEDP also is going to increase the tension, wall tension, isn't it? Any increase in wall tension will increase
oxygen demand.
So suddenly the patient may go in for a critical situation wherein the supply is less and demand is increasing. So at that particular moment, he may wake up with angina, which is called as nocturnal angina, isn't it? So something called as a postprandial angina. Can you just tell about postprandial angina, which is again an unstable angina?
It occurs immediately after the meal because the blood supply is deviated to the GIT. So the reduced blood supply to the heart. So that aggravates the, again, increase in the demand. So that reduces the coronary perfusion pressure.
No, it may not increase the demand, but it decreases the supply. So there will be an imbalance between supply and demand, isn't it? So this is again a unstable angina, but the problem here is you may not be able to differentiate whether it is due to reflux esophagitis or is due to angina, isn't it? So you have to be extremely careful with this. So many times you may get confused with, gastrointestinal problem, gastrointestinal reflux disease also can present like that. So, but in a patient with ischemic heart disease and presenting like that, so first diagnosis should be unstable angina. Okay, now Harish, why are you bothered about unstable angina? Why should you classify angina into stable and unstable as an anesthesiologist?
Unstable angina patients are at they're more critical. They supply demand. They get angina at very minimal stressful activities, and as we know, surgical and anesthesia procedures like intubations are very stressful. So they're very.
One thing before you go into details about this, as far as the coronary artery disease is concerned, where you classify this unstable angina, there is something called as acute coronary
syndromes,
isn't it?
Yes.
So unstable angina is usually classified as an
acute coronary
syndrome. So what are the acute coronary syndromes other than unstable angina?
NSTEMI and STEMIs.
Yes, isn't it? So even this unstable angina can be myocardial infarction. We don't know, isn't it? So all acute coronary syndromes, if you go with the algorithm of ACC-AHA for accepting the patients, so it is an active cardiac condition. Any active cardiac condition, when the patient is posted for an elective procedure, you don't take them up, isn't it? So this unstable angina is an active cardiac condition. So this has to be first, optimized.
Yes.
So the patient may have to be referred immediately to a cardiologist. Even the patient may require either modification of his medical therapy, or he may require even a revascularization procedure before you take him up for elective procedure. So because the risk of the patient having an intraoperative myocardial infarction or even in the postoperative myocardial infarction is very high in these patients if they have, because they are already having a critical supply demand problem, isn't it? So you have to be extremely careful. That's how this history of angina, especially the unstable angina, is very important to take. So that is one thing. So again, I was talking about the active cardiac conditions. Vinod, can you just name other active cardiac conditions other than the unstable angina or acute coronary syndromes? Because the first step as far as the ACC-AHA guidelines is any patient with active cardiac diseases, you don't accept for any elective procedures, only life-threatening or limb-threatening emergency procedures you're going to accept. So can you just name other active cardiac conditions?
Like arrhythmias, sir.
What kind of arrhythmias are called as active cardiac conditions?
So Mobitz type 2 and
okay.
atrial fibrillation
type 2, that is second degree AV block with Mobitz type 2, right?
And atrioventricular.
So it is not just Mobitz type 2, Mobitz type 2 with symptoms.
Yes.
Yeah, he has to be symptomatic for decreased cardiac output. So Mobitz type 2 symptomatic, then complete heart block.
Yes, complete
heart block. Then
supraventricular tachycardias and ventricular tachycardias.
No, VT, VF, definitely VF, the patient will be in arrest. Yeah. So which supraventricular tachycardia, especially any atrial fibrillation? Yeah, AF, all AF is considered as acute active cardiac condition.
Symptomatic.
Not symptomatic.
Uncontrolled atrial.
Very good. Uncontrolled rate. Suppose the patient with atrial fibrillation is there, has not been given any beta blockers or calcium channel blockers or digoxin, which are amiodarone to treat, so that rate modulation or even rhythm modulation has been done. So such patients with high rate, so you should consider it as an active cardiac conditions. So again, the patients in cardiac failure. All patients in cardiac failure also you consider them to have active or cardiac conditions. So these are the patients who are at very high risk of developing, major, cardiac complications, which is called as MACE. So that is what you have to be very careful in these patients. Okay, now the other than the angina, now the other thing is about you have talked about dyspnea, isn't it? You have written here that no history of dyspnea and exertion. So again, why dyspnea is important, and how do you classify the dyspnea as far as cardiac dyspnea is concerned?
So dyspnea is an unpleasant awareness of one's own breaths. It is classified by NYHA classification.
Okay.
It is graded into 4, sir. Grade 1, grade 2, grade 3, and grade 4.
Okay.
Grade 1 when the symptoms occurs in the no symptoms occur in the ordinary activity.
Okay.
And grade 2 is symptoms occurs in the ordinary activities. And grade 3 symptoms occur with a minimal ordinary activity. And grade 4 the symptoms occur at the rest also.
Okay. Now, what do you call this patients with grade 3 and grade 4 dyspnea? This is actually NYHA classification for patients in cardiac failure, isn't it?
Yes.
So suppose a patient has, your patient, fortunately, there is no history of dyspnea and exertion. Yes. So, but suppose the patient is there who has dyspnea on minimal exertion or dyspnea even at rest, that is orthopnea also. So these patients, what do you think they have?
Congestive cardiac.
Yeah, they may have cardiac failure, especially in a patient with ischemic heart disease patient. He may have a poor left ventricular function. So that is why it is very important to know about the or classifying the grading of dyspnea. Suppose why I'm should be bothered about if a patient has got grade 3 or grade 4 and I am suspecting the patient to have a poor left ventricular function. So why it's important?
We can optimize or we can further go for the evaluation where that's grade 3 and grade 4 comes in the base high risk factor.
You have to evaluate the left ventricular function, sir.
Okay. Okay. No, is it just preparing the patient? Suppose I take this patient for surgery. What modifications I may have to do in a patient with poor left ventricular function, which is actually is very, very important to know in your pre-anesthetic evaluation, whether the patient has got a good left ventricular function or a poor left ventricular function. Patients with good left ventricular function, you know that they have got good reserve.
Yes,
and
yes.
For everything, what we always look for is the reserve capacity they have, yes. Whether it is a pulmonary system or renal system, end-stage liver disease, whatever it may be, what is the amount of reserve? So if they have good reserve, so you don't have to worry much in managing these patients. So that means a patient with poor left ventricular function means the reserve capacity of the cardiovascular system or the heart is very poor. So why, as an anesthesiologist, you should know what modifications you may have to make. Suppose the patient has got poor left ventricular function, as far as the anesthetic technique itself.
Yeah, we should not allow the sudden drop in systemic vascular resistance, any hypotension we should avoid.
So naturally, you may not be able to go for a central neuraxial block in such patients, isn't it? So otherwise, the patient with good left ventricular function, you can easily go for central neuraxial block, maybe epidural, maybe spinal. We'll discuss that later. So this is one thing. So just knowing whether the patient has got a poor left ventricular function or good left ventricular function. So you may have to, change your technique of anesthesia. One, suppose if you're going in for GA in this patient, again, what are the other problems? Can I use propofol?
No.
Yeah, then that
Depends
also,
upon
induction itself. Induction itself, I may have to be very careful, and managing the patient throughout also is maybe very difficult. And also you may require to go for invasive monitoring. You may have to go for a direct arterial line and central line for these. Fluid management maybe becomes very critical in these patients, isn't it? So if you just give more, they may go for pulmonary edema. If you give less, they go for severe hypotension. And these are the patients who may also require post-operative management in ICU, ICU management. So you see why it is so important to just classify dyspnea. Grading of dyspnea is so important for us to have so much of knowledge about what to be done with this particular patient, how to optimize, what all the problems I do expect as far as the anesthetic technique and management is concerned. So other than the dyspnea, one very important thing, though you have you are not mentioned here, is the functional capacity of the patient should be included in the history itself.
Okay, sir.
Functional capacity.
Okay.
So every patient you have to ask about functional capacity, and then that has to be included in the history, because again that carries a lot of knowledge as far as managing these patients are concerned. So how do you check for the functional capacity in a cardiac patient?
We ask for metabolic equivalence.
Okay.
If the patient is able to claim
what is Harish, one metabolic equivalent?
Regular household walking.
So what do you mean by one metabolic equivalent?
One metabolic equivalent is consumption of 3.5 ml of oxygen per minute per kg.
Okay, why is this important? Again, for example, if I say patient has 5 METs, so what will be the amount of oxygen that is required for that particular exercise?
Approximately 20 ml.
Yeah, 5 multiplied by 3.5.
15 plus.
So it is actually the amount of oxygen required for a particular exercise you are trying to get by doing this functional capacity assessment.
Yes.
And which is usually, when you say METs, which particular index is usually used?
Duke's activity status index.
Yeah, Duke's activity status index. How many criteria are there in Duke's activity status index usually? How many? It's a questionnaire, isn't it? Actually, it's a questionnaire.
Yes, it's a questionnaire.
So how many questions usually regarding the physical capacity you'll be asking?
10.
Usually 12.
12.
Based on Duke's activity status index, is 12 questions you'll be asking, and you'll be giving scores for these activities. And finally, what is the formula for calculating the METs?
So 0.43
yes
into Duke's index, sir. The sum of questionnaire numbers.
Okay.
Plus 9.6.
Okay.
So this
divided
gives...
by... No, you have to divide it by 3.5.
Divided by 3.5. Yes.
Yeah. You know why I asked you this is, sometimes you may be asked by any examiner to calculate based on, Duke's activity status index. How do you calculate the METs one? And when you are writing down in theory, it should always write down regarding this particular formula. It's a very simple formula, so you could express so easily, you could memorize. So it's very important to memorize and then tell in the exam also. So again, you know that if a patient has, how do you classify based on these METs regarding the functional capacity of the patient? When do you say patient has excellent? When do you say patient has got moderate? When do you say patient has good? And when do you say patient has got poor?
More than 10 METs is excellent, sir.
Okay, good.
4 to 10 is 7 to 10 is good.
Good.
And 4 to 7 is moderate. Less than 4 is
poor.
Person.
Isn't it? So again, functional capacity is very important. Again, it will give you an indication regarding the functional reserve capacity the patient has, isn't it? And with the algorithm, it is very easy for you. So if a patient is posted for a high risk or elevated risk or intermediate risk surgery, you just have to know what is the functional capacity of the patient. So if the functional capacity of the patient is more than 4 METs, you don't require to do any other non-invasive tests. Yes. Cardiac tests also not required. So such an important thing. So when you are actually presenting, always see that you always talk about the METs, because invariably there will be some questions regarding METs. So you'll be asked about and you have to answer. So suppose, something else is there in respiratory system about the functional capacity. So what do you call that in respiratory system? Almost akin to the METs in cardiovascular, evaluation. Pulmonary system.
Cardiopulmonary reserve.
No, that is there. So METs is also a cardiopulmonary reserve only.
Yes.
Mainly when you talk about a cardiovascular case, you will be talking about METs. when you are talking about respiratory case, what you'll be talking about? Have you heard about VO2 max?
Yes, sir.
Yes.
Yes.
Isn't it? It's
Yes.
almost same as max only, VO2 max. So that you can go for, even you can ideally, you for calculating the VO2 max, you require a cardiopulmonary exercise testing in a lab. But otherwise also you can easily know by taking the history, VO2 max. And always, VO2 max and max, almost you can say both will give you an indication of cardiopulmonary reserve. So you can always ask about the patients whether they are able to climb a particular number of flights of stairs, isn't it? So again, we know the how do you assess the METs based on climbing of the stairs?
Sir, more than 5 flights, it will be more than 10 METs.
Okay. Or, if you talk about
20,
max,
20,
yeah, 20 ml per kg per minute.
And
Okay.
if it is more than 4, then it will be 4 to 7 METs, where this one 15 ml per kg per minute.
Yeah, 3 flights, 15 ml.
Okay. Then 2 flights.
12
More
ml.
than 10 ml. Yes.
2
Less
flights,
than
12 ml. And less than 1 flight, it is less than 10
less than
ml.
10 ml.
Isn't it? So that's how, the METs also you can always check about based on the patient's functional capacity. And whenever you are doing a cardiopulmonary exercise testing, very important thing is called as anaerobic threshold.
Yes.
So what do you mean by anaerobic threshold?
So that's the threshold where like 9 to 11 ml per kg per minute, it is the value where.
No, it need not be 9 to 11.
Okay.
Anaerobic threshold is at which, the tissues will start going in for anaerobic metabolism. The lactic acid will start increasing because, that all the tissues are supplied by cardiac output with oxygen. At a particular exertion level, the amount of oxygen that is being supplied may not be sufficient. At that particular critical period, the tissues will go for anaerobic metabolism and, lactate will be produced. So in cardiopulmonary exercise testing, they also will measure the lactate levels and they calculate the anaerobic threshold. Suppose if a patient has got very high anaerobic threshold, so naturally has got a very good reserve. That means he could increase the cardiac output to that level even to manage that amount of exertion. So that's why the anaerobic threshold, suppose if a patient, you said about 10 ml per kg per minute of anaerobic threshold. So if it is less than that, then definitely these patients will have a very, very poor reserve and require a lot of optimization and will, have probably high incidence of MACE also intraoperatively and perioperatively. Okay. Now that is regarding the functional capacity, which is very, very important, and you have to take that history. So the other thing I told you is about palpitation. You have also written there is no history of palpitation. So you should always elaborate on that. So what is palpitation, Harish?
Sir, it is unpleasant feeling of one's own heartbeat.
Okay. So what are the conditions in which the patient can develop palpitation?
So it can be seen in tachyarrhythmias like supraventricular tachycardia, like AF, atrial flutter.
Can it also produce in palpitations can be produced in bradyarrhythmias? Suddenly the patient will feel suddenly missing beats. It is very unpleasant.
Yes.
So it can occur, majority of the times it is a tachyarrhythmias. It can also be produced as bradyarrhythmias, especially, type 2 or type 1 AV blocks, second degree AV blocks. And very common these patients can have. Or majority of the times it can be, the cause can be tachyarrhythmias, especially, SVTs and monomorphic VTs or even atrial fibrillation. So these ischemic heart disease patients, are they prone for all these kinds of problems?
Yes, sir, they are very.
Yeah, these patients can be prone for atrial fibrillation. They are prone for SVTs. Sir. They are prone for AV blocks. They are prone for even sick sinus problems or, SA node problems. isn't it? All these things are there. Suppose why it's very important to know whether these patients are prone for this. Suppose the patient also has an AF, atrial fibrillation, and why it's important for us to know about this.
So it may occur, embolism may occur because.
So atrial fibrillation means one thing is they may go for suddenly stable angina can become
Unstable.
Unstable angina. We'll come to that because heart rate is so important. It is present in both supply and demand. Suddenly, the patient who was fine suddenly may go in for unstable acute coronary syndrome. That is one problem. The other thing is, as you said, they may be prone for thromboembolic phenomenon. So we know why they are prone for thromboembolic phenomenon if they develop AF.
So again, there will be in myocardial ischemia.
There will be stasis of the blood in the
stasis of the left atrium. Yes.
Yeah, stasis of blood in the left atrium. So any stasis can produce a thrombus, and this thrombus may be ejected into the circulation, and most often where it can go?
Cerebral circulation.
Yeah, cerebral. So these patients are likely to develop stroke. So these patients may require anticoagulant therapy, isn't it? So if your patient has palpitations, you should always think, yes, this patient may also, if he has given history of palpitations and he is on a particular drug, because many times you don't know what drug these patients are on when you are asking the history. So they may tell you that they are on blood thinners, isn't it? So blood thinners can be antiplatelet drugs also. So how do you, Harish, differentiate when you are taking history whether the patient is on antiplatelet drugs or anticoagulants?
So with prior history of any chest pain, whether the drug was prescribed for chest pain or prescribed for such an event like palpitations.
So antiplatelets are also routinely given, isn't it?
Yes.
So suppose the patient is on, majority of the times the patient will be on oral anticoagulant drugs. And the most commonly used oral anticoagulants are either warfarin or acetram, that is vitamin K antagonist. So these patients require any investigations?
They will be checking APTTs frequently, monitoring of the.
Not APTT, INR, oral anticoagulants. So the patient is on oral anticoagulants. They do require to check their INR every 3 weeks. So you just have to ask them, so are you getting any investigation done every 3 weeks? So if they say yes, then you will have to think that the patient may be on anticoagulants. So it's very important for us. Is it important for us to know that whether the patient is on anticoagulant therapy or not?
Yes, sir.
So why should you know whether the patient is on anticoagulant therapy or not?
So if a patient is on anticoagulant therapy, we may have to bridge with IV heparin. I think if the patient is on platelets,
so there are a lot of problems will be there for us as anesthesiologists. If the patient is on anticoagulant therapies, and you may have to think about when to stop the oral anticoagulants. So what investigations you have to do, whether bridging is required or not, and when to take up these patients for surgery. There are so many things to be answered, isn't it? So that's the reason why it's so important to know about palpitations, and if the patient has had any ischemic heart disease and which has produced an atrial fibrillation. So it becomes very important. Just like that, one question for Vinod. So if a patient has developed atrial fibrillation, do you think that all the patients require anticoagulant therapy for chronic atrial fibrillation?
No, sir. If it is a controlled.
No, whether it is controlled, not controlled, the atrial activity is not there.
Yeah. But
even if you are rate controlled, majority of the times we go for rate control. And especially this can occur in geriatric patients, hypertensive patients, mitral stenotic patients, hyperthyroid patients, collagen disorder patients. So these are the patients who are prone for ischemic heart disease. So your patient is also a hypertensive patient. So, such patients with atrial fibrillation. So when you should require anticoagulant therapy. So because, once you start the anticoagulant therapy, patient will be at high risk of bleeding, isn't it? So they have to monitor. So it is not just like giving any drug. So you have to think many times before, prescribing anticoagulants to the patients. So have you heard about charts VAS scoring? Any idea, Harish, charts VAS scoring? Can you just tell me about charts VAS scoring? So it is CHADS VASC. So I am just telling you, C stands for congestive heart failure. H stands for hypertension. So you are going to score 1 point for congestive heart failure, 1 point for hypertension. A stands for age more than 75 years. And the patient will score 2 points. And D stands for diabetes mellitus. And S stands for any history of stroke or CVA. So again, for stroke, 2 points. And then V is peripheral vascular disease. Again, 1 point. A is age between 65 to 75. For above 75, you had scored 2 points. 65 to 75, again 1 point. And female sex. SC is female sex. So you start scoring based on charts VAS score. And if a patient scores 0, but atrial fibrillation is there, they don't require any anticoagulant therapy. If the patient scores only 1 point after this, again, they don't require. If the patient scores 3 points, definitely, you have to put them on. They are at high risk of developing a cerebrovascular accident because of the thromboembolic phenomenon. So you have to put them on anticoagulant therapy. Between 2 and 3, if the patient has only 2 points, but not 1, so then you'll have to think about the benefits of anticoagulant therapy and the risks of anticoagulant therapy, and then you have to decide. So any patient who scores 3 and above definitely will require. So suppose a patient with 1 point has been given anticoagulant therapy. So he is at low risk of developing cerebrovascular accident. So he does not require any bridging therapy. That's what, as anesthesiologist, it's very important. So if a patient has got 3 and above and has been on anticoagulant therapy, definitely he requires bridging therapy. So if a patient has 2 and has been given anticoagulant therapy, then again, so he may not be in very high risk, he may be in intermediate risk. So you can bridge or you need not have to bridge. So that's why bridging, because these are the things which we are going to do, isn't it, before taking up the patient for surgery. So that's why you have to memorize this charts VAS scoring. Okay, any other question regarding this? Do you have any doubts? Clear?
Yes.
Regarding atrial fibrillation. So
Yes.
Other thing is, the patient also may be, because of ischemic heart disease, patient may also be in, complete heart block, an acquired heart block. So the patient has got an acquired heart block, what else he requires?
Pacing.
The pacing. So that history is again important for you when you are taking the history, because the patient is on a pacemaker, and there again your whole managing the patient, everything will become quite different, isn't it? If the patient, you have to assess when the patient has had a pacemaker implanted, what kind of pacemaker, whether the pacemaker is functioning or not, whether you are going in for what kind of surgery, whether it is suprainguinal surgery or infrainguinal surgery, whether you require to bring the patient to asynchronous mode, isn't it? So what sort of monitoring you have to do in these patients, what all the things you have to keep ready. So there are many things, isn't it? So that is why any kind of palpitations, and if the patient has developed because of an ischemic, because AV blocks are very common because of either degenerative problems or because of ischemic heart disease. So especially in an older patient with ischemic heart disease, the high chances that he may also have an AV block and maybe on a pacemaker. So this history becomes Very, very important. Okay, one more thing other than the palpitation in your slide, it is syncope. So why did you ask Vinod about syncope in this patient?
Sir, in unstable angina, there may be chances of syncopal attacks. So that would be less reserve volume.
So you must have heard about revised cardiac risk index.
Yes, sir. Reverse.
Isn't
Yes.
it? So syncope can be a
Cerebrovascular
symptom of cerebrovascular disease, isn't it? It can be TIA, transient ischemic attack. So even the patient may give you a history of stroke also. So actually in the revised cardiac risk index, this is one of the criteria which is very, very important, isn't it? So that is why syncopal attacks, you should always ask about whether the patient is having this kind of a thing. So, okay, that is another thing I just wanted to tell you about the 5 things. I think we discussed about all the, one more thing is about edema. Okay,
Yes.
Harish,
Yes,
why
sir.
edema is important?
So
For your
patients with
conversation.
right heart failure can have dependent edema. It may
Yes,
be
very good.
progressing with day as the day progresses.
So that means the patient, if there is history of edema is there, pedal edema is there,
Then
or
we
even puffiness of face is there. There are multiple causes are there. The most important cause for us when we are discussing about the cardiovascular disease is
congestive.
the right heart failure, isn't it? So right heart failure, and other thing is, the nephropathy also can produce puffiness of face, and peripheral edema is always there. So one thing you should always realize, any patient with cardiac failure which is not been optimized should never be taken up for any kind of elective procedure, because it is an active cardiac condition. Just asking about the edema in a patient with cardiac disease, and if the patient gives you history of edema and still having edema, so you'll have to think twice before accepting the patient for any kind of elective procedure. So you have to really optimize if the patient has cardiac failure. So other edema is the history of pulmonary edema. It is not the peripheral edema, the history of pulmonary edema also. Any history of pulmonary edema again is very, very important, especially when you are going in for these risk indices. One of the risk indices was introduced by Datsky. Must have heard about Datsky's risk indices. Goldman's risk index was the original first one, modified by Datsky. In the Datsky, again, he gives a lot of importance for pulmonary edema, whether there is history of pulmonary edema, or recent history of pulmonary edema, active pulmonary edema. So because high chances of these patients developing multiple problems perioperatively and postoperatively. So that is why edema is again important, whether it is history of pulmonary edema or history of peripheral edema. So that is again important. And one more thing is, again, these patients are also prone for any patient with ischemic heart disease or hypertension, prone for nephropathy also, isn't it? The end organ damage. So again, any patient with nephropathy again can develop edema. So again, that is an important thing, especially revised cardiac risk index. One of the criteria is again creatinine, isn't it? So such patients you may have to look for the creatinine levels also. Okay, now the other history in this patient, can we go for the next slide?
Yes.
Sir, before we go,
Yeah.
I believe 300 plus students have joined. So
Right.
just requesting the students to leave any comments in the chat box so that we can answer if they have any queries or anything.
Right.
So
have they asked any questions by now?
Yeah, sir. There one couple of questions have come in. One is why by Dr. Gandhi Shanmuga Velu.
Okay.
Sir, flight of stair means what?
Okay. Okay. So instead of asking Vinod and Harish, I am going to answer this.
Yes,
one flight of stairs is 20 steps. And each step is of 6 inches. So because, we have to standardize these things, isn't it? Unless you standardize, you don't know. When you are asking about the history regarding the number of flights the patient can climb. So it is 20 steps, each step is of 6 inches.
Yes, sir. So the other question was, is it very important to know there is METs. What is MET 1, MET 2, MET 3, MET 4 in the exam? Will we be asked in the exam?
No, it is not very important to know about these things as long as you know that patient can climb 2 flights of stairs and or he's going to walk about a kilometer, that is about 3 or 4 blocks. Each block is about 110 meters. The patient can walk more than 4 blocks. So you know that the patient has more than 4 METs. So for us, it is only 2 things, less than 4 METs or more than 4 METs.
Yes.
So if there are more than 4 METs, so we are happy. If the patient has got less than 4 METs, so our job becomes more, problematic. So
Sure.
that is there.
Thank you, sir. One more question by Dr. Karthik was, do we have to ask the history for rheumatic heart fever? I mean, rheumatic heart disease to rule out any fever history? Should we ask in ischemic heart disease also?
No, in ischemic heart disease, you need not have to.
Need not ask.
Because if you are thinking that this patient has got a valvular heart disease, and the most common valvular heart disease in India is mitral stenosis because of the rheumatic origin. So that you may have to ask. So that is most important. Sometimes, the patient also can have aortic valvular heart disease, especially the bicuspid valve producing aortic stenosis. So also can mimic all the symptoms of ischemic heart disease, because we know that any patient with aortic stenosis is going to have an increased demand and a decreased supply, because aortic stenosis diastolic pressure will be low, but left ventricular hypertrophy and then the left ventricle compliance will be very low. So left ventricular end diastolic pressure will be high. So his demand will be high and his supply will be less. So they usually present with angina. Angina, dyspnea, and syncopal attacks. These are the triads of aortic stenosis. But aortic stenosis, only aortic stenosis is very rare with rheumatic heart disease. It is always the mitral valve first and then the aortic valve next. It is always the congenital bicuspid valve in younger patients and in older patients aortic sclerosis. That
Sure.
You can exclude definitely, but not history of fever.
Okay, sir. And Dr. Arnab Banerjee was asking, I think this is regarding the induction of anesthesia, sir. Maybe we can answer when we're doing this.
Yeah,
Sir,
that we have got a lot of time is there. Probably
yes,
tomorrow we'll be discussing about the anesthesia part. We will discuss that.
the question
definitely.
was, please explain how to assess safe apnea time. Probably we can do it that time.
Yes,
Is
yes.
there any formula for that? So Arnab, please make sure you ask this tomorrow so sir can answer. One more question was orthopnea mechanism, sir, by Karthik. Dr. Karthik was asking.
Orthopnea.
Yes, sir. Mechanism of.
Yeah, you know that orthopnea can be due to respiratory disease or even cardiac disease. Since we are discussing about the cardiac disease, so any patient who lies down, so the diaphragm will move up. So the compliance of the lung will decrease. In the meantime, there is more amount of fluid shifts towards the pulmonary circulation. Any patient with problem as far as his left heart is concerned, so the pulmonary capillary pressures will increase, hydrostatic pressures will increase. So that can produce definitely more difficulty, because more amount of fluid may enter into the alveoli and interstitial space as far as the patient has got a cardiac disease. And second thing is, if a patient has got a respiratory disease, the diaphragm will move up, the compliance of the lung will come down. So the work of breathing will increase. So once already the patient is having so much of dyspnea, so because of that, he may have to increase his work of dyspnea, work of breathing. And again, cardiac problem also, the PaO2 may come down, the cardiac output may come down because the left ventricular end diastolic pressure may increase. So his work of breathing overall will increase. So whenever he has an increased work of breathing, he'll have dyspnea. So that is what is orthopnea. Once he sits down, or even stands, so the venous return will come down, the diaphragm will move down, he can have a easy excursion of his diaphragm. So his work of breathing will come down.
Sorry, before we go ahead with the next session, sir.
Yeah.
One question by Dr. Suchetan Praminik. Sir, please, can you repeat VO2 max correlating with the flight of stairs? That's what I think you said, sir. 5 flight of stairs.
Yeah, 5 flight of stairs, 20 ml. 5 flights, 20 ml. 3 flights, 15 ml. 2 flights 12 ml, 1 flight 10 ml.
Fine, sir. As of now, only so many. So we have about 300 plus participants, sir.
Okay.
So we can continue, sir.
So
Thank
let them ask, because tomorrow morning what we can do is we can first take up all these questions and then we can proceed.
you. Yes, sir. Sure.
That we
So,
can do.
yes, sir. So students, please leave your questions in the chat box so we can go through that. Arnab, make sure you ask this question tomorrow, please. Thank you. Right, sir.
Okay. Now
Sir, I have one doubt.
let us move forward. Good thing that Azam, we had a slight break for our students.
Yeah, sir.
So,
Sir, one more question. I think Vinod has one question, sir. So
okay.
I think it is required, sir. You've been talking more. So sorry for that.
No. You can always.
Thank you, sir. Vinod, go ahead and ask your question.
Sir, that we have taken history of dyspnea and chest pain and everything, no, sir?
Yeah.
That we have done with the retrospective that patient is IHD. So, like, we can't just, they have given the case like swelling in the umbilicus.
Yes.
We can't go and ask them there is an history, like how it will be. If they have given a case with swelling around the umbilicus,
right.
So we can't ask those all questions. So we have to go retrospective only, you know.
Yeah.
In the history of
No,
presenting
here,
illness.
no, in the history, there is a definite history of the patient having hypertension is there. Already patient is on treatment for hypertension. Hypertension itself can produce end organ damage and can produce dyspnea, and that you are going to assess. The second thing is the patient is already gives you a history of placement of probably a stent. So revascularization procedure, you know that ischemic heart disease patient is there. So then you have to ask. So always, what I suggest is, I don't classify this past history and history of presenting illness at all.
Okay.
So whatever that is relevant to me as anesthesiologist, I'll put all those things in the history of presenting illness.
Okay.
I'll not say past history of hypertension for the past 10 years. Now also patient is having hypertension. Why should I put it into past history? Because it is still there. And patient has had a ischemic heart disease. She is still having ischemic heart disease. And these are very, very relevant to me as far as the anesthetic management is concerned. So all those things I'll try to put it in the history of presenting illness when I'm, presenting to the examiner. So that's very important. For example, now in a respiratory disease patient, smoking history, I don't keep it to the personal history.
Yes.
Or even in ischemic heart disease patient, smoking history is so important. I'll bring it in the history of presenting illness. I don't want the examiner to wait till you are going to present the personal history regarding smoking.
Okay.
And in end-stage liver disease, history of alcohol, again, intake is very, very important. I'll try to include it in history of presenting illness.
Okay.
So that's why when you know that you are going to present it as the history of presenting illness about the hypertension, ischemic heart disease, then definitely you would be asking about dyspnea, isn't it? Which is very, very important.
Yeah, yes. No.
Sir, Dr. Anirudh Patil, sir, can we use Duke's activity status index to assess efforts tolerance even if the patient has no cardiac disease?
No, you can definitely. You can definitely, because what you are going to assess is the amount of reserve the patient has. Suppose if any patient has got more than 10 meds, now you can close your eyes and then give anesthesia. Yes. That is why one of the tests I always tell every patient to be, to undergo is, breath holding test. So whether the patient is posted for is a known case of ischemic heart disease or respiratory disease, or he is in ASA grade 1, I want every student to do a breath holding test and to time the breath holding time and to see whether the patient has got adequate breath holding. So that will give both cardiac reserve and a pulmonary reserve, which is very simple test, and you can definitely gain a lot of knowledge about it.
Yes, sir. Sure.
Yeah.
Thank you, sir.
Okay. Now, another history here is about Azam. We may be taking up slightly more time.
Please, sir. Please, sir.
No problems.
Absolutely no problem, sir.
Because initially you had told me that 3 hours previous day and 3 hours next day. I only said that no, let us have only 1.5 hours, 1.5 hours, because
Yes.
the patience of the listeners will not be beyond 20 minutes. Everybody says, but we are taking so much of time, 1.5 hours.
Yes, sir.
It's okay if we extend a little bit.
Yeah, sir. Yeah, sir. Yeah, sir. No, sir. There are 335 people have joined just to listen to you, and I'm sure they would love to listen to you. Probably another 1 hour extra. No issues.
No problem then.
Please.
We will see how
Yes,
much,
sir.
when I should stop today.
Yes, sir. Whenever
Okay,
you
now,
get tired.
Harish, you have also in this particular slide, you have written that the patient is a known case of hypertension for the past 10 years on treatment, isn't it?
Yes, sir.
So hypertension as such is very important for us, or the end organ damage that is produced by hypertension is important for us?
Both hypertension and end organ damage is very much important.
Now, among that, which is, we have permissive hypertension also. What is permissive hypertension? Just like permissive hyperglycemia.
So any hypertension without any hypertension about BP about 180, systolic 180 and diastolic about 110 without any end organ damage is permissible.
Yeah, isn't it? You still accept the patient if the patient has up to that, because it is still hypertension only.
Yes.
Isn't it? So that is why hypertension by itself, you said that with this blood pressure of 180 systolic and 110 diastolic, you can still accept, provided
the patient doesn't have any end organ damage.
So that is most important. So when a patient has a hypertension, it is very important to know about the end organ damage it has produced. By itself hypertension or by itself hyperglycemia, we are not bothered. It is the end organ damage the diabetes produces or hypertension produces is more important for us. So what are the end organ damage you always think about when a patient has hypertension?
It can be chronic renal
impairment. In order of importance to you as anesthesiologist.
Ischemic heart
Don't
disease.
tell retinopathy first.
Ischemic heart disease.
Retinopathy will be the least important thing for you because it is not going to change your method of management. Isn't it? Okay, yes. Tell me now.
Ischemic heart disease.
One is ischemic heart disease. Then
renal impairment.
No, in the cardiovascular system itself. One is ischemic heart disease. Can the patient develop left ventricular failure because of hypertension?
Yes, sir.
He can develop an acute left ventricular failure or even chronic left ventricular failure.
Yes.
Okay. Hypertension, I told you, is one of the very important causes for atrial fibrillation.
Yes.
So that also, isn't it? So this is few things, and again, the patient can develop a left ventricular hypertrophy. And all the problems of LVH can be there. Okay. Then next organ.
Renal.
Next organ is brain. Isn't it? Heart. Next is brain. Whether the patient has got a stroke, hypertension, can it produce stroke?
Yes, sir.
Isn't it? Cerebrovascular accident is very common. So why should you ask about stroke in a patient who is hypertensive?
So that autoregulation may be set at a higher rate in patients with, and there can be
good. One itself, as you said, that hypertension means the cerebral autoregulatory curve is shifted to which side?
Upper side.
No, it is shifted to either right or left.
Right.
It is shifted to the right, isn't it? So the minimum pressure at which the autoregulation starts, the maximum pressure at which the autoregulation ends gets shifted to the right. That means at higher pressures. So this is very important for us to know in a hypertensive patient, because any decreased pressure than that the lowest mean arterial pressure at which the autoregulation starts can steeply reduce the cerebral blood flow. And the patient may end up intraoperatively with a stroke and he may not recover, isn't it? So that is one very important thing, as you said, that the autoregulatory curve will be shifted to the right. And how long it will take the autoregulatory curve to shift back to its normal position or normotensive position once I start treating the patient?
6 weeks.
Because again, this is important to know, isn't it? Suppose a patient is non-hypertensive but well-controlled hypertension. So you have to ask since how long the patient is on antihypertensive treatment. Once you know that the patient is on an antihypertensive treatment for a particular period and well-controlled, then you know that no problem as far as the autoregulatory curve is concerned. It has been shifted back to its original normotensive position. 3 months.
3 months.
Yeah, it takes about 3 months. So that's why, ideally speaking, if a patient has hypertension, for elective procedures, you may have to treat him and control the hypertension, and better to take after 3 months, because then you know that the cerebral autoregulatory curve has shifted back to normotensive levels. Okay, one thing. Second thing is, if there is, patient gives you a history of stroke.
Whether it is ischemic or
No, hypertensive patient given a history of stroke, and now you have to accept or not to accept for any elective procedure. When should I accept after a history of the stroke, the period, the duration after the attack of stroke?
That's 3 months.
Yeah, minimum
For
idea would
electives.
be 3 months.
3 months.
3 months. Now, what is the problem if I accept earlier? Usually, you should never accept, ideally, for elective procedures within 1 month of stroke. Now, what will be the problem?
Again, they may be in intracranial bleed for shifting of this autoregulation.
So, one more, reinfarction.
Reinfarction.
Cerebral reinfarction is very high if you take up within 1 month of one episode of infarction or stroke. So, second thing is, the blood-brain barrier. So, total disorganization of the blood-brain barrier occurs after an attack of stroke. So, it takes about 3 months for normalization of the blood-brain barrier. So, that is another thing. So, you should always, end organ damage, hypertension, cerebrovascular disease is again important. Next, third organ.
renal system.
Yeah, renal. Nephropathy. Definitely, nephropathy is another very important thing, because end-stage renal disease or chronic kidney disease, one of the causes can be hypertension, and also hypertension can be an effect.
Be due to secondary
Yeah.
to chronic.
No, it can be an effect, or it can be a cause. So you should always inquire about the nephropathy in these patients, and definitely if they have nephropathy, whether you have to grade the nephropathy, and if they have end-stage renal disease, then other problems are there like hemodialysis, the problems associated with all those things you'll have to think about. So that's why the stage renal disease, again, another very important thing. Next, any other system gets involved?
Peripheral vascular.
Yeah, peripheral arterial disease. Is it again, Vinod, is it important to know that whether the patient has got peripheral arterial disease?
Yes.
Yes.
Why, Vinod, why that is important to you?
Thromboembolic events are more in the peripheral vascular.
If the patient is having thrombosis in the peripheral, if the disease in peripheral, they can have invariably in the coronary system as well.
Yeah, coronary, yes. High probability of ischemic heart disease and high probability of even cerebrovascular disease also will be there. That is one thing. Second thing is, you'll have to really check for the peripheral pulses also. So many times, if you get a case of peripheral arterial disease is there, that is the one which becomes very, very important. And also you have to know about, the ankle brachial blood pressure ratios, isn't it? So that also becomes very, very important. So that's why hypertension, peripheral arterial disease is there. Many times they may go together. Okay, so these are, whenever a patient is on hypertension, so these are the things which you have to know about. And another thing there is now very important for our discussion today is the patient also is a known case of ischemic heart disease, and 1 year back she has had a percutaneous transluminal coronary angioplasty. So this is the most important history for today's discussion again. So did you inquire about in details about her IHD and PTCA?
So we didn't heard the question. Pardon, sir.
No, you see, now we have written that no details available.
Yes.
So you should have asked the patient to bring about all the documents pertaining to this particular PTCA.
Yes, sir. We asked, but the patient couldn't get.
Okay, it's very important. Reasons. Did you ask from which hospital the patient has had this PTCA?
Yeah, we asked.
She told
that at least the patient will be telling you.
Yeah, yes.
Now, why it is important to ask about a particular hospital where this particular procedure has been done?
If they have went into the cardiac hospital like Jaideva, so there
Okay.
may be a revascularization done, like stenting can be done. When they went into the normal nursing home, like basic nursing home, there the revascularization not be done.
No, she has already undergone, you say that she has undergone PTCA. Isn't it? You have
Yes.
written that 1 year back post PTCA. So why it's important to know which hospital is, suppose you want to know, you can directly ring that hospital, ring up that hospital, and you can know what had happened, why PTCA was done, whether the patient has an unstable angina or an acute coronary syndrome, the problem like MI, non-ST elevation MI or even ST elevation MI. So how the patient presented. So these things become very, very important, isn't it? So that's why in the exam, because this particular discussion is mainly related to the postgraduates attending the exam. So don't write down there no details available. You should try to extract as much as history as possible. You can always ask, why did you go to that hospital for getting this particular PTCA done, isn't it? So the patient must have had chest pain,
Yes,
isn't it? So you could have gone into details about whether she has had an MI then. For MI only she had gone there, and what happened, how did she present? So those details are very, very important when you are presenting the history in the examination. So because that becomes very important to us as well. Okay, now that means she has undergone a revascularization procedure. So about a year back. So why this revascularization procedure history is important to you as anesthesiologist?
So depending upon what stent they have put, whether it is drug-eluting stent or bare metal
Very
stent,
good.
duration of the surgery matters
Okay.
for elective surgeries.
Okay. Can you just
And,
tell based on what kind of a stents are usually placed?
Nowadays they are placing drug-eluting stents.
Okay.
And the bare
in the
metal
olden days they were placing
bare metal stent.
bare metallic stents, isn't it? So can bare metallic stents also can be placed now also?
Now also,
Is there any indication for bare metallic stents? Can you just name some of the indications for bare metallic stents? Okay, I'll give you a clue. Okay, a patient has a severe ischemic heart disease, and during assessment you have found out that she has ischemic heart disease requiring probably revascularization, and she is for a time-sensitive procedure. Yeah,
So
then definitely you can definitely ask the cardiologist. You can discuss with the cardiologist. A bare metallic stent can be placed wherein you can take up the patient
within
maybe after about
1 month. 1 month.
1 month, 30 days. So that is one of the indications. Suppose you think that the patient, what is the cost of bare metallic stent and the cost of drug-eluting stent?
Cost of drug-eluting stent is very high, sir. If patient
Very
is
high.
not affordable.
Suppose the patient says that she is not able
Not
to
affordable.
So that may be should be an indication, but you never know in India. So maybe an indication. Okay. Now, third thing is the patient, you think that she may not take antiplatelet drug therapy. She may not be compliant after placing the stent for a long time. Chronic antiplatelet therapy is required if a patient is on drug-eluting stent, isn't it? In such patients,
We may.
yeah, because stent thrombosis is can be a fatal complication after putting a stent. That is the reason why these patients can be on antiplatelet therapy. For a bare metallic stent, usually how long they require absolutely the antiplatelet therapy?
4 to 6 weeks.
Yeah, minimum 4 to 6 weeks. So if you think that this patient can take only for about 4 to 6 weeks, afterwards she may not take. So definitely, probably a bare metallic stent may be an ideal thing. And the other thing is, suppose the patient is at a high risk of bleeding problem. Like the patient is already on anticoagulants also. Because anticoagulant therapy plus antiplatelet therapy, again, the patient will be at a high risk of bleeding problems, bleeding complications anytime.
Yes.
So even in such situation also, probably may be an indication of bare metallic stent. So just remember about this. You may be asked in the exam. So what are the indications for bare metallic stenting? So these are the 4 probable indications. So you can always tell in the exam. So you said, Harish, bare metallic stent, what is it made of? Stent has to be placed, before actually they used to do only dilatation of the ischemic area and then leave it. But invariably it used to get blocked again, isn't it? So that is how they wanted to dilate it and place something there so that again it should not get blocked. That is why the stent insertion have started. So bare metallic stent was the initial stents that used to be placed. So what are they made of? Initially what they are made of, and now what they are made of now. Made of stainless steel. Originally they were made of stainless steel. Now they are made of cobalt chromium or platinum chromium. So which are very, very less inert, platinum chromium or cobalt chromium. Okay, now you said about drug-eluting stent. Nowadays, majority of the patient has had an PCI, percutaneous coronary intervention. Invariably, you know that the patient would have been placed with a drug-eluting stent, isn't it? So, what are the implications of patients on with a drug-eluting stent?
So we cannot take them for surgery for minimum of 6 months.
Now, is it still 6 months or reduced further? Suppose the surgery cannot be postponed for that long. Now they say that even after 3 months, we are having second generation, third generation drug-eluting stents. So with that, even after 3 months. But for exam purpose, you always say whatever the answer you said is correct. 6 months you always say. But if the examiner asks, can these patients be taken up even early? Then you say that patients may be on second generation or third generation drug-eluting stents. So then postponement may not be required for more than 3 months. They can still be taken up. Okay. Now, when I say drug-eluting stent, what do you mean by elution? What do you mean by eluting or elution? So why a drug-eluting stent when compared to a metallic, bare metallic stent? How it is advantageous?
Drug-eluting will maintain the patency of the vessels.
Now, how does it maintain when compared to bare metallic stent? What happens? Any foreign body is placed there. Body tries to cover it, isn't it?
Yes.
There is cellular proliferation will occur, and once the cellular proliferation, especially the intimal proliferation occurs, there can be narrowing of again the stent also.
Oh.
That is the problem with bare metallic stent. So intimal proliferation or hyperplasia will occur that can narrow the area, and definitely again the patient can develop ischemia. So drug-eluting stent, elution means gradual and controlled release of a drug. That is called as elution, gradual and controlled release of a drug. Here, drug-eluting stent, the drug that is there along with the metal platform continuously will be releasing, and the controlled release of this particular drug, which prevents neo-intimal hyperplasia. Did you understand? Because there is a continuous release of the drug, so it prevents this neo-intimal hyperplasia, so that that patency of the stent can be maintained for a long time. So that is the advantage of a drug-eluting stent. So what are these second generation and third generation drug-eluting stents? Again, first generation, just better to know about these things. First generation, again, they were using stainless steel. Over that, the drug used to be placed. That as the platform. Now we have cobalt, chromium, or the other better metals are platinum, chromium is being used. Or that the drugs are placed. so that early reabsorption will occur, and you don't require for a long time the patients to be on antiplatelet drugs. That's how in second generation and third generation we have better metal platforms. So that is one. And what is the common drug that is used? Sirolimus. And its derivatives. There are many derivatives that are used. Just remember about these. Suddenly if you're answering very well in the exam, such questions will be asked for you, because the examiner always thinks that you are not going to answer this. But if you answer that question also, then your marks will jump. So just remember about that. Differences between first, second, third generation of drug-eluting stent. What do you mean by drug-eluting stent means, and all these things. Okay, now once the patient is on drug-eluting stent, so the patients invariably, you have also written here that the patients have to be on antiplatelet drugs, isn't it? So usually on dual antiplatelet drugs, especially when the patient is on a drug-eluting stent. The most common dual antiplatelet drugs that are given are aspirin and clopidogrel. So, okay, now this patient is on aspirin and clopidogrel. So again, what are the importance of knowing that this patient is on these antiplatelet drugs? Harish.
If the patient is on clopidogrel, as per ASRA guidelines, if we cannot give Nuraxel blockade for 7 days.
Okay.
And
that is one thing. Yes. Suppose if the patient comes in an emergency situation, so suppose which you could have done under Nuraxel block, you cannot use it. Okay.
So, and the risk of bleeding will be more. So we have to assess whether the risk of bleeding is more or the stent thrombosis is more.
Isn't it? So you have a lot of problems whenever the patient is already on antiplatelet drugs, whether you can stop antiplatelet drugs or you have to continue them. If you continue, what are the problems? Those things are always there, isn't it? And when the patient, I also said that 3 to 6 months, as just now we discussed about drug-eluting stents, ideal would be 6 months. So before 6 months, it's better not to take up the patient for elective procedure. Even after 6 months, if you are taking up whether to stop the drug or to continue the drug, whether to stop both the drugs or stop one drug to continue 2 drugs, all these questions will be there, isn't it? So suppose the patient comes to you with a drug-eluting stent and he is being posted for an elective surgery. Ideally speaking, how long you can postpone?
1 year.
Yeah, ideally 1 year. Why this particular thing?
1 year,
what
after 1 year,
the
risk of stent thrombosis will drastically reduce.
Isn't it? Now it has been reduced to 6 months. Definitely that algorithm is always there. You learn about this algorithm. Patient coming for emergency surgery, there is no way. Yes. So you have to think that yes, this patient is going to bleed a lot and you have to prepare for that, because yes, there is no time for you to stop the drug, isn't it? But history of this patient being on dual antiplatelet therapy becomes very important. So suppose the patient comes after 3 months after dual antiplatelet, drug-eluting stent and posted for an elective procedure which cannot be postponed for long, like I told you, time-sensitive surgeries. Again, you can still take up and think about the bleeding risk and the stent thrombosis risk. After 3 months, usually the stent thrombosis risk will come down. So definitely you can still stop clopidogrel and continue with aspirin, isn't it? So that's how. So, and you may be asked a few things about the pharmacology of these drugs, aspirin and clopidogrel. So, for example, now aspirin. So, how does it produce this antiplatelet activity?
So it inhibits the thromboxane A2.
By what method? It is a cyclooxygenase inhibitor, isn't it?
Yes, COX-1.
Yeah. You just can tell in the exam by COX-1 inhibition, cyclooxygenase 1 inhibition, aspirin is going to act. Okay. So suppose many times you must have heard also when you are answering about a patient with myocardial infarction that is landing up in the casualty or in the emergency department, you are supposed to give him immediately 300 milligrams of aspirin, isn't it? Yes. So you should know when it is going to act. when the maximum antiplatelet effect of aspirin will start after oral aspirin.
After 48 hours.
After 30 minutes.
Yes.
The maximal antiplatelet inhibitory effect starts after just 30 minutes. So again, that's why you should know about, isn't it? Because that is the reason immediately you're going to give the patient, if a patient comes with myocardial ischemia or infarction, to the emergency department. So aspirin is very, very important. So the second thing is, what is its half-life? Half-life of aspirin. No, I don't think you would have thought about all these things, isn't it? You may be asked in the exam. Half-life. Half-life is also 30 minutes. It has got a short half-life. Very short half-life. So, but once aspirin is given, what it does, it is going to produce an antiplatelet activity, isn't it? Is it a reversible antiplatelet effect or irreversible antiplatelet?
Reversible.
Pardon?
Reversible.
No. For all those platelets which are in circulation, it is going to produce an irreversible antiplatelet activity. So that all those platelets cannot have an aggregatory property at all. So irreversible antiplatelet effect will be there. One single dose of aspirin. Okay, so this is again very important. So see, suppose I stop aspirin today. So every day, how much of regeneration of or new platelets will regenerate? Because this single aspirin dose, as long as those platelets are alive, they are inhibited. So what is the life of a platelet?
7 days.
7 to 10 days.
Okay.
7 to 10 days. That means for 7 to 10 days, one dose of aspirin is going to produce an antiplatelet activity of those platelets in circulation on that day. So every day, if I'm giving, so every day they have all those new platelets. Every day we are going to have generation of new platelets, isn't it? So they are going to have this blocking of their activity. So suppose I stop today. So for tomorrow, what is the percentage of platelets that new platelets will generate? Again, whether it is aspirin or clopidogrel, the answer is same. That's why I was asking. Now, regeneration is about 10%. Sometimes you may be asked, so aspirin has got a short half-life, why should I stop 5 to 7 days? Isn't it? So at least you have to have a sufficient, active platelets available for producing hemostasis during surgery. So suppose if I stop today, every day 10%, so 5 days 50%. So okay, more than 50% activity is more than sufficient for good hemostasis. Same thing with clopidogrel also. So that you should always remember. Sometimes you may be asked, why should I stop, so early, at least 5 days before clopidogrel? So let me ask you about clopidogrel also. What is when the maximum antiplatelet effect of clopidogrel will start? After oral, clopidogrel is always given oral. So it starts after 6 hours. After 6 hours. And because almost every patient with ischemic heart disease will be on these drugs. So it is better as an anesthesiologist, you know about this. Whether it produces a reversible or irreversible antiplatelet effect.
Irreversible.
Yeah, again, clopidogrel also, just like aspirin, produces irreversible. So that platelets which are in circulation, they will not be effective at all. Okay. Then what is the half-life? Half-life of aspirin, I said 30 minutes. Half-life of clopidogrel. The same 6 hours. Maximum effect occurs after 6 hours. The half-life is also 6 hours. So, but all those platelets will be definitely inactivated by clopidogrel. Okay. So that is the reason why you take about 5 days minimum because 50% of the new platelets would be in circulation. Don't think that the clopidogrel will be acting for 5 days.
Yeah.
It doesn't have a prolonged half-life. The effect goes off after 6 hours. Half-life, it won't go off after 6 hours. Half-life is 6 hours. Of course, 2 to 3 half-lives are very important for us to see that the effective concentration is decreased in the blood. So even then, it is about maximum about 18 to 24 hours, isn't it? If you even think about 3 to 4 half-lives. But we are going to stop at least 5 days before. So why 5 days before? Is because this 10% of regeneration of platelets every day. So minimum at least about 50%. If you have, you are very happy to manage the patient. You can even go for your central uraxial block. Okay, so that is another very important thing about these platelets. So sometimes you may be asked, if you are stopping these, should you give any parenteral antiplatelet drugs?
No, not treatments.
Usually nowadays, not required. And do you know any, these, can you name some drugs?
Low molecular weight heparin.
No, that is not an antiplatelet drug, it's an anticoagulant. So you should always remember about these things, which is an anticoagulant and which is an antiplatelet drugs.
Ticagrelor.
So you must have known about glycoprotein,
2B,
P3A.
3A,
So some of them, of course,
Ticagrelor, Prosip.
just you know, it is okay if you can remember about this.
okay.
So that is very important. So another thing about this is, patient is also on other drugs, isn't it? The patient is on drugs like your slide is showing me, other than antiplatelet drugs, patient is on amlodipine.
Yes.
Can you just talk about this particular amlodipine? What sort of a drug is it? And its anesthetic importance.
It's a calcium channel blocker, sir.
Okay. What kind of a calcium channel blocker? Fast calcium channel blocker, slow calcium channel blocker?
So intermittent acting.
No. I'm not asking whether it is long acting, intermittent acting, or short acting. So, which channel? Slow calcium channels?
Slow calcium.
The slow calcium channel blocker, because in the heart, also in many of the smooth muscles, you have a slow calcium channel. So in skeletal muscles, nerve ending, you have a fast calcium. So it's usually a slow calcium channel blocker. So what is its anesthetic importance? Should I continue on the day of surgery, or should I stop it before surgery?
We should continue on the day of surgery.
Yeah, you should continue, because the patient is being given for hypertension control. You continue. So suppose I continue the drug on the day of surgery. Any problems?
It may cause hypotension during.
Why? With what drugs it can produce hypotension?
Induction agents like Propofol.
With inducing agents.
IV induction agents. What about inhalation induction agents?
Yes.
It can also produce. One thing you should always remember is both inhalation induction agents and IV induction agents, they have an effect on calcium movement across the cells and also in the cells.
Okay.
Calcium has to be released from sarcoplasmic reticulum.
Yes.
So they inhibit that. So that's how, the troponin cannot act on the actin filaments. So, actin cannot act on the myosin filaments and produce contractility. So because the calcium metabolism is very, very important there, again, both IV anesthetic agents, again, transportation of calcium into the cell is prevented by inhalation anesthetic agents. So again, if the patient is already on a calcium channel blocker, so exaggeration of effect of these with the anesthetic agents can occur. So exaggerated hypotension can occur. Okay, one. Any problem on neuromuscular junction and are non-depolarizing muscle relaxants?
It can prolong the duration of.
Why? How?
By blocking the calcium channel at the neuromuscular. By
which part of neuromuscular junction? Presynaptic. Presynaptic. Why calcium is important to move inside the presynaptic nerve ending?
Once calcium is entered, it increases the potential at the presynaptic and causes the release of neurotransmitters.
acetylcholine, isn't it? It releases acetylcholine because the entry of calcium, it induces release of acetylcholine. So that is important. Though they are fast calcium channels, but you know that these may not be highly selective. So there can be a problem. So that is the reason that also you have to know about, and better to monitor these patients if you have a neuromuscular junction monitor. So that's about the calcium channel blockers. So regarding the beta blockers, Dr. Azam, can we continue tomorrow or?
Sir, if you're tired,
already we have spent 1 hour 50 minutes.
If you're, I'll leave it to you, sir, because I don't want you to be straining yourself.
Now, another 10 minutes regarding beta blockers, then we can stop today and we can discuss tomorrow morning.
Yes, sir. After that, there are a few questions we can discuss. Sure, sir.
Okay.
Please continue.
So, Vinod, how about patient is also on metoprolol?
Yes, sir. Metoprolol is an selective beta block.
Yeah, is it highly selective or just selective?
Highly selective.
Is it highly selective?
Yes.
Can you name some highly selective beta blockers?
Atenolol.
Bisoprolol.
Atenolol.
Bisoprolol. So bisoprolol, atenolol, of course, also, but bisoprolol is highly selective. Metoprolol may not be highly selective. In higher doses, it may also block the beta 2 receptors. We want it to block only beta 1 receptors. We don't want to block the beta 2 receptors. So what happens if there is a beta 2 receptor blockade also? Like propranolol is non-selective. It blocks both beta 1 and beta 2.
Profound hypotension can be.
No, blocking beta 2 will produce hypotension.
In Broca's constriction.
So beta 2 agonism will produce in the peripheral vessels vasodilatation or vasoconstriction. Beta 2 agonism. Because beta 1 receptors are mainly present in the heart and then kidneys and pancreas and also eyes, whereas all other places beta 2 receptors are there, especially the peripheral arterioles. So stimulation of beta 2 will produce arteriolar dilatation.
Yes.
There is always, equilibrium between alpha stimulation and beta 2 stimulation in the peripheral vessels. Because of that, the vessels will remain dilated because of the beta 2 effect. Suppose if the beta 2 effect is taken off, alpha 2 effect becomes predominant, vasoconstriction can occur. We don't want this, isn't it? In a patient with, we don't want to increase the systemic vascular resistance in a patient with ischemic heart disease. So that is why highly selective beta blocker is ideal. So whenever you talk about beta blockers, again, whether it should be, continue on the day of surgery or should we stop on the day of surgery? What is the guidelines?
We should continue on this.
Yeah, continue on the day of surgery. Suppose, why should I continue? What happens if I stop it early, 2-3 days before?
There can be rebound hypertension, tachycardia, which may be detrimental.
Yeah, very good. So why rebound hypertension, tachycardia can occur with metoprolol or beta blockers?
As alpha 2.
So why beta blockers suddenly should not be stopped? Have you heard about upregulation of receptors?
Receptor, beta 2 receptor.
So there will be beta 1 and beta 2 receptor upregulation will be there, especially beta 1. So suddenly if you stop, the same amount of catecholamines will have an increased amount of effect, isn't it? So that is the reason suddenly the patient can develop increased myocardial contractility, increased heart rate. Suddenly the patient can end up with a myocardial ischemia or infarction. So that is the reason you should never stop it before surgery. You should always continue on the day of surgery. So that is one important thing. So again, beta blockade is very important during surgery, isn't it? Because surgery is a stressful thing. And many times when the patient is in lighter planes, the patient can develop tachycardia and catecholamine surge can occur. This can increase the demand, decrease the supply. And chances of intraoperative myocardial ischemia is very high. So beta blockers definitely have got a very good role. So that is why if the patient is on a beta blocker, you always continue, do not stop on the day of surgery. So I said there are so many advantages of beta blockers. Can I start beta blockers on the day of surgery if the patient is not on beta
Not much benefit. No much beneficial.
We should be started earlier.
Yeah.
No, everybody knows that it has to be started earlier. The guideline also says minimum 24 hours, ideal would be 1 week. So why this? Why if I start? Because we should always think about the PICE 1 trial, EOISE, isn't it? So this was started in 2004 and ended in 2008. And we got all the conclusion inferences of PICE 1 trial. That is, what is PICE trial?
They used high doses of.
So what is this? PICE means
Preoperative
Preoperative.
ischemic evaluation.
Preoperative
Ischemic
evaluation
trial.
Perioperative ischemic evaluation trial, very important trial. So where how much of metoprolol was used on the? They started on the day of surgery, not before.
300 mg of metoprolol.
Yeah, 300 milligrams. So preoperatively, the pre-medication 100 milligrams, intraoperative 100 milligrams, and immediate post-operative 100 milligrams. So per day 300 milligrams. And afterwards, how long it was continued?
For 30 days.
30 days.
Yeah, for 30 days, high dose of metoprolol was continued. I said that metoprolol is not highly selective. So with this high dose, what the inference with this? What happened to the MACE, incidence of MACE?
MACE decreased, but they had more incidences of stroke and hypotension.
Yes, major adverse cardiac events, definitely incidence came down, but incidence of stroke and mortality increased in 30 days. Why stroke in these patients?
Secondary to hypotension caused by metoprolol.
Is it only hypotension? I told you they are not selective. So beta 2 receptor also there in the brain. Suppose if you block the beta 2 receptors, the alpha receptor activity will increase. So what will happen to the cerebral vasculature?
Vasoconstriction.
Yeah, vasoconstriction occurs. There are certain watershed areas where there is hardly any anastomosis is there. It entirely depends on the blood pressure and blood flow. Suddenly vasoconstriction is occurring. Those are the areas which can go for ischemia and the strokes can occur. So that is the reason it has been said that if you want to put the patient on beta blockers, don't start on the day of surgery. You always start at least 1 week before ideal. So why not within 24 hours I should start? I should not start. Why at least more than 24 hours? Ideal would be 1 week. Why not? Okay, let me start about 10 hours before, 18 hours before. So this question can be definitely asked to you. Because I still remember why I asked this particular question to you is because one of the Kerala students who regularly keep on messaging me every day so many questions, she also messaged this question also. Sir, why beta blockers should be started at least 1 week before the ischemic heart disease? One thing you should realize, beta blockers have to be titrated. You can't give suddenly a high dose of beta blocker. That's what happened in PICE trial. You have to start with the minimal dose, titrate it in such a way that you are keeping the heart rate between 60 to 70 beats per minute, and the mean arterial pressure is always kept up more than 65 to 70 millimeters of mercury. Because you only said that beta blocker suddenly, if it is given, they can produce hypotension. So you have to start titrating because individual variations are so much. I may react in a different way. You may react in a different way. So that is the why the beta blockers have to be really, dose have to be titrated. Start with the lower dose, titrate. That is why ideal would be 1 week is very important. So that is why you have to start earlier. So what are the indications for beta blocker? Suppose I want to put this patient on beta blocker. He is not on beta blocker. At least 1 week before I want to start him titrate. So there are a lot of advantages because perioperative myocardial ischemia and MACE can definitely decrease. So what are the indications?
So it gives time for diastolic filling.
No. What are the indications for starting? I'm not asking how it is going to help. Suppose the patient is posted for a high-risk vascular surgery. So if the patient is not on beta blocker, he should be started at least 1 week before titrated. This is one indication. Okay. The second indication is, that RCRI, revised cardiac risk indices. If the patient has more than 2 or 3 risk indices is positive clinical risk indices. So you may have to put the patient on because he's at high likely that he is at high incidence of developing MACE, isn't it? So this is the second indication for beta blocker therapy. The third indication is suppose because of his the problem whatever he has, the severe ischemic heart disease or anything, as such he required beta blockade therapy even later, then also you can start as well. Better to start at least 1 week preoperatively, and it is also will be effective for us during the perioperative period. So these are some of the indications for beta blocker therapy, preoperative. Okay, so let us stop at this. So if there are any queries, we will just answer, and or we can answer even tomorrow if you think that the students are getting bored.
Yes, sir. Actually, we have increased the numbers to 400, sir, as of
Oh
now.
my God. Okay,
Yeah.
okay. Then we can just clear these doubts, and then we can go for tomorrow.
Yeah.
Yes.
I think very simple, sir. I think for you it should not take more than long time. Where we had left last was 1 minute, sir. Right of
So
state.
that we will answer tomorrow. That perioperative queries. So whatever till now, whatever we have discussed, we will answer.
Yes, sir. So, okay. I think we answered this, right? The Duke's activity in non-cardiac, we said yes.
Okay.
Then Suchetan Parmenik. Sir, importance of drug-eluting stents used for coronary stenting.
No, already it has been known. You see that stent thrombosis is prevented, and
Yes.
with bare metallic stents, their life is very short, and there can be blocking. So that is why drug-eluting stents, so that preventing intimal hyperplasia.
Yes, sir. And Dr. Darshini Murthy, sir, history of bleeding varices is a contraindication for drug-eluting stent.
Actually, it is not a contraindication as such. It depends on the benefits of the drug-eluting stent and the risk of bleeding. Because if a patient definitely has a more major life-threatening ischemic heart disease, definitely I would place the drug-eluting stent in such patients.
Dr. Karthik, you will get the link for the video for both the sessions today and tomorrow, so no problems. Dr. Arnab Banerjee, so why long time antiplatelets for drug-eluting stents and short for bare metal stents, sir?
So that already I have discussed.
Yes,
That the neovascularization or intimal hyperplasia occurs faster if you don't have any drug elution there. So that is the reason for bare metallic stents, rapid neovascularization occurs. There is no point in just giving antiplatelet drugs there.
Yes, sir. Sir, can you please repeat permissive hypertension because I was not able to hear you clearly.
Permissive because anything above 139 or of systolic, anything above 89 of diastolic, we call it as hypertension. So, but during any perioperative period, even if the patient, the guideline says that up to 180 systolic and up to 110 diastolic, we can still accept these patients for surgery, provided they don't have end organ damage, which has not been controlled or optimized. So if the patient doesn't have any end organ damage on the day of surgery, he has 180 systolic or 110 diastolic, you can still accept because they are still hypertensive and you are permitting that amount of increase in pressures. That's why you call it as a permissive hypertension, and you can still take up because Chris Roberts has done a lot of studies on. He's the one who has said that okay, up to 180 and up to 110 patients you can still take up, because what has been found is the number of patients developing intraoperative and postoperative MACE is the same whether the patient was in normotension or up to 180, 110 blood pressures. So perioperative complications were almost similar. So that's why, depending on whether the patient, you cannot postpone the surgery. Suppose, let us say, the surgeon says, no, I have to take up. So you have permission to take up to 180 and up to 110. That's why we call it as permissive hypertension, because like permissive hyperglycemia,
Yes.
up to 180 blood sugars, you are still, it is fasting blood sugar is too high if you are telling about 180, but still we accept.
Yes, sir. And it's not anymore 160, 110, no, sir. It is 180 by 110.
No, it is 180, 110. That is what in latest Miller also he gives.
Yes, sir. Muthu Kumar Rajgopalan, I think this you answered, sir. Nowadays, RSI guideline says there is no need to stop aspirin for regional anesthesia. Yes. Any specific dose, sir, where we have to stop aspirin? Because 150 we go ahead and give regionals.
Huh.
So up to
So
150.
usually if it is above 300, because usually for these, the starting dose is always 300 milligrams.
Yes, sir.
So that is a loading dose. And afterwards, we usually go for 75 to 150 milligrams, maintenance dose.
Maintenance.
So loading dose is only a single dose of 300 milligrams, subsequently 75 to 150. So as long as the patient has less than 150, you can still allow to go for central venous flow.
Yes, sir.
No problem.
Dr. Arnab Banerjee, please repeat the drugs for second and third generation drug-eluting stents, sir.
So there are I don't think you do require, because there are so many drugs. All are probably the same drug which was used originally and some modifications. So you don't require to know, and even if the pronunciation itself is so difficult.
Yes, sir. Erunaka Mani, sir, can you please give clear guidelines of when to stop antiplatelets and heparins? I think you have told it very clearly, sir.
Yes.
A word about heparin, sir.
Heparin, we will come to that once we discuss about anticoagulant therapy.
Yes, sir. Yes, sir.
Preoperative management preparation tomorrow.
Yes,
so
sir.
we'll discuss. Just remember about anticoagulants, and we will discuss tomorrow.
Yes, sir. And sir, can you repeat the upregulation of beta receptors? You said we should, I think this was regarding why we should
not stop.
Not stop, yes, sir.
Yeah, because any drug, when it is given to suppress the receptors, body will not keep quiet. It tries to increase the number of receptors so that the effect can be there, the original effect can be there. So that is what occurs here. It's like, you must have heard about lower motor neuron palsy, upper motor neuron palsy. You have upregulation, denervation, supersensitivity occurs. There is so many receptors, extrajunctional receptors are formed. Like that, when patient is being given beta blockers, it is going to suppress the beta 1 receptors, and if it is a non-selective, it is also going to suppress the beta 2 receptors. So body tries to increase the number of receptors, and this is called as upregulation. So when you keep giving agonists, there can be downregulation also. The opposite also can occur if you keep giving agonistic drug on a receptor. Both are possibilities. So when you keep giving an antagonist, so there are more number of receptors are formed. So suddenly you withdraw the drug, like even clonidine, the same thing occurs. So suddenly if you withdraw the drug, the circulating catecholamines will remain same, but they can act on more number of receptors. The effect suddenly can be pronounced. So this is what occurs. And the same thing with antiplatelet drugs also.
Okay.
Suddenly the new platelets, they have an increased amount of activity.
Oh.
When the patient is on a prolonged antiplatelet drugs, and suddenly if you stop, these are the patients likely to develop thrombosis and thromboembolic phenomena. That is why you continue aspirin. You don't stop aspirin, even though you can stop clopidogrel, because the new platelets that are generated, body, it's a fantastic machine.
True.
So it doesn't keep quiet. So it increases the activity of these platelets. So thrombogenicity will be very high. That's how you can always ask, why should I continue aspirin? Why I should have stopped that also, isn't it?
Correct.
So it may not, the stent thrombosis will be very high if you stop both the drugs.
Sure. Dr. Ernaka Mani, I think sir has told that we'll discuss about the coagulation. So there was a question saying, sir, please give clear guidelines on to stop antiplatelets and anticoagulants before.
No, tomorrow we'll discuss, definitely.
Tomorrow we'll discuss. And sir, same thing, sir. And another two questions can I take, sir? 2 or 3?
Yeah. We'll just take 2 questions.
Yes, sir.
8, 10 already.
Yes, sir. Shailaja, sir, request you to conduct more classes like this. It benefits everyone. So.
No, it all depends on Dr. Azam and Medinet.
I will, sir. I will, sir. Sure, sir.
Okay, okay. If
Yes,
people
sir.
want, definitely I don't
No,
mind.
sir. There are, you believe me or not, sir, I will forward you if you don't believe me. There are about 75 messages to 80 messages which saying, please request sir to conduct more classes. So,
Sure. No problem.
sure, sir. Any effects of, sir, this is a good question from Sri Somya Balaji. Any effects of anesthesia on drugs on stents?
Anesthetic drugs do not have usually, surgery can have.
Yes, sir.
Because surgery has got a prothrombotic effect. And that is the reason why you have to continue antiplatelet drugs on the day of surgery, especially aspirin. Don't stop. Because any surgery has got a procoagulant effect and stent thrombosis can occur. That is the reason why we don't stop these drugs till at least about 3 to 6 months before surgery.
Dr. Arnab and Dr. Saida Sana has same question, sir. What is MACE?
MACE is major adverse cardiac event. Like, the patient can have a cardiac arrest, can have myocardial ischemia, myocardial infarction, pulmonary edema, or even silent infarction. All these are MACE, or even malignant dysrhythmias like atrial fibrillation, ventricular tachycardia, ventricular fibrillation. All these are called as major adverse cardiac events.
And the other question from Dr. Gandhi Shanmugam Velu, sir, importance of ankle brachial index.
Yeah, ankle brachial index to know atherosclerosis and peripheral arterial disease. Yes. So normally ankle brachial ratio should be 1, because whatever the pressure when the patient is lying down, whatever the pressure in the upper limb, the brachial should be same in the ankle. That is in the dorsal pedis artery. Suppose if the ratio, then if it is same, the ratio is 1, isn't it?
Yes.
So,
sir.
but we are recording the pressure in the dorsal pedis by using a Doppler, and you are using the regular non-invasive, NIBP monitoring of the upper limb. So, and you take the ratio ankle blood pressure to brachial blood pressure. Suppose if it is less than 1, you know that the patient has got peripheral arterial disease and atherosclerosis. Because the atherosclerosis and peripheral arterial disease starts usually in the lower limbs and later the upper half of the body. So that's how ankle brachial ratio may be important.
Yes. So this finishes
0.9 and below is very significant ratio.
Sure, sir. Dr. Prasanjit Padwal, yes, these videos will be available to you and it will be circulated to all over. And sir, the total number of count we, Jordan was saying that 434. So this tells you the popularity that you have, sir. And thanks from bottom of my heart for conducting this, because it goes, it means a lot to a student and it goes long way, sir. Thank you so much once again.
If it is going to help the student, I don't mind taking any stream.
It will, sir. It will, sir. I'm sure Vinod and Harish have to say something. Please go ahead. Because
they are the ones who are going to be benefited, if at all, with this class.
Yes, sir.
Thank you so much, sir, for giving valuable time.
I really appreciate, sir, because your time is more important than ours. And thinking for students and doing so much, I really appreciate. So tomorrow we can start by 10 o'clock.
Tomorrow again 9 o'clock. 9, I think.
1 minute, sir. I think it is not 9, sir.
10 to 11:30.
11 o'clock.
10 to 11:30.
Yeah.
10 o'clock, right?
10 o'clock, right?
Okay.
1 minute, sir. 1 minute, sir. Let me.
I just check. I also have not checked.
1 minute, sir.
Oh, yes, doctor. It's 10
It's
a.m.
10 a.m. to 11:30.
Yes.
10 to 11:30. Okay.
So
tomorrow we'll meet at 10.
Yes, sir. So thank you so much, sir.
Thank you so much.
For all
Thank
the
you.
classes.
Thank you, Azam. Good night. Good night for both Vinod and Harish.
Thanks, Vinod, Harish.
Good night.
Thanks,
We'll
Jordan.
meet again tomorrow. Right.
Thank you, doctor. Yes.
Thank you.
All right.
Maybe tomorrow 10 o'clock we can join. Yeah. Good morning again. Welcome back for the part 2 continuation of ischemic heart disease. And at the outset, again, I would like to welcome Dr. Gurudatt sir, professor and head of the department, JSS Medical College. Thank you once again, sir, for all the pains that you have taken to thank you, sir. Thank you so much. Harish and Vinod, thank you so much for your presentations. And we had a discussion, and yeah, not to forget Mansa, Mahesh, and Medinit for helping at the back end for ensuring the whole program goes very smoothly. So thanks, Mansa and Mahesh. And yesterday we had started part one discussion. It was about 2 hours, 20 minutes discussion that we had. Fantastic discussion by sir. Thank you once again, sir. So with that, we will continue and over to Vinod and Harish and sir. Thank you so much, sir.
Thank you, Dr. Azam, and thank you, Medinit, for this opportunity. Yesterday, we had a very healthy discussion with Dr. Vinod and Dr. Harish. They were so active, and majority of the questions they could answer, and also that's how it was a very, very healthy discussions we had. I hope today also we can continue to have the same type of discussion. So I request Dr. Vinod and Harish to upload and then share their screen for the case presentation. Yesterday, till the patient was on a particular few of the drugs. So till then we were discussing actually. So we had discussed just the beta blockers and what to do when the patient is on a beta blocker. Should we continue on the day of surgery or should we stop? Or whether if the patient is not on beta blocker, should we start? And if we have to start, when we have to start. So, and you see if the patient is on beta blockers, if we continue on the day of surgery, what problems we expect, especially the drug interactions between the inhalation anesthetic agents, IV anesthetic agents. Definitely there can be quite a bit of bradycardia and also hypotension, especially beta blockers and succinylcholine. So for exam purpose, this is another very important thing because we know that succinylcholine is 2 molecules of acetylcholine. So by itself, it can produce bradycardia, but usually what we have seen with succinylcholine is the second dose of succinylcholine invariably will produce bradycardia. And if a patient is already on a beta blocker, which also has got a negative chronotropic effect, and also we are going to give a second dose of succinylcholine, you have to be extremely careful. Probably you may have to give additional dose of atropine, and then only you can definitely go for second dose of succinylcholine. So those are some of the important things regarding the patient on beta blockers and anesthesia. So now coming back to the other drugs. Yesterday also we had discussed in detail about aspirin. We had discussed about clopidogrel also we had discussed. So this patient has stopped clopidogrel 7 days back. Ideally, even 5 days back is enough. And aspirin, we continue aspirin in these patients because the patient is having probably a regulating stent. And yesterday I was discussing when you suddenly stop these antiplatelet drugs, so there is an increased chance of stent thrombosis even after say 6 months or 1 year. So it is always better to continue one of the drugs, aspirin. And we know that as long as the patient is on aspirin up to 150 milligrams, the chances of epidural hematoma or any other problem will be very minimal, and we can safely go for central blocks in spite of the patient is an aspirin. So only thing is, if you think that after 1 year, if the patient is on aspirin and the chances of the surgery which is going to have very severe bleeding, then you can think about even stopping aspirin also, because then we'll have to think about the chances of stent thrombosis and the bleeding. So if the bleeding problem is more, if you think, then better to stop aspirin also. Suppose if the patient is on aspirin for some other thing, like he has not been put on a drug-eluting stent or any other stents, no revascularization has been done. So, but still many of these patients, if they have a TIA or if they have even a cardiac ischemic heart disease, many of them are put on aspirin. Then definitely you can take a chance. Suppose if aspirin has been given for prophylaxis of myocardial infarction, so in most of the surgeries you can stop. There is no absolute indication to continue. But if aspirin has been given for secondary prophylaxis, like a patient has already had a myocardial infarction and he is being put on aspirin, or if the patient has been put on a drug-eluting stent and is on aspirin, so better to continue aspirin. So only thing is in closed cavity surgeries, like spine surgeries, like intracranial surgeries. So then you'll have to think about the risks and benefits of continuing aspirin. Otherwise, you can continue aspirin safely. That's about that. So the other common drugs, though this patient is not on these drugs, or we should also discuss about nitrates, because many of these ischemic heart disease patients will be on nitrates. So Harish, can you just tell what is the advantage of using nitrates in patients with ischemic heart disease? How effective it will be to prevent the problems of ischemia and angina?
So nitrates will cause vasodilatation, especially the venodilatation,
Yes.
and also coronary vasodilatation. So that will help in increasing the coronary perfusion pressure and to some extent decrease in preload to the heart.
No, the therapeutic dose of nitrates, what we usually give either oral or even intravenous, therapeutic dose, I mean, it will produce mainly the venodilatation, it may not produce in arterial dilatation. So may not have much effect on the coronary vasodilatation as such, because coronary arterioles may not dilate much, but it is the preload that is decreased, because a venodilator, because the decrease in preload, left ventricular end-diastolic pressure decreases. So we already know that left ventricular end-diastolic pressure is important for both demand and supply. Supply is very important because of diastolic pressure minus left ventricular end-diastolic pressure is the coronary perfusion pressure. Because it's not going to produce arterial dilatation, it is not going to decrease diastolic pressure in therapeutic doses. It is going to decrease the left ventricular end-diastolic pressure. So the coronary perfusion pressure will increase. So this is what you have to talk about in the exam also, how nitrates are going to help these patients. Okay, so that's how many times, acute angina, as the patient has, yesterday we were discussing stable angina. So the patient takes a sublingual nitrate, so immediately the patient will get relief. That is mainly by decreasing the left ventricular end-diastolic volume and pressure. So that is very important. So suppose if the patient is on nitrates, so should we continue nitrates on the day of surgery or do we stop it?
We should continue.
Yeah, there is no contraindication in continuing nitrates. So, but if the patient is on nitrates, again, the chances of interaction with our inhalation anesthetic agents and IV anesthetic agents, and the chances of more exaggerated hypotension is always there. So that you have to keep it in mind. That is one thing. The second thing is, whenever a patient is on nitrates, because it is going to reduce the preload, what is very important here is orthostatic hypotension is a problem. So that when you are checking with the blood pressure, you have to check whether there is significant orthostatic hypotension is there or not. So why should you check for orthostatic hypotension if the patient is on drugs like beta blockers, nitrates, calcium channel, peripherally acting calcium channel blockers, centrally acting drugs like clonidine? Why orthostatic hypotension and even diuretics especially? It's very important for us to check. Anyway, we'll be discussing that when you talk about blood pressure. Yes, now we are talking about nitrates. You can just answer that. Why should you check? This is very important. Lying down blood pressure, standing blood pressure, systolic blood pressure fall by more than 30 millimeters, diastolic blood pressure fall by more than 10 millimeters. Again, very important. Why, Vinod?
Because of pooling of the blood in the legs. So there will be
that is
again
okay. I'm not
decrease
asking you what is the role, mechanism of orthostatic hypotension. I'm asking, suppose if orthostatic hypotension is there, what is this anesthetic relevance?
So there may be decrease, diastolic pressure will decrease much. So coronary perfusion will be reduced because of diastolic pressure.
No, these are the patients who will have exaggerated hypotension and they cannot tolerate any change in posture. So especially, for example, a patient is posted for, let us say, laparoscopic cholecystectomy. So you're going to have the patient in head-up position. So when you put this patient in head-up position, they may not tolerate. Or a neurosurgery patient or a thyroid surgery patient, where you're going to put them on head-up position, suddenly there can be very severe and refractory hypotension. So you have to keep that in mind, and volume status have to be improved in these patients before putting these patients into any head-up position. And also, that gradually you have to improve the positioning. So it should be very gradual to attain whatever the final position, so that the body, you give sufficient time for the body to adjust for this change in position. And again, these are the patients who are extremely liable to develop hypotension after your central axial blocks. So that is why drugs like these beta blockers, calcium channel blockers, clonidine, centrally acting alpha 2 agonist, nitrates, you have to be very careful about the volume status and also about the central axial blocks. Okay, so that is one thing about nitrates. So the other drugs these patients can be on are statins.
Yes.
So this patient, I don't know whether she is on statin or not, but what you have presenting is that she is not on statin as such. But statins are majority of the times are the most common drugs that are used in patients with ischemic heart disease. So what are basically the statins?
Anti-lipid drugs.
Yeah, they are lipid lowering drugs, isn't it? Atorvastatin is one of the most commonly used drugs. It has got a long half-life. So that is the most commonly used drug. So what are the other advantages of these statins in patients with ischemic heart disease?
It reduces the chances of getting atherosclerosis because of reducing lipids.
So that is, that is why a lipid lowering drug statins were actually introduced and started. But afterwards, they finally found out that they also have other beneficial effects.
Plaque stabilization is.
Yeah, that is the most important part of this. They have an anti-inflammatory effect, and also they have now plaque stabilization. Atheromatous plaque stabilization is one of the most important thing. We know that the type 1 myocardial infarction, non-surgical patients developing myocardial infarction is because of the type 1, majority of the times because of the plaque suddenly gets destabilized. It gets out of the area where it is there and then comes and blocks a healthy vessel, and suddenly the patient can develop a myocardial infarction, isn't it? So the stabilization of the plaque is very, very important in these unstable atheromatous plaques. So that is what is by statins. So statins are the mainstay, but if the patient is, when you start the patient on statin, what are the problems you expect for the patients?
There can be increased incidence of type 2 diabetes mellitus.
Yeah, hyperglycemia is one problem in patients who are prone for it, already having insulin resistance. So you have to check for the blood sugars. What else? It can produce for us, what is more important is it can produce severe myopathies. So, myopathies and succinylcholine, isn't it? In patients who have got myopathies, if you use succinylcholine, there is rare chances of rhabdomyolysis. Rare chances of rhabdomyolysis, and the patient can suddenly have hyperkalemia and all the problems associated. So suppose if you want to start statin, so when it should be started ideally?
1 week prior to the.
No, it should be started 2 weeks prior. So unlike beta blockers, we said at least 1 week, because you have to titrate the dose and then you have to stabilize the patient on beta blockers. But whereas statins, you have to go for at least 2 weeks, because the myopathies and anesthesia. That's what one thing I said. And it takes again the anti-inflammatory effect to be effective. It takes about 2 weeks. So for stabilization of the plaque. So in 2 weeks, it may not produce so much of decrease in lipids, but most important for us in these patients who are subjected for surgery, who are subjected for real stress, and again, the hyperinflammatory state that is produced because of the surgeries. So then, there can be a chance of this stabilization, the destabilization of the plaque, and type 1 myocardial infarction can also occur. So that's how 2 weeks prior, it also should be, ideally should be started. So especially for vascular surgeries, even if the patient is not on statin, usually now the guideline says that you should start them on statins at least 2 weeks prior. Okay, so one more drug these patients can be on, especially the patient also has some left ventricular functioning, poor left ventricular function. So these patients can be on AC inhibitors or ARBs, and also can be on diuretics, isn't it? So, okay, now Harish, if the patient is on AC inhibitors or ARBs, so what are the anesthetic implications?
They can have profound hypotension.
So first of all, should we do any investigations if the patient is on AC inhibitors or ARBs?
The serum electrolyte we should monitor, so they can have hyperkalemia.
So, okay, why hyperkalemia with AC inhibitors and ARBs? Why it should produce hyperkalemia? Why other antihypertensives do not produce hyperkalemia?
It acts on aldosterone.
Very good.
Sir,
Very good.
so there will be potassium. Potassium efflux is less, and it
So
will
what
stay.
happens to aldosterone? Is inhibited or stimulated?
Aldosterone is inhibited.
Yeah, aldosterone effect is inhibited. So aldosterone mainly, increases the potassium excretion and retains sodium. So now the reverse occurs. Sodium is excreted more with AC inhibitors. Potassium is retained by the kidney. So these patients can develop hyperkalemia. So any patient who is on AC inhibitors, so you should always check for potassium prior to the surgery. That is okay. Now you are telling that they may produce exaggerated hypotension, and which can be sometimes refractory also. Now the thing is, should we continue on the day of surgery? Should we withhold? Because there is a lot of controversy regarding AC inhibitors and ARBs to be continued or not to be continued on the day of surgery.
If the patient is posted for surgery which involves major fluid shifts, so it is better to withhold on the surgery.
No, but that will occur later, isn't it? This the hypotension with ARBs occur when you induce the patient.
Yes.
Because these AC inhibitors and ARBs can produce vasoplegia along with our inhalation anesthetics and IV anesthetic agents. So because of that, these patients can develop severe refractory hypotension. But majority of the people say that if the patient is on AC inhibitors or ARBs for hypertension, so you can stop on the day of surgery. It is not a must. It is not a must. So many of the anesthesiologists do continue, but for your exam purpose, you can always say if the patient is being given AC inhibitors for hypertension, so you can stop it on the day of surgery. But if the patient is on AC inhibitors for the control of left ventricular failure, especially to decrease the afterload, you can continue. But caution is that they can produce hypotension that you have to be aware of. So it is always, one thing is if you want to continue AC inhibitors on the day of surgery, if the patient is on AC inhibitors or ARBs for hypertension, it is better to preload the patient so that you can definitely decrease the chances of hypotension. So in a patient with left ventricular failure, we have to be very cautious in preloading the patient because these are the patients can develop, pulmonary edema. So you have to be extremely cautious when using or continuing AC inhibitors and ARBs on the day of surgery. So you have to look for refractory hypotension. So another question that can be asked for you in the exam regarding these ARBs and AC inhibitors is, suppose if the patient develops refractory hypotension, what is the drug of choice to be used? Which vasopressor to be used?
Phenylephrine.
Not phenylephrine.
Dobutamol.
It is vasopressin, the drug of choice for patients developing refractory hypotension if they are on AC inhibitors and ARBs, because they develop vasoplegia. And vasopressin acts on vasopressin 1 receptors, and it is going to immediately produce vasoconstriction in these patients so that the hypotension can be corrected. So you should be careful about that. And you can give vasopressin in the dose of 0.04 units per minute, like you keep on titrating the dose, and you can definitely improve the problem associated with refractory hypotension. So these are some of the things. And of course, yesterday we also discussed about the anticoagulants other than antiplatelets. So again, regarding the anticoagulants, we'll discuss just prior to the, when we go for preparing the patient, isn't it? We'll go into details about patients on anticoagulants. So what all the precautions we have to take and how to manage, and regarding anticoagulants and neuraxial anesthesia. So that is one of the most commonly asked questions for you in the exam. So ASRA guidelines is the one which we always follow. We will discuss when you are talking about the neuraxial anesthesia in this patient and patient on anticoagulants. Now let us move on to the examination. So do you have any thing regarding the history? Because why I went in for so long discussion regarding the history in a ischemic heart disease patient, it is mainly the history. That's what yesterday I was telling you. So you have to understand the many important things about the what all the history you have to take, and almost your pre-anesthetic evaluation will be 85% is completed with just history. Probably your examination and investigations add on about 15%. So now let us move on to the examination, and you start with the examination. One more thing about the umbilical hernia you were talking about, because this patient has umbilical hernia. So in the history, again, these are patients, female patients with hypothyroidism. There are more incidents of umbilical hernias, because one of our surgical PGs when I was in Mysore Medical College also did a study on thyroid functions and umbilical hernias. He found significant number of patients, especially female patients with hypothyroidism developing umbilical hernia. So it is better you keep that in your mind, and you can also get the thyroid function test done, and you can also ask few questions regarding the thyroid functions in these patients. Because if there is hypothyroidism, you can definitely treat hypothyroidism before taking up this patient for surgery, especially umbilical hernias in female patients. Okay, right. Let's move on to general physical examination.
Our patient is moderately built, sir, moderately nourished, conscious, oriented to time, place, and person. With my patient has height of 158 centimeter, weight of 60 kg, with body mass index of 24.03, and patient doesn't have any pallor, icterus, cyanosis, clubbing, or lymphadenopathy, or pedal edema.
So just at this general physical examination, so again in these patients with ischemic heart disease, one very important thing is ruling out syndrome X, isn't it? Especially the obese patients, truncal obesity. So very important. Even the body mass index may be normal, but they may have a truncal obesity. So here you better measure the waist circumference and waist hip ratio is very important, because that has not been measured. Did you measure, or you have not measured?
Mm.
You have not measured, isn't it? So what should be when do you say waist circumference is significant, male, female?
Male, it is more than 105 centimeters, sir. Female,
Okay.
it is 85 centimeters.
Yeah, more than 102 centimeters in males, and 88 centimeters in females. 88 and 102. That you should always remember. And waist hip ratio?
1.5 in males.
1.1.
1.2.
1.1 in males, 0.85 in females. So anything more than that, you can say it's a truncal obesity is there, and syndrome X. So what are the other features of syndrome X other than the truncal obesity?
Hypercoagul state, dyslipidemia, hyperglycemia.
Okay, and hypertension. Yesterday we discussed briefly. So when you may be asked about this syndrome X or metabolic syndrome when you are presenting this patient with height and weight of the patient. Okay. Now again, height is very. Sometimes they may ask you why do you want to know about height? Height is very important, especially when you want to calculate the tidal volume for this patient. Suppose I'll put this patient on mechanical ventilation, GA I'll give, and mechanical ventilation. So how do you check for the predicted body weight for tidal volume based on the height of the patient? It is called as a predicted or appropriate body weight for calculating tidal volume. It is only for calculating tidal volume based on height. Because again, this is important because you are likely to, I don't think you'll manually ventilate. You will put the patient on mechanical ventilator during anesthesia. So for that, you have to know what should be the weight for you to calculate the tidal volume. Tidal volume depends on the height of the patient, not on the weight of the patient. What is the formula that you use? Any idea, Vinod or Harish? Okay, the formula I'll just tell you, just note down, it is very important because even if these patients, if you are working in ICUs, so you have to calculate the tidal volume based on this only, especially for morbidly obese patients. This formula is very, very important. So the formula is, for male patients, for males, it is 50 plus 2.3, then in brackets, height in inches minus 60. So for males, it is 50 plus 2.3, then in brackets, height in inches minus 60. So this is appropriate body weight for calculating the tidal volume. For females, it is 45.5 plus 2.3, height in inches minus 60. Only change in females is instead of 50, you take it as 45.5. Okay. Now in this patient, 158 centimeters is 5'2", that is 62 inches. So if she is 62 inches, 62 minus 60 is 2. 2 multiplied by 2.3 is 4.6. Roughly, you can say 5. So 45 plus 5 is 50 kgs. So though her weight is 60 kgs, you calculate the tidal volume based on her appropriate tidal volume, appropriate weight for the calculation of tidal volume. So 50 kgs means 7 ml per kg body weight should be about 350 ml.
Yes.
Okay. Otherwise, you would be giving unnecessarily higher tidal volume, which she would not be requiring, isn't it? So that is why height is important for calculating the tidal volume. Again, for example, if you are planning for a lumbar epidural, again, height is important to know what should be the volume per segment that has to be given. So I'll just tell you about the volume per segment that you have to give in lumbar epidural. This is mainly for lumbar epidural. So do you know how much volume you have to give based on the height?
Per segment will give 1.5 ml.
1 ton.
No, it's not like that. Based on the height, suppose the patient is less than 150 centimeters, it is 1 ml per segment. You calculate based on number of segments you will calculate later. So you calculate up to 150 centimeters is 1 ml per segment. And after 150 centimeters, every 5 centimeter increase in height, you keep on adding 0.1 ml. Okay, I'll give you an example. 0.1 ml you have to add for every 5 centimeter increase in height after 150 centimeters. Let us say your patient is nearly 160 centimeters. So 1.2 ml per segment you have to use it. And again, age becomes important. After 40 years, you reduce by 0.1 ml for every decade. Now, let us say your patient is 60-year-old. So you have calculated based on height as 1.2 ml because after 42 decades, so instead of 1.2 ml, you have to reduce it to 1 ml. You have understood?
Yes.
So
after
next
40 years, every decade you reduce by 0.1 ml. Okay. Because as the age advances, the requirement of epidural volume dose also decreases because the intervertebral foramen becomes very narrow, leak through the intervertebral foramen decreases as the age advances. So height is important. Suddenly you may be asked about height and your ischemic heart disease patient posted for surgery and what is the relevance. Okay, for GA, relevance is in calculating the tidal volume, for epidural in calculating the total volume to be given for that particular, the surgery, okay, for lumbar epidural. Okay, now the other thing is, pallor is very important, as you said, because, hemoglobin levels, we'll discuss about that in when we discuss about hemoglobin. So general physical examination, again, here, you usually should add again the JVP. I don't know whether you have added JVP somewhere. So usually you can definitely add JVP also, and always ask for a backrest when you want to check for JVP in the exam. Because with a backrest only, you can keep the patient at 45-degree angle. Without a backrest, because I still remember one of the examiners, when the student said that JVP is not raised, he called the expert and then asked, did this student use the backrest? Then the expert said that he did not use. Then, the examiner said to the student that you have not actually checked for the JVP. Are you sure did you check like? So that is why you just ask for a backrest in the exam if you are want to check for JVP. Okay. Now the other vitals, you can proceed.
Vitals heart rate 65 beats regular, good volume,
Okay.
with no radial delay and no radiofemoral delay. All the peripheral pulses felt well.
Okay.
Blood pressure 130 by 80 millimeter mercury, right arm in sitting position, and respirate rate 14 breaths per minute, thoraco-abdominal type.
Okay, just here, when you're describing the heart rate, one thing is very important here is every student will talk about radial delay, radiofemoral delay and all. When it's usually present?
So radiofemoral delay will be present in cortication of the aorta.
Okay.
And no radial delay will be in the peripheral vascular diseases like subclavian arteries.
Because how many times really you have checked it, and how many cases of coarctation of aorta you have seen. So there is no need actually, because suddenly your discussion may go in towards coarctation of aorta, and suddenly you are not prepared for it. You will have a lot of problems. So better don't talk about it. You can just talk about rate, rhythm, volume, and most important in these patients with ischemic heart disease is character of the vessel wall, which you have not written here. So how do you check for the character of the vessel wall? Because invariably you want to check for atherosclerotic problems in these patients. So if there is atherosclerosis, definitely it will be quite thick and wall will be very thick. So how do you usually check for the character of the vessel wall?
By palpating over the radial artery with 3 fingers.
Very good. Very good.
With the first finger, we'll empty the blood volume, and in the middle finger, we'll palpate.
With the 2 fingers, you'll totally block the blood supply.
Right. Yeah.
So that there should not be any pulse wave when you are actually palpating the arterial wall. So with the middle finger, so index finger and then the ring finger are going to block the artery. So with the middle finger, you just palpate for the character of the vessel wall. So that is one thing which you should always remember. And I was talking to you about the blood pressure. Always examine these patients when they are on many of these drugs like diuretics and vasodilatory drugs, centrally acting drugs. So check for orthostatic hypotension. Okay. So then, okay, proceed. So that's very important, so that you can, because direct effect on our anesthetic management will be there if the patient also has an orthostatic hypotension. Right. Continue.
We have written meds here, sir.
No, ideally meds should be, it's a history. Meds is not examination finding, it's a history finding. Questionnaire, you'll be asking the patient, and then based on the questionnaire, you'll be coming to a conclusion that yes, this patient has got less than 4 meds or more than 4 meds. Yes, okay.
Coming to airway examination, there is no loose tooth or no missing tooth, no artificial dentures, mouth opening more than 2 fingers.
So airway is normal airway.
Yes.
Normal airway.
So here one thing I want to tell you is that you have a scale with you, isn't it? You have measured thyrometal distance.
Yes.
So why you are talking about mouth opening as 2 fingers?
Okay.
So again, it becomes very confusing. Whose fingers? Is it patient fingers or your fingers or your assistant's fingers? So whose fingers? The finger diameter can vary.
Okay.
So this is very confusing. In the exam, you should be very clear. You should always measure with a rigid scale. All measurements you should measure using scale, either a tape or ideal. For these things, ideal would be a rigid scale. So mouth opening means interincisor gap or interalveolar gap in those patients who are edentulous. So you always measure using scale and write down what is the in centimeters, because suppose you have examined the patient, Harish is the one who is doing the anesthesia part. So he just goes through your case sheet. He will be confused. What is this mouth opening 2 fingers means what? You can definitely check with the patient, but it is always, if you write down in centimeters, it's the same thing for everybody, isn't it? So, okay. Now this patient, absolutely no anticipated difficult airway. Fine. Next. Continue.
Yes, sir.
Yeah, we
Systemic
can
exam.
actually skip this abdominal examination because you have done a detailed abdominal examination. You have not found any abnormality except that the umbilical hernia is a very reducible umbilical hernia, isn't it? That is what is very important to know, whether it is reducible, irreducible, or whether there is obstruction or strangulation. So that is fine with the abdominal examination. We'll go for the other systems.
Cardiovascular system examination, sir. Inspection, chest shape is normal, apex beat is not visible, no scars or sinuses or dilated veins are observed, no precardial bulge seen on inspection.
Okay.
On palpation, inspection findings were confirmed. Apex beat felt at 5th intercostal space, half inches lateral to the midclavicular line. On percussion, the right heart.
Okay, don't have to do percussion for CVS. Have you really percussed? You don't do, isn't it? For CVS, no. Respiratory system, you do percuss. CVS, very difficult to percuss. Okay, right.
On auscultation, S1 and S2 sounds are heard, sir, no murmur.
Okay, with your apex beat, you have written felt at 5th intercostal space.
Yes.
Is it 5th or 6th? Because this patient is a chronic hypertensive patient. So suppose if you have written that apex beat felt at 5th intercostal space, half an inch medial to midclavicular line, I would have accepted because she has been very well controlled. Her hypertension has been very well controlled. And that is why remodulation of her heart has occurred and there is no left ventricular hypertrophy. But if it is lateral to the midclavicular line, then again a confusion starts.
Yes.
Isn't it? So these are the things which you should avoid in the examination when you are presenting the case. Okay. Suppose if you have written 6th intercostal space, lateral to the midclavicular line, yes, I would have accepted. Yes, this patient is a non-hypertensive. So probably because of the left ventricular hypertrophy, this patient has had the apical impulse shifted downwards and outwards. And character of the apical impulse is again important. You have to mention here the character of the apical impulse. You have not mentioned the character. Is it normal? Is it tapping? Is it hyperdynamic? Is it heaving? So these are the 4 different characters of the apical impulse. So what is normal apical impulse? What is the character? How it felt? Probably you will be feeling with your index finger, isn't it? Yeah, when you feel the apical impulse with your index finger, how does it feel? Normal. It just lifts the finger.
Yes.
Yes.
And then goes back, isn't it?
Yes.
So it will not sustain. So it just lifts the finger and goes back. What about tapping? Tapping apical impulse, you usually you will be telling in mitral stenotic patients, isn't it? Because what you actually feel is they say that the loud first heart sound. So what will be the character of a tapping apical impulse?
Will be more than the normal rise in the finger.
No, tapping means suppose you tap the door. How do you tap? Gentle tapping?
No.
You will do a gentle tapping, isn't it?
Yes.
Just gentle tapping. That means there won't be any rise in your finger.
Okay.
The apical impulse just comes and touches your finger and goes back. Just touches and goes back. This is tapping apical impulse. Now, in patients who are anemic or suppose aortic regurgitation is there where they have a hyperdynamic circulation, even mitral regurgitation. So how will be the apical impulse of hyperdynamic circulation?
It will be sustained.
It will lift your finger more than the normal lift and ill-sustained. It will not sustain. Ill-sustained. Okay. Sometimes you'll be asked, how do you feel about the heaving apical impulse? That is very important to know whether the patient has left ventricular hypertrophy. So it is always, the more than normal lift will be there of the apical impulse and it sustains for a few milliseconds and then goes back. So ill-sustained is hyperdynamic circulation. Sustained, forceful apical impulse is heaving apical impulse. So very important for us to just to rule out whether the patient has got any left ventricular hypertrophy is there. That means the patient's hypertension has not been properly controlled. There are other reasons are also there. Any increase in afterload can produce left ventricular hypertrophy, but it is very important. So the other thing also you should look for in any of these patients when you do a cardiovascular system is, any P2 palpable and also parasternal heave. Always look for the right ventricular hypertrophy also and pulmonary hypertension, just to rule out, because any patient with ischemic heart disease associated with pulmonary hypertension, you have a higher risk for these patients when he comes for anesthesia and surgery. So that's how when you are presenting to the examiner, just say there whether P2 is palpable and P2 is loud. So if P2 is palpable and loud, definitely it shows that the patient has got pulmonary hypertension. And also look for parasternal heave. So you keep your ulnar border of your hand across or all along or parallel to the left border of the sternum, and see with every contraction of the right ventricle, your hand gets lifted. And this is called as parasternal heave. So two heaves you should always mention when you are presenting. One is the left ventricular hypertrophy, that is heaving apical impulse. Right ventricular hypertrophy, parasternal heave. So just remember this when you are, and P2, whether it is palpable and loud or not palpable and not loud. So rule out pulmonary hypertension, especially in respiratory diseases. You have to really go for this because carpulmonale can be there. But even in ischemic heart disease patients also look to rule out pulmonary hypertension. Okay. Anything in the respiratory system in this patient?
No.
Any positive findings?
No, sir.
No
No, sir.
positive.
Yeah, what findings you wanted to look for in a patient with ischemic heart disease? Let me say this patient has got a ischemic heart disease with poor left ventricular function.
It could be patient may be having breathless and chances of pulmonary hypertension.
There
Respiratory
will be
system?
there will be use of
For
accessory
accessory
muscles.
No, all those
And
things, that's okay. But what you should
There
look
can
for
be
in
added sounds like
Yeah.
crepitations.
basal crypts. And also S3 gallop in when you are auscultating, S3 gallop with basal crypts. So sign of left heart failure, isn't it? Because you are talking about the right heart failure, the signs are basically raised AVP, tender hepatomegaly, and pedal edema that we discussed yesterday. So here, left heart failure, because these patients with poor left ventricular function, they may also be in left heart failure. So ruling out left heart failure clinically also is very important. Of course, we are going to do an echocardiography and then we'll finally know. But again, clinically, again, important because in the exam, you will not be given any echocardiographic or any other investigative findings. So you may have to talk about this also. So fine crepitations, basal crepitations, and also S3 gallop. So why it is again important is any patient with failure, whether it is right heart failure or left heart failure, if he has not been optimized, is not a patient to be taken up for any elective procedures. Only life-threatening, limb-threatening surgery emergencies, you should accept them. Otherwise, no. And they carry a very high risk of, perioperative mortality also. That is why basal creps is important. Fine basal creps. Coarse creps you can hear in respiratory problem, especially chronic bronchitis or even suppurative lung disorders. So here, fine creps are important. So just say that there are no fine crepitations. So let the examiner ask you, why did you look for fine crepitations? So you can always say, so I just want to rule out left ventricular failure in this patient. Okay, right. So CNS, you have not found any change,
No.
any positive findings.
No.
So especially in these patients, already we were discussing, thromboembolic phenomenon can be high. So you should look for. And again, one thing I want to tell you in all these hypertensive patients and ischemic heart disease patients, also auscultate over the carotid arteries. Feel for bruit, auscultate for the murmur there. Bruit is, carotid bruit is an indication. What does it indicate, carotid bruit, if it is there?
Atherosclerosis, sir.
A narrowing of the carotids, isn't it? So once the critical narrowing occurs, the bruit can be heard. Why bruit there? Why normally you don't hear any bruit or any abnormal sounds over the carotids normally? And why you hear if there is a narrowing?
Turbulent flow with the
Yeah, very good. So why turbulent flow occurs?
narrowing of the.
Yeah, if narrowing is there, why turbulent flow? What happens to the velocity?
Velocity will
Increase.
Velocity
Velocity
increases.
increases.
So the Reynolds number,
Reynolds.
isn't it? So once the Reynolds number crosses 2000, so because of the increase in velocity, Reynolds number, it's just a number. It is velocity into density into diameter divided by viscosity. That is the Reynolds number. So whenever narrowing is there, in order to keep the flow constant, because flow is nothing but velocity multiplied by area. Flow is nothing but velocity into area. So if you want to keep the flow constant, if the area is decreasing, the velocity automatically has to increase. So that's what occurs here. So in order to maintain the flow, body tries to, the area has come down because the carotid narrowing. So velocity increases. But when velocity reaches a critical point at which the Reynolds number crosses 2000, you can start having bruit. So that's why check for carotid bruit, because these are the patients who are likely to have CNS problems later, at least intraoperative or the postoperative period. So it may be, if the bruit is there, you may have to ask for a carotid Doppler also, Doppler study of the carotid. So you have to check for how much it is narrowed, isn't it? So that is again important. And in some of the guidelines, it is said that if critical narrowing is there, more than 50% narrowing of the carotids are there. So one may have to first go for carotid endarterectomy or percutaneous manipulations before actually going in for whatever the surgical procedure the patient is posted for. So such may be the problem of patient developing perioperative stroke. Okay, so that's why a simple thing, just palpate over the carotids, just also auscultate, just rule out carotid bruit in these patients with peripheral arterial disease and ischemic heart disease patients. Okay, now your diagnosis. Any doubts till now what we have discussed, Harish and Vinod? No doubts? Can we go for the diagnosis and then?
Sir, in the HOPI, do we have to mention as a patient has so many meds, or we should mention the question that the patient can able to perform this activity?
Both you mentioned. Okay. You say what is the exercise the patient can do, and also say patient has more than 4 meds. Okay. So you are mentioning both, isn't it? So that way, definitely it's going to help. Okay.
Sir, before we go, can we take some questions, sir? Some few questions are there.
Oh, yes, sure.
Or you want to take it later, sir?
No, anytime, no problem.
So one Dr. Anu Lakshmi, sir, can you please repeat the indications of beta blocker in IHD cases, sir?
So definite indication is there for patients who are likely to go for surgery, because indications as such, all IHD patients, beta blocker is an indication, because beta blockers reduce the heart rate and also they'll depress the myocardium. So they are going to help in decreasing the demand and also improving the supply. So the definitive indications for these patients on beta blockers is that if the patient is already on beta blocker, you continue on the day of surgery. That is always there. The patients are not on beta blockers. If the patient is being posted for a major vascular surgery, definitely you should start these patients on beta blocker therapy at least 1 week before. That is one. Then you also look for the revised cardiac risk index in these patients. So if the clinical risk predictors or indices are more than 2, then definitely these are the patients who require beta blocker therapy at least 1 week before. The third indication is, okay, now this patient is not on beta blocker, but later at least he's going to require beta blockade therapy, either for his hypertension or because of ischemic heart disease. If the cardiologist thinks definitely I may have to put this patient after the surgery beta blocker, then why after the surgery? You can always start the patient on beta blocker therapy at least 1 week before. So these are the definitive indications for beta blocker therapy to be started before surgery.
Yes, sir. Thank you, sir. And sir, can you please repeat about the volume for epidural volume to be given based on the height, sir? Is there anything in regards to spinal volumes also?
A spinal volume, it is only for pregnancy, it is there, not for non-pregnant mothers. So for pregnant patients, up to 150 centimeters, you go for 1.4 ml of bupivacaine heavy, 0.5%. Up to 150 centimeters, that is short females with pregnancy, 1.4 ml. And then for patients with 150 to 170 centimeters, pregnant mothers, it's only pregnant mothers,
yes, sir.
go for 1.8 ml. And more than 170 centimeter height, go for 2.2 ml. It is 1.4, 1.8, 2.2 ml for pregnant mothers posted for cesarean sections for under spinal anesthesia. So because many of the students will be, they'll have a short pregnant patient, they would have measured the height as 145 or 150, 46 centimeters. When they are asked how much to give, they say 2 ml. So for everybody, they would have given 2 ml. It is not like that. So based on the height, only for pregnant patients, the spinal anesthesia, in the literature, it is there. And for epidural, somebody was asking already, we discussed based on the height, it is mainly for lumbar epidural, because for lumbar epidural, you want to go up high up, because the number of segments you want to block more and more number of segments, even the thoracic segments, if you want to block. So you always calculate based on the height. Up to 150 centimeters, you calculate as 1 ml per segment. And after 150 centimeters the height, any increase in height of more than any height, every 5 centimeter, you keep on adding 0.1 ml. That's what I gave you an example, like 160 centimeter, you have to add 0.2 ml because 155 centimeter, 0.1 ml. Another 5 centimeter, 160 centimeters, again 0.1 ml. So it will be 1.2 ml. So, and then age also is very important. After 40 years, so you start decreasing by 0.1 ml for every decade. So this is how you calculate.
Thank you, sir. So after the age of 40 years, we also reduce it by 0.1 ml per segment.
0.1 ml for every decade.
Every decade. Yes, sir.
Yeah.
Thank you, sir. Arnav was asking, is there any volume for thoracic epidural, sir?
No, there is no definitive volume for, because, number of segments you are going to block is very limited.
Yes.
When you go for thoracic epidural, because you are placing the catheter high up and you are mainly using probably for upper abdominal surgeries or thoracic surgeries.
Yes.
So there is no this thing. You can grade it up.
Yes, sir. And sir, you had asked for backrest while checking JVP. Is there any specific reason to be kept a backrest for?
No, you have to keep the patient at 45 degrees angle. So the back to the bed, the angle formed between the back and the bed should be 45 degrees angle. So why we have to keep the patient at 45 degrees angle for measuring JVP? That is also many times this question can be asked. You should always remember that JVP or jugular venous pulse, JVP is not jugular venous pressure. That you should always remember. It is always the jugular venous pulse. So jugular venous pulse will be always at the level of manubrium step, whatever the patient's position. It is always at the level of manubrium. So we know that the manubrium will be at the same height as or at the same level as the clavicles when the patient is lying down at 45 degrees. That means the jugular venous pulse should be just above the clavicle when the patient is lying down at 45 degree angle to the bed. Did you understand?
Yes, sir.
Because it is at the same level as manubrium. Manubrium will be at the same level as clavicle. And suppose the patient is completely sitting. So the manubrium will be much lower than the level of clavicle. So you will not be able to see the JVP at all. Suppose the patient is lying down, the manubrium will be much higher than the clavicle. So in spite of normal jugular venous pulse also, you can see much higher above the clavicle. It is not raised. So when you want to check it, so you always keep the patient at 45 degrees angle. Suppose if it is higher than the clavicle, then you know that JVP is raised. So again, you always measure the JVP from the manubrium sterni. That is very important, isn't it? So you see what is the highest level of jugular venous pulse you are able to visualize above the clavicle. So you keep a scale there, and then you keep a scale horizontal at the level of the mammarium. You measure in between, the height in between. So sometimes they may ask you again, why mammarium? Because always the jugular venous pulse should be at the height of, at the level of mammarium. That is why you want to know how much is elevated above the mammarium. Yes, at 45-degree angle, because at 45 degrees angle only, if it is elevated, you can see above the clavicle. Otherwise, you don't see. Okay. Super. So if you add 5 centimeters to this JVP, you get CVP roughly, yes, because right atrium is 5 centimeter deeper to the mammarium in normal chest position patients, not in barrel-shaped patients and all. So you add 5 centimeter, you can get a CVP.
Thank you, sir. Such an excellent explanation. So one more question by Josna. Sir, what if patients are on digoxin? Any care to be taken?
Patients can be on digoxin and diuretics if the patient also is in failure, or digoxin can also be given in patients with atrial fibrillation for control of rate. In India, still digoxin is very popular for atrial fibrillation because digoxin is a very cheap drug. Yes. The cost of the drug is very, very low. That's why it is always given. And when patient is on digoxin, when you are asking the history, it's very important. You have to ask the patient whether the patient has been told to continue the drug throughout the week, or has he been asked to stop the drug at least for 2 days in a week. So once the patient says that he's taking some small white tablet, but he has been asked to stop for at least 2 days in a week and then again continue for 5 days, that is what you have to mention it to the examiner. The next question by the examiner is what may be that particular tablet, and you say it is digoxin. And very important to know about digoxin the patient is on, because digoxin has got a narrow therapeutic index. Because therapeutic index is the therapeutic dose divided by the lethal dose. So that is what is therapeutic index. The therapeutic concentration of digoxin is just about 2 nanograms per ml. Is therapeutic concentration. The lethal concentration is 3 nanograms per ml. You can imagine there's so much of a narrow therapeutic index is there with digoxin. That is why you have to be extremely careful. That is the reason why we stop the drug at least for 2 days, because digoxin has got a long half-life of 48 hours. So that is the reason why you don't want the cumulative effect of this digoxin to produce toxicity. You're going to reduce or you're going to stop. So that is very important to know about. And the first toxic effect of digoxin that occurs is anorexia, nausea, vomiting. So the patient was fine. The patient is on digoxin. You get the history that the patient suddenly has developed anorexia, nausea, and vomiting. So you have to suspect digoxin toxicity. Again in the exam, any VPCs, especially the VPC occurring after every second beat, bigeminy or trigeminy, it is one of the most common problems of digoxin. And again, if you look at the ECG, so normally the reverse tick mark is digoxin effect, because it will be acting on the phase 3 action potential by inhibiting the sodium potassium ATPase pump. So it will be effective on phase 3, that is in the the relaxation phase or repolarization phase. So you have ST, a reverse tick effect will be there. That is, if you just see ST with the mirror image tick mark or a correction mark, then you know that the patient is on digoxin. It is a digoxin effect. It is not digoxin toxicity. But if the patient has developed a prolonged PR interval, first degree AV block, it was not there before, and after some time after digoxin, the patient has developed first degree AV block. So you know that the patient has developed digoxin toxicity. You have to assess, measure the serum concentration. If lab facilities are available, better to stop the drug. Okay, these are some of the things to know whether the patient has developed toxicity or not. Okay, another very important thing about digoxin is the hypokalemia can exaggerate digoxin toxicity. The same concentration, therapeutic concentration, can produce digoxin toxicity whenever the patients develop hypokalemia. So that is another very important thing. You have to measure potassium when the patient is on digoxin before taking up for surgery. So the next is whether to continue digoxin on the day of surgery or not. If the patient is on digoxin for control of rate for atrial fibrillation, you continue the drug on the day of surgery. You don't stop it because you are giving digoxin for control of rate in atrial fibrillation. Whether the patient is posted for cardiac surgery or non-cardiac surgery, you continue on the day of surgery. If the patient is taking digoxin for control of rate in atrial fibrillation. So suppose the patient is not having atrial fibrillation, but digoxin is being given for the optimization of the heart failure, especially the right heart failure. So you stop the drug if the patient is posted for cardiac surgery at least 2 days before, because digoxin sensitizes the myocardium. But if the patient is posted for non-cardiac surgery, you continue the drug even on the day of surgery. So non-cardiac surgery, digoxin to be continued on the day of surgery, whether he is posted for, if he is taking digoxin for control of rate in atrial fibrillation or the failure, you continue on the day of surgery. And another very important thing, once the patient is on digoxin, never hyperventilate. Very important, you can produce iatrogenic hypokalemia because hyperventilation, respiratory alkalosis, pushing the potassium into the cell, sudden hypokalemia, suddenly the patient can develop, even if the patient doesn't have atrial fibrillation, he can develop atrial fibrillation. So you have to be very careful how to ventilate the patient in a patient who is on digoxin. So, and again, exaggerated bradycardia can occur with succinylcholine, digoxin and succinylcholine interaction. So these are some of the things which you should know, because somebody asked about digoxin. I had to go into details.
Excellent explanation. I think everything about digoxin has been told, sir. There's nothing left. Sir, even I think we need to be careful while we are giving spinal anesthesia in patients with digoxin, or?
No. Not much of a problem in patients with spinal anesthesia with digoxin. No problem.
Yes, sir. And sir, you said there is, I think Josna only is asking this. You said we have to check for orthostatic hypotension during evaluation. So what is the exact way of doing it, sir?
No, you lying down, you check for the blood pressure, and then make the patient stand and again check the blood pressure. Only in diabetics, you wait for 3 minutes and check the pressure. Because there, autonomic neuropathy is there. You give sufficient time for the body to take measures to optimize the blood pressure. So in diabetic patients, you wait for 3 minutes and check the pressure. In non-diabetic patients, you can immediately check and then see whether there is any orthostatic hypotension there. So very important for your exam purpose, and routinely, it is very important for us to check for this.
So you mean to say you ask the patient to stand up, wait for 3 minutes, and then check the blood pressure by keeping the blood pressure cuff at the same, the apparatus at the same level?
Not apparatus. Cuff should be at the level of the precardium. Apparatus can be, you can keep it anywhere.
Okay.
That is again another very important thing when you are checking the blood pressure. It is nothing to do with the apparatus. Your apparatus can be on the floor also. You are checking the pressure in the patient in the standing position. The sphygmomanometer cuff should always be at the level of the heart. Like when you are using a IBP, that is IABP, not IABP, sorry, IBP. So invasive blood pressure monitoring, the transducer level is very important. The transducer level should be at the level of the heart. So like that, the blood pressure cuff should be at the level of the heart, not the instrument. This again is exam question. Many the examiners are fond of asking this.
Sir, Sanjana is asking.
You can actually do this. You keep the blood pressure apparatus at different positions and check.
Yes, sir.
Yeah.
Thank you, sir. So, Dr. Sanjana S, I think Dr. Imran Khan, we have already answered about the epidural dose with height, that we have already answered. Dr. Sanjana S, sir, what are the points to be mentioned in the airway examination? I think she wants to know, while mentioning about the airway examination, what are the points that should definitely not be missed?
So airway examination, routinely, 5 things you have to measure, 5 things you have to talk about. One is interincisor gap. Ask the patient to open the mouth, measure the interincisor gap or the interalveolar gap. Suppose if the patient is edentulous, so in between the upper gum and the lower gum, you measure. So, and immediately you also look for the malampati. You ask the patient to put out his tongue, head in the neutral position, look for the malampati. Then, ask the patient to protrude his jaw and then bite the upper lip. So upper lip bite test. So rapidly you can do, it takes about 2-3 minutes for this. Then you have to measure the thyromental distance. So thyromental distance, you make the patient to completely extend his neck and the upper border of the thyroid cartilage to the mentum. You have to measure the vertical distance. That is, you have to use a rigid scale. Don't use a tape. So that is thyromental distance. So another thing is the movements of the neck movements. So just check for the neck movements, or you can even ask the patient just to, without moving his eyeballs, to look at the roof of the building. So if the patient is able to look at the roof of the building, that means he has got a good neck extension. Extension is more important for us than flexion. So one more thing you can also add is the teeth. Any loose tooth is there, any dentures are there, any temporary dentures are there. So these are the minimum things. Suppose the patient also has got a short neck, and in obese patients and in pregnant patients, you also measure sternomental distance. Sternomental distance. Sternomental distance will give you what is the length of the neck, whether it is short or not. Normally it is 12 centimeters and above is normal sternomental distance. Anything less than that, you have a short neck, and any short neck, the larynx will move up, cephalite. So when you do a regular laryngoscopy using your Macintosh blade, you may not be able to visualize the larynx. Whenever a patient has got short neck, because the larynx has moved up, so more cephalite, more anteriorly placed, so you require probably a Mackay blade may be required in such situation. So already you keep ready, or definitely you can keep as your video laryngoscope as the first choice.
Yes, sir. And I think, Soumya, we have already spoken about nitrates. Let's not waste time on that. Sir, is there any calculation for giving an opiate by Dr. Muthukumar Rajgopalan?
Opiate, subcutaneous, IV, intramuscular, oral, intrathecal, epidural, which particular route also is very important. If they are thinking about the intrathecal, so usually we don't go beyond 0.1 to 0.2 milligrams. It is not per kg body weight or anything. Usually you don't go intrathecal. It is the gold standard for analgesia, intrathecal analgesia, post-op analgesia. For Indians, I feel that 0.1 milligram is ideal, because Indians are extremely sensitive to opiates because of their pharmacogenetics. So don't go beyond 0.1 milligram intrathecal. So epidural, you can definitely give 2 to 3 milligrams. So you don't have to calculate per kg body weight in adults. Usually you give 2 to 3 milligrams epidural per dose. Invariably it acts for about 8 hours. So another thing about the morphine is why it's a gold standard for central neuraxial post-op analgesia is it is more hydrophilic than lipophilic. All other opiates, immediately they get into the blood and they may be acting supraspinally. Whereas morphine acts more on the spinal receptors, opiate receptors. That's why it has got a prolonged duration of action. And when you are restricting your dose to 0.1 milligram intrathecally and 2 milligrams epidurally per dose, you don't have respiratory depression, because it takes a long time to move up and to produce respiratory depression. The rostral spread takes almost about 6 to 8 hours. So that's how it is very, very safe.
Yes, sir. Thank you, sir. Sir, diuretics by Ashish Gupta, Dr. Ashish Gupta. Sir, any diuretics to be continued on the day of surgery or to be stopped?
Because in between, I remembered about diuretics when I was talking to them about orthostatic hypotension, because if a patient is having a left ventricular failure, so he'll be on AC inhibitors and diuretics, and especially potassium sparing diuretics and on a combination with loop diuretics. So spironolactone with furosemide. So lacilactone, we commonly say. Many of these patients can be on these drugs. So the patients are on diuretics, orthostatic hypotension, you have to check for one. Second thing is that will give you a volume status. Second thing is you have to check for electrolytes, especially if the patient is on potassium sparing diuretics, there can be hyperkalemia. If the patient is on loop diuretics, there can be hypokalemia. So check for the electrolytes. That is very important. And to be continued on the day of surgery. Again, this is a very important, relevant question. If you are using diuretics for control of failure, so the thing is you can continue on the day of surgery, provided you have you take care regarding the problems associated with that, like hypotension can occur. But if you are giving diuretics for control of pressure, sometimes we add hydrochlorothiazide as one of the diuretic for control of blood pressure. So if that is so, then if it is more than 1 week, you can continue on the day of surgery because it is more of vasodilatory effect. If it is less than 1 week, better to stop on the day of surgery. So otherwise, diuretics are usually can be continued on the day of surgery if you are using it for failure problem of the patient.
Okay, sir. Or can we put it up like this, saying that if a surgery, if there is a surgery where there are a lot of fluid shifts, can be avoided? Can we say that in the exam, sir?
Yeah, definitely 24 hours before you can give, and on the day of surgery, you can avoid.
You're right. So one Muthu Kumar Rajgopalan. Sir, how reliable is BP blood pressure monitoring in lower limbs?
Lower limbs, especially in a patient with peripheral arterial disease, it is not at all reliable, definitely. And again, if you are recording the pressures in standing, definitely it will be much higher. Change of position, definitely, suppose head up position of the patient, it will be higher. Second thing, third thing is, the cuff size is very, very important. So if you are measuring in the lower limb, so unless the cuff size, at least it covers at least half of the thigh, then only it will be slightly better reliable than the upper limb. Upper limb is always more reliable.
Yes, sir. One last question, sir. I think Muthu Kumar again has mentioned it clearly that sir has cleared the epidural and spinal dosing. I'm very happy. Abdul Nazir, Dr. Abdul Nazir, is there any zero reference point in terms of blood pressure monitoring, sir? I think it's the transducer. What is or the
transducer monitoring? Definitely, you always go for fifth intercostal space mid axillary line. That is for patients on any position there. So always go for fifth intercostal space mid axillary line. That is the reference.
Non-invasive, sir?
Non-invasive, the cuff should be at the level of the chest. That's all. The heart.
Yes, sure. I think yes, sir. We are done with these questions, so we can continue with summary and proceeds.
Yeah. Okay. Vinod, can you just summarize?
A 55-year-old female with complaint of swelling around the umbilicus, a known case of hypertensive since 10 years, on tablet amlodipine and tablet metoprolol. A known case of IHD 1 year back with status post PTCA on aspirin 75 mg and clopidogrel 75 mg, stopped 7 days back with the meds more than 4, diagnosed with umbilical hernia, posted for open umbilical hernia repair with mesh.
Okay, now with this diagnosis, now this patient is posted for an elective umbilical hernia repair. Now, how do you investigate, and what will be your choice of anesthetic technique for this patient, and how do you proceed? Can you just talk about the investigations in this patient?
I would like to ask complete hemogram, sir.
Okay.
Complete blood hemogram.
Well, in complete hemogram, it is always better to go for indicated tests, isn't it? So in this complete hemogram, which test is more important for you in a patient with ischemic heart disease?
Hemoglobin.
Hemoglobin is most important, isn't it? So
yes.
Why hemoglobin is important for you?
One to estimate maximal allowable blood loss.
Yes, very good.
And one to see the oxygen carrying capacity of hemoglobin, how much?
Or oxygen content, isn't it? So yes. Oxygen content and maximal allowable blood loss. So why oxygen content is important in a patient with ischemic heart disease? For that, you can just tell me about the factors influencing the oxygen supply and factors influencing the oxygen demand in any patient with ischemic heart disease.
Reduce your asking.
Factors influencing the oxygen demand, supply and demand.
Tachycardia.
The first most important factor for supply is
hemoglobin.
Oxygen content and coronary blood flow, sir.
Coronary perfusion pressure, isn't it? Coronary perfusion pressure is most important, and it is the diastolic pressure which is more important as far as the coronary perfusion pressure. Diastolic pressure, always, the blood through any vessel flows through a gradient. Unless there is a gradient, blood cannot flow or any fluid cannot flow. Now, the gradient here is from between the diastolic pressure in the coronary vessels to the cavity pressure in the left ventricle, isn't it? Because we know that only during diastole, the myocardium of the left ventricle gets supplied with oxygen and blood, isn't it? During systole, it cannot get the blood. Why, Harish, during systole, the left ventricle cannot be supplied with blood? No coronary circulation.
The intramuscular capillaries will get compressed during the systole. So there won't be perfusion pressure during the systoles. I mean, there is no pressure gradient between.
So what you should tell is the pressure gradient. Just now I said that the fluid moves with the pressure gradient. If there is no pressure gradient, the fluid cannot move. Now, during systole, what is the pressure in the coronaries?
120.
Same 120. What is the aortic pressure that is there? It has to be there in the coronaries. Yes. So what is the pressure inside the cavity, ventricle, left ventricle?
It will be above the aortic pressures.
It will be almost same, isn't it? 120. So where is the gradient?
There is no gradient.
There is no gradient. That's why it won't flow. Whereas the right ventricle, again, the coronary is supplying the right ventricle. What will be the pressure during systole?
70.
Same 120.
Yes, 120.
No, it has to be same, isn't it? Same. The coronaries, because they take origin just distal to the aortic valve from the aorta root to the aorta. So whatever the pressure is there in the aorta, the same is conveyed to the coronaries also. Whether it is right coronary, left coronary, it doesn't matter. So it is the same systolic pressure, 120 will be there. What is the intracavity right ventricular pressure during systole?
25.
Yeah, 25 millimeters of mercury. See, the gradient is so much. That's why the right ventricle gets supplied both during systole and diastole. Whereas the left ventricle during systole, it cannot be supplied. Whereas diastole, what is the pressure in the coronaries during diastole?
80
millimeters. What is the intraventricular pressure?
10.
It is about 8 to 10 millimeters of mercury. So there is a 70 millimeter gradient normally also in normal hearts. So that's how, during diastole, even the subendocardium gets supplied. Whereas the right ventricle, no problem, isn't it? What is the intracavity pressure in the right ventricle during diastole?
4 to 5.
Yeah, same as CBP, isn't it? Just about 4 to 6 millimeters of mercury. So again, diastolic pressure is 80. So there is quite a bit of. So right ventricle usually will not suffer from ischemia much. So right ventricle will be getting blood supply both during systole and diastole. Only the left ventricle is a problem. That's why in all other tissues, we always calculate the perfusion pressure as mean arterial pressure minus whatever the pressure inside the veins there. Whereas only in case of the heart, especially the left heart, we always go for diastolic pressure minus left ventricular end-diastolic pressure. Whereas for cerebral vessels, again, you go for mean arterial pressure minus, the intracranial pressure, isn't it? There we don't go for systolic or diastolic, mean arterial. Everywhere it is MAP, except for the left ventricle, it is always the diastolic pressure. So that you should always remember. Okay. So that is one of the most important factors, which is, the first factor regarding the blood supply and oxygen supply. Okay. What is the amount of blood supply to the myocardium? How much of blood supply goes to the myocardium?
Approximately 250 ml per.
250 ml or roughly about 5% of
Cardiac output.
You can remember like that. 5% of cardiac output is the blood supply. 10% of the total oxygen consumption is to the myocardium. Yes. Normally, total oxygen consumption by the body at rest is how much per minute?
250 ml.
250 ml per minute, isn't it?
Yes.
In a 70 kg man, 3.5 ml per kg per minute. So it roughly comes to 250 ml. What is 10% of 250 ml? 25 ml. Yeah, 25. So this is commonly asked for you when you have ischemic heart disease patient. How much is the blood supply? How much is the oxygen requirement? Oxygen requirement is 10% of the total oxygen requirement at rest, and the blood supply is 5% of the cardiac output. What is the size of the heart?
Weight.
Size means weight.
250 grams. 1
so
gram.
roughly 250 grams, isn't it? 250 to 300 grams. You can say 250 grams. So 1 ml per gram is a blood supply, isn't it? So, and oxygen supply is 1 ml per every 10 grams. So remember about the blood supply and oxygen supply. And the perfusion pressure is the one of the most important factors, which is very important. So application of this is never allow the patient to develop hypotension intraoperatively. Hypotension is more dangerous than hypertension intraoperatively for these patients, because any hypotension will decrease the diastolic pressure, that will decrease the coronary perfusion pressure, so that can produce myocardial ischemia. Okay, so that is why diastolic pressure has to be maintained in these patients. Okay, sometimes you will be asked about a patient with aortic stenosis. Invariably, you'll have an ischemic heart disease also, because they're present with angina. There again, central neuraxial block may be absolutely contraindicated in patients with severe aortic stenosis. Because when you give a central neuraxial block, you're going to produce sympathetic block, you're going to decrease the diastolic pressure. So here, already aortic pressure is decreased, isn't it? Because of the narrowing of the aortic valve, the amount of blood entering into the aorta itself is decreased. So the aortic pressure is decreased, coronary perfusion, coronary diastolic pressure is decreased. So if you further decrease the aortic diastolic pressure, these patients invariably go for myocardial ischemia or infarction. So that is why in patients with severe aortic stenosis and also severe hypertrophic cardiomyopathy, so central neuraxial blocks, definitely you have to be extremely cautious or better to avoid. These are the patients who also will have angina ischemia. Okay, so that's why this diastolic pressure minus LVEDP is very important to know about. Okay, and again, why it's important again in those patients with diastolic dysfunction. So LVEDP can be high, because whenever a diastolic dysfunction is there, what happens to the compliance of the left ventricle? Decreases. What do you mean by compliance?
It is the tendency of
what is the definition of compliance? Volume change per unit pressure change. Isn't it? Volume change per unit pressure change is the compliance. So for the same volume, if the compliance is high, the pressure developed is much lower. But for the same volume, if the compliance is low, the pressure developed is much higher. So diastolic dysfunction means ventricle is not relaxing. If the ventricle is not relaxing, its compliance has come down. If the compliance has come down, so naturally, for the same left ventricular endostolic volume, the left ventricular endostolic pressure is much higher. So if it is much higher, so you can think that these are the patients where the coronary perfusion pressure may come down, isn't it? Diastolic dysfunction. Hence, that is also very important. Nowadays, we always look for diastolic dysfunction. So we can, discuss more about diastolic dysfunction when you talk about the echocardiogram. Okay. Now, one factor you said is coronary perfusion pressure. What is the second most important factor?
Oxygen content.
Oxygen content. Yes, very good. So in the oxygen content, what is the most important factor?
Hemoglobin levels.
Hemoglobin is the most important factor, isn't it? So other things like saturation, yes, majority of the times, as long as you maintain above 94-95% saturation, there's absolutely no problem. 1.34 is a constant, because 1 gram of hemoglobin will carry 1.34 ml. And as long as the PaO2 is above 100, so the insignificant amount of dissolved oxygen is also there. Isn't it? It's more important here is the most important factor that can change during surgery is the hemoglobin, or preoperatively also it is hemoglobin. So that's why hemoglobin estimation is very, very important. Now, another common question you can be asked is that transfusion trigger based on hemoglobin. So suppose in a ischemic heart disease patient, what is the transfusion trigger before surgery?
8 milligrams.
Grams, not milligrams.
8 grams. 8 grams.
Yeah, it is 8 grams only. For a patient who is not having any ischemic heart disease, what is the transfusion?
10.
No. If the patient doesn't have
7.
Yeah, it can be 7 or even less than 7, depending on the clinical symptoms the patient has. So 8 grams is definitely the transfusion trigger for geriatric patients, for ischemic heart disease patients, valvular heart disease, any cardiac patients, respiratory disease patients, and patients in the ICU also, critically ill patients. So transfusion trigger based on hemoglobin only. Actually, you should not go only with hemoglobin. You have to go with the clinical symptoms also. It is 8 grams. Intraoperatively, what is the transfusion trigger?
10
It is
grams.
8 grams. Because suddenly if the patient starts bleeding, if you can have a method of knowing what is the hemoglobin level, can you check non-invasively the hemoglobin levels? Continuous hemoglobin estimation intraoperatively.
Plethysmographic.
Yeah, no, we have Massimo pulse oximeters. So Massimo pulse oximeters continuously they'll be giving what is the hemoglobin levels also. Based on that, that's how once they started using Massimo pulse oximeters for hemoglobin estimation, the number of blood transfusions intraoperatively have come down drastically, because you will wait till 8 grams of hemoglobin production occurs. Otherwise, by just visual estimation, we used to give blood transfusion. So the problems associated with blood transfusion intraoperatively, isn't it? So that's how the hemoglobin estimation is very important. And then in a patient with ischemic heart disease, hemoglobin level is very, very important. So because it is the one which is carrying oxygen, and any abnormal hemoglobins definitely will bring down the amount of oxygen that is carried. Like in a patient who is smoker, carboxyhemoglobin level, if it is more functioning hemoglobin that is carrying oxygen will come down. Okay, it is not just the hemoglobin, it's a functioning hemoglobin, which is very, very important in such patients. And again, it's very important for you not to hyperventilate the patient during anesthesia. If you hyperventilate, you're going to produce hypocarbia, and hypocarbia is going to shift the OD curve to the left. And though the hemoglobin is normal, but the amount of oxygen also it is carried by is normal, but it cannot release to the tissues. The affinity of hemoglobin to oxygen will increase if the OD curve shifts to the left, isn't it? So these are the very important points regarding hemoglobin and oxygen content. Okay, can you increase the oxygen content intraoperatively if the patient develops any problems of ischemia?
If you have to increase the flow, sir. Oxygen content, because myocardium
how do you increase the oxygen content? Content I'm asking, I'm not asking about the oxygen flux or DO2. DO2 depends on the cardiac output. How do you increase the oxygen content? By increasing FiO2. By increasing FiO2, you are going to increase the PaO2. When you increase the PaO2, you are going to increase the oxygen carried in the form of dissolved content. Dissolved oxygen content you are going to increase again based on Henry's law, isn't it? So these are all very important, these gas laws when you attend an exam. Suddenly you may be asked, okay, what law as far as solubility of a gas in a solvent? It is directly proportional to the partial pressure, that is Henry's law. Okay, so you can definitely increase. That's why sometimes when you are asked about myocardial ischemia, how do you manage? You'll say that I'll increase the FiO2. So why FiO2? How it's going to increase the oxygen content? It is going to increase the oxygen content by increasing the dissolved oxygen content, which is again a part of oxygen content. Okay, it will not increase the oxygen carried by hemoglobin, mind you, increased FiO2. Okay, now that is the second factor. What is the third factor? Heart rate. Factors influencing the supply. Why again we know the heart rate is important as far as the supply to the myocardium.
So as the heart rate increases, there will be reduced diastolic filling time.
Yes, very good.
So that leads to again fall in the pressure, and there will be
diastolic filling time means diastolic filling of what?
Ventricle filling, sir.
It's not ventricle. That is in mitral stenosis, isn't it? Diastolic period is very important because during diastole the myocardium gets supplied. That is what you have to be very clear in the ischemic heart disease patient and in a valvular heart disease patient, MS patient. In MS patient, you require good amount of diastolic period because the left ventricle gets filled from the left atrium during diastole. Whereas in ischemic heart disease patients, because only during diastole, already we discussed, only during diastole the myocardium gets supplied. So that is the reason why you have to have a sufficient time for diastole. So any increase in heart rate decreases the diastolic period, decreases the time for diastolic filling of the myocardium. Okay, not the left ventricle. So that is again important. So you have to maintain the heart rate on the lower side. Ideal between 60 to 80 would be ideal. So any intraoperative tachycardia you have to avoid, and if it is there, you have to immediately bring back to the regular rate. So that is very, very important. Okay. Now that is the heart rate. Okay. Next is the caliber of the lumen of the coronaries, isn't it? The arterioles, coronary arterioles. So why that is important, Harish? Already there may be a narrowing of the arteries in these patients, isn't it? So if the artery, the diameter or the radius of the artery decreases, how does it affect the coronary blood flow?
As per the Hagen-Poiseuille's law, the flow is inversely proportional to directly proportional to the fourth power of radius.
It's very good.
If the radius is reduced by half, the flow will going to reduce by 16 times.
So that is why the caliber of the aortic vessel is very important. That's why whenever there is stenosis, when they do an angiography and then they find out more than 70%, they do a stenting, isn't it, to increase the diameter or increase the radius so that the flow increases. So how you can produce problems for the patient by narrowing the lumen intraoperatively?
If we are hyperventilating, they can cause hypocapnia, it can cause coronary spasm.
Yeah, any hypocapnia, it is always like that. Any hypercapnia will dilate. Any hypocapnia will constrict. This is for all the vessels except pulmonary vessels. Pulmonary vessels opposite occurs. Hypercapnia constriction, hypocapnia dilatation, isn't it? So here, if you produce hypocapnia by hyperventilating the patient, you're going to reduce the caliber of the lumen of the coronaries. You can produce ischemia. So that's why never hyperventilate. Can you hypoventilate?
No, sir. Hypoxemia again.
The next question can be, can you hypoventilate these patients? Because hypoventilation, hypercarbia will produce dilatation of the coronaries.
Hypoxemia again causes...
No, I'm not talking about hypoxemia. We are talking about carbon dioxide. Hypoventilation means carbon dioxide level will increase. Ventilation and carbon dioxide are related. Always. You should always remember. Hyperventilation will reduce PaCO2. Hypoventilation will increase the PaCO2. So should I hypoventilate to produce coronary dilatation?
No.
Why not? What are the reasons why you should not hypoventilate also?
Will be reduction in oxygen carrying capacity.
No, but you can increase the FiO2 as long as, of course, as you said, that alveolar partial pressure of oxygen is always, in proportion to the PaCO2, isn't it? If PaCO2 increases, alveolar partial pressure can come down. But if you increase the PiO2 or the FiO2 when you are using, so that problem can be managed. But any hypercarbia will produce sympathetic stimulation.
Yes.
And any sympathetic stimulation will increase the myocardial contractility, increase the demand, increases the heart rate, decreases the oxygen supply. So, and also the myocardium will be prone to produce dysrhythmias. Any hypercarbia. There can be multiple problems associated with hypercarbia. So, no hypoventilation, no hyperventilation. So, maintain normoventilation and maintain normocarbia. That is the dictum in all these patients with any patient with ischemic heart disease or any other problems. Okay, so these are the factors which influence the supply. So what are the factors which influence the demand?
Tachycardia, sir. Wall tension.
Yeah, first is left ventricular wall tension.
Wall tension.
Isn't it? So based on what law?
Weierstrass's Laplace.
Laplace law. What does it? What does Laplace say?
Laplace law states that the wall tension is directly proportional to pressure and radius and inversely proportional to thickness.
Yeah, thickness. It is inversely proportional to thickness. That's why whenever there is increase in the afterload, in order to decrease the tension, the wall hypertrophies. Hypertrophy of the left ventricle is a compensatory mechanism that you should always remember about. Because once it hypertrophies, it's going to reduce the tension. So once the tension is decreased, the myocardial oxygen demand decreases. But here, what is more important is the pressure, the left ventricular endostolic pressure during diastole and the systolic pressure during systole. If these pressures are high, then the wall tension will be high, isn't it? So this you have to maintain. So that's why any increase in myocardial any increase in left ventricular endostolic pressure or any increase in the afterload can produce increase in the wall tension, can increase the demand. So there can be an imbalance between supply demand. Okay, so that is another very important thing. So the next thing, as you said, is the myocardial contractility. Again, increased myocardial contractility increases the demand, and any increased demand, again, supply may not meet, so imbalance. So you should not allow the myocardial contractility to increase. Slight myocardial depression is still better, like you are giving the beta blockers. So beta blockers not only reduce the heart rate, they also will produce myocardial depression, thereby they improve the supply, they decrease the demand, isn't it? So third is again the heart rate. So any increase in heart rate is going to increase the myocardial contractility, isn't it? What is that effect called as?
Bowditch effect.
Bowditch effect or Treppe effect or staircase effect. Intracellular calcium levels will increase because of the increase in heart rate. Myocardial contractility increases. So that is again, so heart rate is the most important thing in a ischemic heart disease patient. Heart rate is there as a factor in the supply. Heart rate is there as a factor in the demand. As long as you keep the heart rate between 60 to 80, so absolutely fine. The demand is decreased, supply is improved, so imbalance definitely can be managed. Okay, so because these factors which influence supply and demand are very important, these can be our goals also in managing these ischemic heart disease patients. Okay, now coming to the other investigations. So any doubts regarding these supply and demand factors? Invariably will be asked.
Sir, will preload come in demand, sir? Excessive preload?
No, unnecessary increase, unnecessarily if you are giving preload. Nowadays, we don't preload the patients, isn't it?
Yes.
Because we co-load the patient, and preloading is not required nowadays because you are giving clear fluids till 2 hours before surgery. Why we used to preload these patients is because many times they used to be empty stomach without even water for 8 to 10 hours. So by the time they are brought to the surgery, they would be coming with a hypovolemic state. That is why routinely we used to preload the patients. So now preloading has got no role because all these patients can be given oral fluids till 2 hours before surgery, clear fluids till 2 hours before surgery. They come with euvolemic state. There is no role for preloading. And unnecessary preloading in these patients to be avoided because it is going to increase the left ventricular endostolic volume, pressure, and effects on perfusion. So can we go for other investigations?
Yes.
Yeah.
Next, WBC count, sir.
Okay.
To know she is undergoing infection.
Like so not much of an indicated thing here. Okay, right.
Platelet count.
Yes, very good.
Because she is on antiplatelet. She is on antiplatelet drugs. So we have to know the value.
So this is again a common mistake every student will do in the exam. So they say the patient is an antiplatelet drug. That's why I want to do a platelet count. Antiplatelet drugs do not have any effect as far as the platelet count is concerned. Okay. It's the quantity will not alter. It is a quality. It is a quality of platelets is affected. So there is no point in doing a platelet count thinking that platelet count will decrease in patients on antiplatelet drugs. No. Just remember that. Okay. So, but platelet count is important. Is suppose if these patients are on heparin. So we'll come to that anticoagulant drugs. If the patient is on heparin, definitely, heparin-induced thrombocytopenia is one of the problems. Or any other condition where you think that the platelets may be reduced, like idiopathic thrombocytopenia, any of the problems like, or in pregnant patients with preeclampsia, HELP syndrome. So all those patients, definitely platelet count is very, very important. Otherwise, as such, may not be very important, but routinely you'll be doing platelet count, but not for patient is on antiplatelet drugs, right? Okay. So you can show your investigations you have already got. Okay, you can actually go through that. So platelet count in this patient is normal, so no problem, but still the patient will have problems because the quality is having a problem. So for quality, to know the quality of platelets, any tests are there? Yeah, definitely thromboelastogram, proto, the other the platelet functioning tests are there, can do, but they are not very, very specific for this also. You can't just say that, okay, I'll do this test and then go for, if the test is normal, I'll go for a central axial block. No, it is better not to go for central axial block if the patient has an antiplatelet drugs like clopidogrel, unless you have stopped it. No Rotem, no TEC. Okay.
Blood group.
Right.
Blood
Other
grouping.
investigations.
Blood grouping.
Yeah, grouping is very important in all patients. And if you think that the patient is going to have a bleeding which is in excess of maximal allowable blood loss, you have to do cross matching and arrange for partials as well. So in this patient, you don't expect that. No problem.
Yes.
Renal function test.
Then again, you have written RBS. So no RBS.
Okay.
RBS is only at the point of taking out the blood, whatever the blood sugar you are getting, it is random blood sugar. What you do intraoperatively is RBS. Intraoperatively, you want to check point of care, glucometer you will be checking, that is random blood sugars. But either you go for fasting blood sugar or postprandial blood sugar, best would be FBS, or you can, even in diabetics, you can go for HbA1c also. So don't say random blood sugar. It's a no. Suppose, let us say this random blood sugar has been done when the patient is fasting. So it is high, isn't it? Anything above 100 is now we consider it as high fasting blood sugar. So that doesn't give you much information. Okay. Then serum creatinine, again important. So why, Harish, serum creatinine is important in a patient with ischemic heart disease?
They can have renal involvement as well,
long-standing
renal
hypertension.
involvement.
Hypertension and long-standing hypertension can be secondary to, it can cause ischemic heart disease as well as the renal impairment. And my patient.
Have you heard about cardiorenal syndrome?
Yes.
What is cardiorenal syndrome? Have you heard about it, cardiorenal syndrome or not?
We have heard, sir.
No, whenever there is a kidney disease, heart can get involved. Whenever there is a heart disease, kidney get involved. So there is always an interaction between the heart and the kidney. So this is what is called as cardiorenal syndrome. So there are 5 types of cardiorenal syndrome. So type 1 is basically an acute cardiac condition producing an acute kidney problem, like even acute renal failure. That is type 1. Type 2 is chronic cardiac disease, produce a chronic kidney disease, a CKD. Chronic heart disease, like in these patients with severe ischemic heart disease, left ventricular failure, they can also have a CKD. Then the third is, acute kidney condition producing an acute cardiac problem. That is type 3. Type 4 cardiorenal syndrome is chronic kidney disease producing cardiac problem. We know that CKD is going to produce heart problem also, like accelerated atherosclerosis, ischemic heart disease. All those things are very common, hypertension, all those. And type 5 is other diseases producing involvement of both kidneys as well as the heart, like rheumatoid arthritis, a collagen disorder. So that is type 5 cardiorenal syndrome. So cardiorenal syndrome can be there. So these patients may have renal involvement also, plus hypertensive patient, as I said, nephropathy is important. And another very important thing here is, serum creatinine is one of the factors in case of RCRI, revised cardiac risk index. If there is any increased creatinine of more than 2, you say it is one of the factors. The patient will score 1 point, isn't it? So very important thing as far as the cardiac index is concerned, isn't it? So that's why this you do. And what is the other problem? Suppose if the creatinine is increased, what do you expect the fluid status of the patient?
They can be overloaded.
Already there can be overload. And you have to be extremely cautious with how much of intraoperative and postoperative fluids you'll be giving. If you just give slightly higher dose, the patient can end up with pulmonary edema, isn't it? So that's how creatinine is a very important test. Fortunately, in this patient, it is normal. Okay. Then
Serum
what are the
electrolytes.
other tests?
Serum electrolytes.
Right, serum electrolytes. So you always have a basal serum electrolytes in these patients. It is very important, and especially in patients on already we discussed SE inhibitors, ARBs, diuretics, and digoxin patients on digoxin. So and also patients, respiratory disease patients who are on inhalational beta 2 agonists. Again, that can push the potassium into the cell. Again, you do potassium levels. Okay, then other investigations.
Coagulation profile.
Coagulation profile is very important. Routinely, you can definitely do, and especially in which kind of patients you always, it is an indicated test. Coagulation profile may not be a routine test, indicated test. What are the indications for doing coagulation profile like PT, INR, APTT, and platelet count?
Liver disease.
Yeah, patients with liver disorders.
Yes.
Is it only for obstructive liver disorders or intrahepatic liver disorders?
Intrahepatic.
Both.
Obstructive.
Both. Obstructive, again, you have vitamin K deficiency. So vitamin K dependent coagulation factors will not be sufficient. So in liver disease itself, the production of procoagulants is deficient. Okay, that is one condition where you have to do coagulation profile. Any other thing?
Patients who are on anticoagulants.
Yeah, patients on anticoagulants, isn't it? So if the patient is on anticoagulant, you always go for, and when to stop and all depends on your prothrombin time or APTT, whether oral anticoagulants or on heparin, isn't it? So only probably these are the conditions where the coagulation profile is definitely indicated, but majority of the times we'll be routinely doing the coagulation profile. Okay. Thus, many times one problem again with the students is they'll say patient is on antiplatelet drugs. That's the reason why I want to do a coagulation profile. Do you agree with that or not? Antiplatelet drugs and coagulation profile. Will there be any alteration in APTT or even PT or INR with antiplatelet drugs?
No.
There won't be anything. So this is one common mistake every student does in the exam. They say that patient is on antiplatelet drugs. That's the reason why I want to do a prothrombin time. There won't be any alteration in prothrombin time even if the patient is on antiplatelet drugs. This is, again, you should always remember about. Okay.
Next, ECG, sir.
Okay, ECG is very important, an indicated test, right? So what do you expect in ECG in these patients? What are the things you look for?
We look for rate rhythm.
Yes. So you want to rule out any abnormal rhythms, isn't it? Especially atrial fibrillation, right?
And any changes in waves, like T wave inversion, Q wave, pathological
No,
Q wave.
before T wave, you have QRS also.
Yes.
You have the PR interval also, isn't it? Because degenerative changes and because of the ischemia, very common in these patients, you may have a prolonged PR interval. You may have a first degree AV block, isn't it? So that is why, and again in the rhythm, you have to rule out these second degree AV block or even third degree AV block. Okay, that is
premature beats.
Yeah, premature beats. QRS complex, widening of the QRS. Look for, ischemic heart disease can produce Van der Blaan blocks, isn't it? So because coronary supply is very important for these bundles. So any decreased supply suddenly, these patients can go for bundle branch block. Either it can be RBBB or LBBB, or even hemiblocks can be there. So whenever there is an RBBB or LBBB, you can find widening of the QRS. What is the normal QRS width?
0.112.
0.08 to 0.12.
0.12.
Yeah. So if there is any increase more than 0.12, say either RBBB or LBBB, you look at the V1, V2. If there are tall R waves, then it is RBBB. If deep S waves are there in V1 and V2, it is LBBB. Very easy to know RBBB or LBB. Then you go for STT wave changes. Okay. So where exactly you measure depression or elevation?
At the J point.
Is it from the J point or 0.08 seconds from the J point? The measuring point is 2 small squares from the J point. It is not at the J point. So it is again crucial. So, and again, if it is a flattened ST or downsloping ST, they are significant for ischemia. If it is only J point depression, upsloping ST is there, it may not be very significant for ischemia. So ST elevation is again significant, isn't it? Unless there is early repolarization, which also elevates the J point. So if there is no J point elevation, if there is only elevation with oving or convexity upwards, so definitely it is very significant for the myocardial ischemia or infarction. So STT wave changes you look for. In the QT interval also you measure, because any prolonged QT, some of your drugs can produce intraoperative dysrhythmias, especially torsades de pointes, which you should be very careful about in these patients with ischemic heart disease. Okay, so if there is a previous infarction, a transmural infarction,
Pathological Q waves.
Yeah, pathological Q wave can be there. When do you say it's a pathological Q wave? One is width and the depth.
Okay.
So width should be more than 1 small square. That is 1 millimeter. It should be more than 1 millimeter. Depth should be more than 1/3 of the succeeding R wave. You have a Q wave next R wave, isn't it? Yes. So if the Q wave depth is more than 1/3 of the succeeding R wave, then it is significant, a pathological Q wave. So if pathological Q waves are there without much of STT wave changes, then you say it's a old infarction. If pathological Q wave is there with ST elevation or ST depression, then it can be even a fresh transmural infarction. Okay, right. That's about ECG. So suppose if this ECG is normal, the patient is complaining of chest pain, would you like to do any other investigation?
Stress cardiac.
Yeah, stress ECG you can also do, isn't it? A treadmill test you can do. So what are the indications for TMT in these patients?
To identify the patient has any ischemic heart disease.
Inducible ischemia. Suppose the patient is complaining of chest pain, but you are not sure whether it is due to cardiac origin or non-cardiac origin. To diagnose whether the patient has a cardiac origin, that is angina, so inducible ischemia is there. So you have to do a stress ECG, ideal. But suppose the stress ECG, you want to get it done, what are the important points for you as anesthesiologist?
Sir,
so why do you want to get a stress ECG for managing this patient intraoperatively and perioperatively?
So intraoperative period is stressful.
Okay.
So we want to.
Let us say the patient has already been diagnosed with ischemic heart disease. You need not have to do a stress ECG to diagnose.
There can be fresh new onset myocardial infarction. The patient is having chest pain.
To what heart rate the stress can be sustained by the heart? So we'll get to know intraoperatively if that what heart rate to be maintained. So that's why.
Very good, very good. So what is that called as rate pressure product?
Yes, rate product.
Rate pressure product at which the patient has developed ischemia. There, when you are doing a stress ECG, is very important for us. So why rate pressure product is important? It is a systolic pressure is important because by systolic pressure, you know the myocardial contractility, isn't it? The systolic pressure is basically because of the myocardial contractility. Higher the myocardial contractility, higher will be the systolic pressure. So if the systolic pressure is increasing, now you know that this contractility is increasing. So it has to increase because the cardiac output has to increase because the DO2 has to increase to meet the increased oxygen requirement during exercise, isn't it? Then the heart rate also has to increase the cardiac output. Now heart rate is there both for demand and supply. Okay. Now systolic pressure, indirectly, you know the myocardial contractility. So when you have a rate pressure product, and what rate pressure product the patient is developing inducible ischemia, as long as you prevent this rate pressure product to cross intraoperatively, because patient may be under anesthesia, so you know that you are not going to produce myocardial ischemia. That is why, as an anesthesiologist, it is very important to check for the rate pressure product at which inducible ischemia has occurred. So again, here, one thing you should realize that suppose the systolic pressure is decreasing, heart rate is increasing, then again the rate pressure product can be lesser than whatever the rate pressure product the patient has developed ischemia, isn't it? So, but this is dangerous. Rate should never go beyond the pressures. So that's why as long as the rate pressure ratio is less than 1 and the rate pressure product is less than that particular rate at which the patient rate pressure product at which the patient has developed myocardial ischemia, is important for us to manage this patient intraoperatively. Okay, that is one thing. One more thing is, suppose you don't know exactly, the patient is giving vague answers as far as meds are concerned. So when actually you are subjecting the patient for the exercise ECG or stress ECG, you are also getting in the report what is the meds the patient has could do without developing inducible ischemia. So you indirectly, you know, what is the reserve capacity or functional capacity of the patient. So these are the important findings for stress ECG, but there are limitations for these, isn't it? So in a patient whose functional capacity is very poor, can you subject him for stress ECG? No. If the patient is on a beta blocker, can you subject him for stress ECG? Because in stress ECG, you also have to go for a target heart rate, isn't it? Once the patient reaches the target heart rate, usually they stop the Bruce. It is there in the Bruce protocol. Usually they stop the patient exercising, and then they'll check for whether there is inducible ischemia is there or not. How do you calculate the target heart rate?
220 minus the age of patient. We target 80%.
Minus age in years, 85% of it. If he achieves, that is fine. So if the patient achieves this with the minimal meds, then you know that it's a sign of inducible ischemia. Or the patient is not able to achieve that, the target heart rate, it is a sign of inducible ischemia. Or the systolic pressure should increase. Just now we discussed, if the systolic pressure starts falling because the myocardium is not able to sustain this amount of exercise, it is a sign of inducible ischemia. So other than ST wave changes, isn't it? ST, if there is any decrease by more than 1 millimeter, other than V2, V3 expect more than 2 millimeters for saying that patient has got an inducible ischemia. So these are some of the things which are very important for about inducible ischemia. So if a patient is not able to do this exercise, you cannot subject him. Second thing is, if the patient is on a beta blocker, he cannot reach the target heart rate. Third is, the patient is on a pacemaker. Again, many times he may not be able to reach the heart rate, isn't it? Suppose if he has got inhibited the pacemaker, then again it will not allow the heart rate to go beyond that particular maximum heart rate. So again, the patient cannot be subjected for this kind of stress ECG. So if the patient cannot do this, then what is the next alternative?
Go for stress cardiac.
Stress echo.
Yes.
Dobutamine stress echo. So that is also can be done. So why dobutamine is given?
It causes positive inotropic effect and positive chronotropic effect. So it is kind of inducing stress.
Yes, pharmacological stress, isn't it? It's also called as a pharmacological stress test. So that way, you know whether you will be continuously monitoring the regional wall motion abnormalities. Suppose suddenly if the regional wall motion abnormality starts with a particular heart rate, then you are observing there, then you know, isn't it? So that is also one of the tests that can be definitely done. And before that, an echocardiography also is very important, the resting echocardiography. What is the importance of resting echocardiography in these patients?
One will get to know all the chambers, are they dilated or no.
Okay.
The other thing we'll get to know the regional wall abnormality motion, any segmental had and that.
Right.
And we'll get to know is there any pulmonary arterial hypertension.
Okay.
And we'll get to know left ejection fraction, that is left ventricular systolic function.
Yes.
And also diastolic function.
Yes. And also thickness of the wall.
Yeah.
And then the valves.
Yes.
Isn't it? Can this patient develop a valvular problem also, ischemic heart disease patients after myocardial infarction?
Yes.
Most common valvular heart disease?
Mitral regurgitation.
Mitral regurgitation. A pansystolic murmur can be heard also, isn't it? So these are some of the things. And again, ejection fraction is important in this to know whether the patient has got a low ejection fraction or he has got a preserved ejection fraction. That's why sometimes this heart failure, left ventricular failure, is usually classified as heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So when these patients with heart failure with reduced ejection fraction, they have a higher risk of developing MACE rather than patients with the failure with preserved ejection fraction, that is a diastolic dysfunction. Patients with the preserved ejection fraction have got a good systolic function but poor diastolic function. That's why they have gone in for failure, isn't it? These are the patients are have less incidence of MACE when compared to patients with poor or reduced ejection fraction. So all these things you can definitely make out from just a resting echocardiography. Plus, if these patients have a poor left ventricular function, ejection fraction is low, these patients also can develop a left ventricular thrombus, isn't it? And which is very important to know about. If a patient has a left ventricular thrombus, again, patients may have to be put on anticoagulants, and you don't take up these patients for elective procedures. That's why resting echocardiography is also, transthoracic echo also is very important. Okay. Any other investigation to check for any inducible ischemia, which is more sensitive?
Dipyridamole thallium scan.
Yeah, perfusion scans. It is called as coronary perfusion scans. So dipyridamole, or nowadays dipyridamole is not being used, adenosine. You are going to produce a steel in the coronaries, isn't it? So you are going to check for how much suddenly after giving adenosine, the thallium which was there is now suddenly missing from there, because it is taken away from the ischemic zones to the normal zones, isn't it? The films you are taking before injecting adenosine, and also you are going to take films after injecting adenosine, how much defects occur. These are the defects which are the ones which are going in for ischemia, inducible ischemia. So all these tests, especially in pharmacological tests or perfusion testing, have got a high negative predictive value. That means if nothing is there, everything is fine, no ischemia is there, usually the patients will not have any problems intraoperatively. But they have a low positive predictive value. Suppose if they are low, the stress test is positive, you don't think that all these patients will develop definitely MACE. They may or may not do. But if they have negative for these tests, usually high negative predictive value. So this is another very important thing you should also know about. Okay, any other tests you want to do? Any biomarkers?
Yes, troponin and the creatine kinase MB enzyme.
So usually troponin, if you want to know about basal biomarkers, ideal would be TROP3 and TROP-I, isn't it? Instead of CPK-MB, so you always go for cardio-specific troponins. So you want to check whether, suppose if the patient develops intraoperatively or postoperatively any myocardial ischemia or infarction. So unless you know the basal values, you can definitely know any increase is there, isn't it? So that's why trop T and trop I can be there. In patients who have got sustained myocardial ischemia or even in failure, any other biomarker you would like to go for?
NT-proBNP.
Yeah, that is again NT-proBNP. BNP or NT-proBNP in all these patients. Why BNP will increase? What is full form of BNP?
Brain natriuretic peptide.
Yeah, brain natriuretic peptide. So why it will increase in patients with myocardial ischemia or failure, right heart failure or left heart failure?
It is a
So any failure, what happens to the tension inside the cavity?
increases.
Increases. Whenever the tension increases, the myocytes, cardiomyocytes will secrete the BNP. Because what is the role of BNP?
Causes natriuresis.
Natriuresis, isn't it? So, and also fluid,
Yes.
along with sodium. So, you know, in cardiac failure patients, you have excess amount of fluid. So it is a protective mechanism by the cardiomyocytes to release the BNP so that it can reduce the volume status of the patient so that the cardiac failure can be decreased. So that's how BNP increases. So that's how when you do these BNP levels, so you can know that which patient is like already having a cardiac failure or likely to go for failure intraoperatively or postoperatively. So that's why now one can do in all these severe ischemic heart disease patients, definitely you can go for BNP and NT-proBNP. What should be the levels, normal levels?
Less than
For
1500.
which you say that it's fine.
Less than 1500.
1500 is very high.
1000.
It's very high, especially for
Less than 500.
Hello, Gurudatt sir.
Hello. Okay, sir, ours is coming.
Sir, I guess Gurudatt sir's internet is freezed. Azam sir, you're on mute.
Yeah, I'll just call him.
Okay.
I'll call him. You're on mute, sir. You're on mute, sir.
okay, fine. Sorry for this thing.
No, sir. No, sir. No
So
problem.
now, Azam,
Sir.
now we have completed the investigations.
Yes, sir.
So what should we do? It is 12 o'clock. We have already spent 2 hours. Should we have one more session?
Yeah, sir. I
Mainly
don't mind,
for
sir.
managing the patients.
Yes, sir. Mahesh, is that okay with you? And Mansa?
Yes, sir. When can we have it, sir?
Whenever, sir, is.
No, I am fine anytime.
Tomorrow we can have, sir, continuation.
Yeah, tomorrow evening 6 to 7:30.
Yes, sir. Yes, sir. That will be excellent, sir.
Okay,
Sorry,
because,
sir. Sorry,
Today,
sir.
Sunday, August 15th, already 2
Sorry.
hours.
I'm
So
sorry,
no
sir.
problem. No, not for me, because many of the students, you know, Sunday they want to celebrate this
Yes,
thing.
yes,
Also,
sir.
2 hours we have spent. So
Yes.
you just check for any chats are there. Any
Yes, sir.
questions are
There are few questions. Can I take it, sir?
Yes.
Okay. One is Suchetan Pramanik. Sir, can you tell us about the coronary steel phenomenon?
Yeah, coronary steel, you know that what happens in ischemic heart disease patients, the coronaries which are narrowed are supplying the ischemic zone. And these coronaries are maximally dilated because body tries to push maximum amount of blood flow and maximum amount of oxygen to these ischemic zones. So these coronaries supplying the ischemic zones are maximally dilated. They cannot dilate further. So when you give a drug which can produce vasodilatation of the normal vessels like adenosine or dipyridamole or even our isoflurane, so what will happen is the coronaries, the normal coronaries which are not affected by atherosclerosis, they suddenly get dilated. And because of this, the blood gets diverted from the ischemic zones to the normal zones. So the ischemic zones become more ischemic. And because their oxygen has been stolen to normal areas. And this is called as steel phenomenon.
Thank you, sir.
And there is something called as a reverse steel phenomenon for brain. That is also called as Robin Hood phenomenon. So if we discuss CNS, I'll talk to you about reverse steel also.
Yes, sir. Thank you, sir. Shweta, Dr. Shweta K. I think, sir, that formula that you mentioned for calculating tidal volume based on the height.
So it is the optimum height for calculating the tidal volume for males is equal to 50 plus 2.3 multiplied by height in inches minus 60. I'll repeat again, 50 plus 2.3 multiply in brackets height in inches minus 60. Suppose the patient is about 5'6". That means 5 feet 6 inches. That means he is 66 inches, a male patient. So 66 minus 60 is 6 inches. 6 multiplied by 2.3. So that will be somewhere about 8 it comes plus 50. So you have to calculate for 58 kgs. Same thing for females. Instead of 50, you make it 45. That's all the difference.
Yes, sir.
So this formula you use whenever you put a patient on mechanical ventilation, whether it is an ICU, whether it is an anesthesia.
Yes, sir. Thank you, sir. I think, sir, this question maybe we can take tomorrow by Dr. Rati. Sir, what is the cutoff level based on the platelet count on epidural or spinal, should be given? So we can discuss.
Yeah, tomorrow we can have, no problem.
Sir, other thing, even this, I think we can take, continuation with that same question. What is graded epidural and what is the right way to answer in the exam? And
tomorrow we will discuss about that. Anyway, we'll be discussing about that.
Yes, sir. How to measure the platelet function bedside when Dr. Muthu Rajgopalan, sir. How to measure the platelet function bedside when there is no specific tool for that, like TEG we don't have. Can we rely on BT and CT?
We can definitely go for bleeding time, but unless you do it properly, bleeding time, then only you can know. Otherwise, very difficult. Proper method of doing a bleeding time is you should know that how much of incision you have to place. You have to have an incision of 2 to 3 millimeter length and 1 millimeter depth over the volar surface of the hand or the ear lobule.
Okay.
So, and then you have to use a paper to be kept at the edge of the wound, not touching the wound, because if you touch the wound with a paper, that will produce coagulation. So at the edge of the wound, so that continuously the blood is being absorbed, and you record the time from the time of incision till bleeding stops. So this is the correct method of doing a bleeding time. So if you can do this correctly, you can use it.
Thank you, sir. Same by Muthu Kumar Rajgopalan. One more question is, what is the least hemoglobin level can we accept for surgeries in case of an emergency, sir? But in patients with ischemic heart disease.
So ischemic heart disease, again, 8 grams.
8 grams. Suppose
say if it is less than 8 grams, better to, it is that's what I told you, that it is the transfusion trigger. Yeah. If it is less than 8 grams, these patients may require preoperative packed cells, and then you can take up.
Yes.
So for that, again, you have to know each packed cell will increase the hemoglobin level by how much. That you should always know. So because each packed cell is roughly 300 ml. And the each packed cell 100 ml, the hematocrit is 60. That means 20 grams is the hemoglobin. So suppose if I give one packed cells of 300 ml, you are going to give 60 grams of hemoglobin. So now you should know about the cardiac output, blood volume of the patient. Blood volume is based on, in males it is 70 ml per kg body weight, in females it is 65 ml per kg body weight. Let us say that the blood volume is 5000 ml. So 5000 ml I have increased 60 grams because I've added this 60 grams into the blood, isn't it? So for 5000 ml of the blood volume, I have added 60 grams by giving one packed cells, that is 300 ml. Each 100 ml containing 20 grams of hemoglobin. So 60 grams I am giving. So for 100 ml, because hemoglobin is always calculated per 100 ml. So 100 divided by 5000 multiplied by 60. So if it will be roughly 1.2 grams. That's why in general, we always say, if you give one packed cell, you are going to increase the hemoglobin level by 1 gram. So, but it is based on the blood volume of the patient. Suppose the patient is only 50 kg weight, and if the patient is a male patient, the blood volume will be 3500. You are giving 60 grams, then 100 divided by 3500 multiplied by 60. So actually you may increase 2 grams. Isn't it? Many times my students do come to me and then tell me, sir, they have given 1 unit of packed cells and they are now getting 2 grams already increased. So how is it possible? So now you have to know exactly, this is how you calculate how much it will increase.
It's an excellent explanation, sir. Thank you so much.
I hope everybody has understood this, because it is important for us to know.
Yes.
You don't give in general, okay, I want to increase by 1 gram, I will give 1 packed cells. No.
It is always based on the body weight.
Blood volume.
Blood volume. Yes, sir. Thank you, sir. Dr. Saida Sana, sir, does diastolic dysfunction produce greater ejection fraction, like more than 80%?
No, it won't produce higher this thing. As long as the systolic function is good, it may produce definitely higher ejection fraction, but not to the extent of 80% also.
Yes, sir. And Dr. Eruka Mani, sir, regarding ST depression and its duration, intraoperatively and postoperatively, are there any criteria?
No, we'll discuss that intraoperative myocardial ischemia tomorrow.
Yes, sir. And Satish, Dr. Satish, can we use intravenous beta blockers to control the heart rate in a patient with low ejection fraction of 30? Is esmolol preferable, sir?
So that we will again discuss tomorrow anyway, intraoperatively in patients with.
I think
definitely you can.
Yeah, sir. I think with this we have come to the end of questions. And sir, if I'm not wrong, the beta blocker study was it was stopped in between because of the lot of side effects, and the study was called off, if I'm not wrong, sir.
The POISE trial they completed. 2004 to 2008, POISE 1 trial they completed. And POISE 2 trial also, I did not mention, that is regarding aspirin and clonidine.
Yes, sir.
That is the POISE 2 trial. Now, whether to continue aspirin if the patient is already on aspirin, or if the patient is not on alpha-2 agonist, should we start alpha-2 agonist on the day of surgery? So that is POISE 2 trial. It was from 2010 to 2014.
Okay.
So what they found is aspirin, if the patient is on aspirin, you continue. And again, check if the patient is going to bleed a lot. That's what I said. And then you can even stop aspirin, because it did not reduce the incidence of MACE much. Of course, it reduced the incidence of stroke, but it did not reduce the incidence of major adverse cardiac events. So the patient is already on aspirin, you continue. If the patient is not on aspirin, don't start aspirin on the day of surgery.
Okay, sir.
That is the inference. Again, for alpha-2 agonists, if the patient is, they have found out that alpha-2 agonists, they used clonidine. So when they used clonidine, the number of incidences of MACE definitely came down, but there was too many incidences of hypotension, refractory hypotension. That's why they say that if the patient is not on clonidine, do not start the patient on alpha-2 agonist on the day of surgery.
Yes, sir. Sir, two questions have cropped up. I think one is we can discuss this tomorrow, Dr. Muthukumar. Sir, can you please explain pharmacological preconditioning by anesthetic drugs? Maybe tomorrow we can do that. Sir.
Tomorrow is because inhalation anesthetic agents produce preconditioning.
And Dr. Kirtana Hariprasad, sir, ideal time to transfuse blood if hemoglobin is more than 8 grams in IHD? I'm not sure what she's trying to ask, but as far as I understand, his transfusion trigger is 8 grams.
8 grams.
So 8 and below 8, you will transfuse the blood.
Yeah, in patients with cardiac disease.
Cardiac disease, yes.
Cardiac disease, geriatric patients, and critically ill patients.
Yes, sir.
And again, it is said that you always go with the symptoms of the patients. It is not just the hemoglobin should not be the only criteria as the transfusion trigger. So many of the patients we have seen 5 grams of hemoglobin without any cardiac disease, they may be asymptomatic. There is no point in unnecessarily giving them blood fat cell transfusion. Most of them may have nutritional problems. Iron deficiency is very common.
Yes,
you give them iron parenterally or orally, within 1 month their hemoglobin will come up to about 8 or 9 grams. So no need to give unnecessarily. But if the same patient is clinically severely symptomatic, not even able to get up, the exercise tolerance has become very poor, such patients definitely you can go for transfusion. So two things you have to correlate, both hemoglobin levels as well as clinical symptoms.
Yes, sir. Sure, sir. Thank you so much. Harish, do you have any doubts?
Yes.
Okay. Sir,
and I would like to appreciate both Vinod and Harish. They are excellent and they're answering majority of the questions.
Thank you,
they
sir.
are making my life very easy.
Thank you.
Thank you.
Hope
So
we'll continue.
There are about 350 participants. Sir, just before we log off today, one small thing from my side for them to understand. You have been an examiner for n number of years. So as an examiner, sir, what do you expect the students to, to behave or to answer, or what is expected from examiner point of view, sir? Just a couple of words and we can call it up.
No, one thing I just want to tell about the students attending the practical exam is, the way they enter matters a lot. Because I still remember one examiner, as soon as the student entered, she started disliking her. As soon as the student entered, the way she entered, the way she, her movements. So that is what is very important. You slowly enter there, you wish the examiners, you stand there, don't pull the chair and then sit in front of the examiner. So your behavior, is very important in practical exam. Your marks, your failure or pass, because if the examiner doesn't like your behavior, your questions may be like, even the examiner himself may not be knowing the question because he need not have to answer, isn't it? But you have to answer. So
Correct.
That is why that is very important. Be polite with the examiner, wish him, and also, listen till the examiner completes the question. Don't try to answer before the examiner completes the question, because many of the students are in so much of hurry. So the question may be actually, when he completes it, may be entirely different answer may be there. They would have heard partially the half of the question they're trying to answer. So wait, you can even take some few seconds, don't take minutes, take some seconds, analyze the question, then, give the answer. And your answer should not be too long an answer. Answer to the point. So, and don't keep on explaining things and come to the answer at the last. Okay, answer to the point so that more questions can be asked and more answers you can give. Because I've seen many of the examiners, one examiner will be asking the question, another examiner will be noting down how many questions the student has been asked and how many answers he has been given. It is not that for one question, if you are taking or making the examiner to ask 10 questions, then you will get the marks of only one question being answered. So don't think that, okay, I've spent 10 minutes with the examiner, I've answered 10 questions. Probably the 10 questions are for getting your answer for one question. So that is another very important thing. So understand the question. And if you don't know, tell no, I don't know. There is absolutely no problem. Otherwise, the examiner gets stuck there. He'll not proceed with. if he's also sitting quiet and you are also sitting quiet, so you are spending precious time. So if you don't know, you just say no, no problem. Nobody will ask you to answer all the questions. You want to answer 50% of the questions to get 50% of the marks, but don't do blunders. That's all.
Thank you, sir. Thank you so much.
Okay.
My professor, Dr. Mallikarjun, I still remember, just to stimulate us to study more, used to tell us examination is very easy for the examiner. If I have to pass you, I will ask, what is your father's name? If I have to fail you, I'll ask, what is my father's name? It has stuck into my mind so much. Thanks to him, because of him, we have learned a lot. And thanks to you also, sir.
Yeah, correct. Sure.
Thank you so much, sir. So
there is one proverb is there. Any fool can ask a question. Only wise people can answer. So the examiners are always, don't think the examiners are fools, but it is just a problem. This thing is there.
No, sir, not
Any fool can ask a question, isn't it? But only wise people can answer. You always think you are a wise person there and try to answer.
Correct, sir. So, sir, tomorrow 6 to 7:30 only.
Yeah.
You can log in by
WhatsApp. Even we may finish earlier to 7:30. We'll try.
Yes, sir. No problem, sir. And a link will be sent.
So how do you spread this to people?
Sir, Mansa is going to send me a link, sir. So I will forward it to you, to everybody, all the groups. There is on Gurudatt sir's kids or something on the Telegram, sir. There is a group on Telegram called Gurudatt's kids. So
I don't know.
Yeah,
it's there.
I will put it on that group also, and so that it can go. It will go to 12,000. I don't know. I think 12 lakhs. I think, if I'm not mistaken, Mansa was mentioning a number of anesthesiologists that the brochure has gone to. So it will reach so many people.
So we'll have part 3 tomorrow evening.
Yes, sir. So I'll circulate that, sir. Sure. Thank you, sir.
Right.
Very kind of you, sir.
Right. Okay. Thank you, Dr. Azam, Dr. Vinod, and Dr. Harish. Thank you so much.
Thanks, Mansa and Mahesh, for your patience, and thank you so much.
Yeah.
Thank you, sir. I'll see you tomorrow, sir. I'll call you, sir. Thank you, sir. Vinod, tomorrow evening by 5:45. Right. Thank you. Good evening, everyone. Welcome back. And this is the part 3 of ischemic heart disease. This class was not supposed to be there. Thanks to Gurudatt sir for giving us another opportunity to finish the whole IHD ischemic heart disease in depth and in detail. So thank you so much, sir. And no amount of words or no amount of gratitude will the dedication that you have shown in teaching us or showing the way for the postgraduate students is something extraordinary, sir. So thank you so much once again. And thank you, Vinod and Harish, for your presentations. And at the end, Mr. Surendra is here, Mansa and Mahesh, thank you for your back-end support. We always look forward for your support. So Gurudatt sir, thank you so much once again. Really appreciate, we are lucky and not to forget, we had about 632 lives. And imagine, it's not the question of the number of students have logged in, it's not the thing, but 632 students have been benefited by your lecture and by your discussion, sir. So that is something, even out of that, even half of that also can answer whatever we could have discussed in the exams. I think that's will be passing with great marks. So thank you once again, Gurudatt sir. I look forward for your support, continual support. Thank you so much. And I'll hand over to you, sir. Thank you, sir.
Thank you, Dr. Azam, and thank you, Medinet, for this opportunity. Good evening, everybody. So we had the 2 classes of this, myocardial ischemic heart disease and anesthesia. Actually, the patient that was presented by Dr. Vinod and Dr. Harish was a 55-year-old female patient who is non-hypertensive and who has had a coronary artery revascularization procedure. Actually, she had a PTCA about a year back, and now she has an umbilical hernia. Actually, this umbilical hernia is an elective procedure. She has been posted for elective procedure. She is on metoprolol, and she's also on amlodipine, and also she is on aspirin and clopidogrel. Clopidogrel has been stopped about 7 days back, and she's still continuing aspirin. So we actually discussed everything about pre-anesthetic evaluation in detail. So because as I was telling in my previous classes also, in these patients with ischemic heart disease, almost 75 to 80% of your pre-anesthetic evaluation is by history. So history is very important, and the patient taking many of these drugs also very important. They can be on multiple drugs. Of course, these patients had only about 4 drugs. So everything we just discussed, and also we discussed about the investigations, what all the routine investigations that are done for a patient with ischemic heart disease. So that also we discussed, and in that we also discussed about some of the investigations which usually routinely may not be done, like coronary perfusion scanning also we discussed, and regular echo and stress echo also we discussed, dopamine stress echo, plus exercise induced ECG also, that is a Bruce protocol and treadmill test. So in detail we discussed about all these things. Because of that only we took nearly about 4.5 hours. So I just want to ask Harish and Vinod about any other test that is one of the gold standards probably to diagnose coronary artery disease, and also to know the extent of coronary artery disease that we have not discussed yet.
Angiogram.
Coronary
Angiogram.
Coronary angiography. So coronary angiography is supposed to be the gold standard, we all know. So it is the invasive test, and routinely we don't do. Routinely for patients who are probably in class, that is especially when we are checking for the number of risk factors and all. If they don't have many of the risk factors, we don't usually subject them for the angiography because it's an invasive procedure. Can we do any non-invasive angiography, Vinod and Harish? Is there any non-invasive coronary angiography can be done? Where the patient is not subjected for catheterization of the coronaries and all. Have you heard about CT angio, CT coronary angio? Yeah, that is a non-invasive test. Some of the patients also can be subjected because it doesn't carry any amount of risk that is involved. CT coronary angio. So in that, the many times the calcium scoring is done. So that also can be done. The original calcium scoring that was done by Augustine. So many of the time, even today, that Augustine scoring can be used. Of course, there are some revised calcium scoring also has been done, but just for the postgraduates, just to know, because you may be asked in the exam regarding CT angio and CT coronary angio and the calcium scoring. So how to know whether a patient has got a mild, moderate or severe risk, even intraoperatively or postoperatively, based on coronary angio, the calcium scoring. So any idea, Harish and regarding calcium scoring?
Yes.
So calcium scoring is usually, you can have either zero scoring. So zero scoring, usually the patients will not have any risk at all regarding perioperative MI or perioperative MACE, that is major adverse cardiac events. But if the patient has 1 to 100, that is called as a mild risk. So if it is 100 to 400, it is a moderate severe risk, and anything more than 400 calcium scoring, definitely the patient can have the higher risk, a very severe risk, you can say, isn't it? So that is one thing we could not discuss about. So that is also can be included. Angiography, invasive angiography is usually may not be advised, unless we will discuss that when we discuss about the how to optimize these patients, especially because coronary angiography can be done if you want to put a stent for these patients, isn't it? So otherwise, or even CABG before surgery. So that is for optimizing and which kind of patients require all these. So before going into the management of these patient optimization, risk stratification, and management, just let us, because one thing we did not discuss is the coronary circulation itself. So can either Vinod or Harish tell about the coronary circulation regarding the coronary arteries and how many arteries are there, what all the areas they supply, and what is the importance of knowing about coronary circulation? Because coronary circulation in theory also it can be given as 10 marks, anatomy and physiology of coronary circulation. So physiology, most of it already we discussed regarding the factors influencing the supply and demand. So anatomy also is very important. Just in brief, can you just tell about anatomy, Harish, of coronary circulation?
Coronary arteries are derived from the aorta, sir, arch of aorta, coronary sinus, basically. And they mainly
exactly they take origin. You should always say from the root of aorta.
Aorta.
Is it distal to the aortic valve or proximal to the aortic valve? Proximal to the aortic valve means it has to be inside the heart.
Yes, distal.
Distal to the aortic valve means immediately after the aortic valve.
Distal to the.
Yeah, again, this is very important. Why it's very important to know that the coronary ostia, that is the openings of the coronary vessels, they arise from the aorta, root of the aorta, just distal to the aortic valve. So why should you know about this? Already we have discussed regarding coronary perfusion pressure, isn't it? So it is the diastolic coronary aortic diastolic pressure which is very important. If it was arising within the heart, you would not have bothered about the aortic diastolic pressure, isn't it? So that is why you should know that they arise from just posterior to the valve leaflets. So how many valve leaflets are there for the aortic valve?
Two.
So yeah, you see, this is what happens even in the examination. Suddenly, such questions are asked, so very difficult to answer. One thing you should realize, all the valves in the heart have three valves, three leaflets, except the mitral valve. Whether it is pulmonary valve, it is a tricuspid valve, or whether it is the aortic valve, have got three leaflets. It's only the mitral valve has got two leaflets. So that you should always remember. Suppose if a patient has bicuspid aortic valve, it is a patient will have an aortic stenosis and will be requiring aortic valve replacement in the younger age itself. Maybe about 30-40 years, he'll become very symptomatic for aortic stenosis and will be requiring for replacement. So that can be asked for you just like that. Okay, now can you just discuss about the anatomy?
The right
How many
coronary
arteries are there? Coronary arteries are there?
Right coronary artery and left coronary artery.
Correct, very good.
The right coronary artery supplies the right atrium, right ventricle, and the SA node in 55% of the patients, and AV node in 90% of the patients, and
Yes,
posterior descending artery supplies the posterior part of the interventricular septum.
And also inferior wall of the left ventricle also. Isn't it? It all depends on whether the artery is the right coronary artery is the dominant or left coronary or circumflex is dominant. So this is another question you will be asked. So when do you say which particular artery is dominant, whether right coronary or the left circumflex? Based on what?
Based on whether the posterior descending artery is rising from the right coronary artery or from the left circumflex.
So in almost 90% of the cases, it is the right coronary artery which gives the posterior descending artery. And it is a posterior descending artery which supplies the inferior wall of the left ventricle also. Plus, it also supplies the AV node, isn't it? So, and also the SA node is supplied by the right coronary artery in almost 60 to 70% of the patients. In remaining patients, it's a circumflex artery which can supply the SA node. So why should we know about the right coronary artery supplying the AV node and the SA node?
So to know to identify where exactly the pathology is. So in case of ECG changes, to identify where exactly the pathology is, and to
Okay. More than that, which blocking of which artery is more dangerous to the patient? Is it right coronary or the left coronary?
Right coronary.
right coronary.
Is dangerous, is it?
Yes.
Right coronary
Yes.
is supplying most of the right
Yes,
ventricle and
node.
right atrium.
And left ventricle pathology is more dangerous.
More dangerous, isn't it? So left atrium coronary artery blockade is more dangerous than the right coronary artery. But the right coronary artery, because it supplies the AV node and SA node, so rhythm disturbances can occur whenever there is ischemia of the right coronary artery. So rhythm disturbances can occur, and the bradyarrhythmias are more common. And many times right coronary artery block may go without any symptoms also may occur. Patients might have had a blocking of the right coronary artery, they might have had an infarction, so they may not know it also. Sometimes when they come for any other non-cardiac surgery, when you take an ECG, you may diagnose the patient to have an inferior wall infarction, isn't it? So that is what one thing is, because it can produce majority of the times the bradyarrhythmias, even intraoperatively, if right coronary artery gets involved, so it can produce bradyarrhythmias, which may require sometimes even they can develop a complete heart block intraoperatively. So you may require to pace these patients. Temporary pacing may be required in such situations. So that is why you should know about the right coronary artery, which supplies the AV node, and also the AV block can occur, isn't it? Complete AV block, because 90% of the cases, the posterior descending artery, which is arising from the right coronary artery, will be supplying these areas. Okay, now the left coronary artery. Coming to the left coronary artery.
Left coronary artery divides into left circumflex and left anterior descending, sir.
Okay.
Left circumflex artery supplies remaining part of the SA node, remaining patients, it supplies the SA node, and for 40% of the left ventricle in left dominant patients.
Okay.
And
so it can also supply the inferior wall in if it is dominant, very rare, but about 10%. But lateral wall is mostly supplied by the circumflex along with the left anterior descending. So both the left anterior descending and circumflex supply most of the septum and also most of the left ventricle. So any involvement of the left anterior descending. So many times this left anterior descending artery was called as a widow's artery. Why it was called as a widow's artery?
Because the most commonly involved artery in the stenosis.
No, if it gets infarcted, if left coronary anterior descending artery is the one which supplies major part of the left ventricle. So, and usually, already we discussed in the unmodifiable risk factors as, male patients are more prone for coronary artery disease. And if this artery gets blocked and suddenly the patient develops a myocardial infarction, so the chances of patient going in for a sudden cardiac death is very common, isn't it? So if a patient dies, the wife becomes a widow, isn't it? So that's why it was called as a widow's artery, left anterior descending artery. So sometimes you may be asked in the exam, so better to know. So that is very, very important, isn't it? And if left main coronary artery is involved, so definitely these are the patients who require a prior, probably a PTCA or PCI may be required, isn't it? Percutaneous or even CABG, depending on the how much is involved, whether it's a simple one or a complex one. We'll discuss about that later. So just remember about these things, and just can you correlate with ECG findings based on which artery is involved and the ECG findings? Suppose the right coronary artery is involved, what are the leads you can get the changes, either ST elevation or ST depression?
Right coronary artery, it will be lead 1, lead 2, and lead 1, lead 3, and AVF.
It is lead 2, 3 AVF, not lead 1.
Okay.
Yeah, lead 2, 3 AVF is represents the right coronary artery. So sometimes even the posterior wall can get infarcted. Then you may not get anything in 2, 3 AVF. Then you will have to have, the right-sided leads also, chest leads you require, isn't it? So RV4 and RV5 may be required. So very rare, but sometimes it can occur. The posterior wall also may get infarcted because of the right coronary artery involvement. But in general, for you as postgraduate, it is 2, 3 AVF represents the right coronary artery and inferior wall infarction. Okay, whenever this occurs, definitely there can be associated with bradyarrhythmias. Okay, now left anterior descending.
Left anterior descending will be chest lead, sir.
Yes, chest leads.
B3, B4, B5.
So you can have either septal infarctions or lateral wall infarctions, isn't it? Or anterior wall infarctions. So you can have anteroseptal, you can have anterior wall itself, and anterolateral. So anteroseptal usually you will find in B1, B2, B3. So anterolateral you have in B4 and B5, V5 and B6, anterolateral infarctions. And in lead 1 and AVL and V3, V4, you can say it is an anterior wall infarction. So that's how, based on the ECG findings, you can say that. And majority of the times, it can be anteroseptal, anterolateral, can be mainly by the circumflex and anterior left anterior descending artery. So if it is mainly only anterior wall, then it can be left anterior descending artery. So this is again important for us to know which all the arteries are involved. Suppose all the ECG changes are there in all the leads, then you can say triple vessel disease also. So majority of these patients with triple vessel disease may require a CABG. So that is the reason why, as an anesthesiologist also, you may have to know briefly about how we can know which particular artery is involved based on the ECG findings. Okay, now all these things are over, the investigations are over. So now this patient, any patient with ischemic heart disease, so how do you optimize the patient before taking up for surgery? What are the methods of optimization?
So it depends upon how.
Because one thing I want to tell both Vinod and Harish. So whenever you talk about for any case, so first is pre-anesthetic evaluation, and then optimization of preparation of the patient. That's how you should always talk about. And after preparation of the patient, the next would be, what technique of anesthesia. Before that, goals of anesthesia, then technique. And in technique, it depends on whether regional anesthesia or general anesthesia. Based on that, you can always talk about that. So one is optimization. Before optimization, definitely risk stratification is also is very, very important. So before actually going in for optimization, we'll just also discuss about the risk stratification in this particular patient. So how do you stratify the risk of any patient with ischemic heart disease posted for non-cardiac surgeries?
So we have major cardiac adverse events, that MACE, and criteria like RCRI criteria.
RCRI is the latest, isn't it, that we are following? Any older this thing, sometimes it can be also asked for you as short notes in your theory.
Goldman.
Yeah, Goldman's risk index was the first one to be introduced. It was introduced in which years?
1995.
Introduced in 70s, 77.
Okay.
Yeah, Goldman's risk index was introduced in 70s. Then was Detsky risk index was there in 1980s. Detsky's, and afterwards was Eagle's criteria was there, later modified by Lee. And what we have presently is the revised cardiac risk index, isn't it? Now there are about 6 clinical criteria are there, risk indices are there in Lee's or revised cardiac risk index. So just enumerate these 6 risk criteria.
One is high risk surgeries.
Okay, what do you mean by high risk surgery?
Sir, abdominal aorta aneurysms, intrathoracic surgeries, and major fluid shift surgeries.
No, in general, high risk surgeries.
Major adverse cardiac events more than
So you
5%.
can just say major intra-abdominal surgeries, major intrathoracic surgeries,
Okay.
and supraumbilical vascular surgeries. That's how they have been just said that, the major surgeries that are there. Okay.
And
So, right.
history of any ischemic heart disease previously.
Okay. History of ischemic heart disease.
History of cerebrovascular accident or syncopal attack.
Okay.
And in patient history of diabetes mellitus on insulin treatment.
Okay. Why on insulin it is said? Why not just a patient with diabetes mellitus? When a patient requires insulin, actually.
Okay.
Is it
you can't
immediately
control
after he has been diagnosed? No, we will not discuss about type 1. It's more, 95% of the patients with diabetes are type 2, isn't it? So only maybe about 5% of the patients can be type 1. So because majority of the patients are type 2 patients can be managed even without drugs initially, and later they may require oral hypoglycemic agents. Much later, they require insulin, isn't it? So that is why it is always said that diabetic patients on insulin. That means the uncontrolled diabetes is there, long-standing type 2 diabetes is there. So whenever they have a long-standing uncontrolled diabetes, usually the vasculitis will always be there. The vascular involvement will be there. So, either microangiopathic lesions, both macro and microangiopathic lesions would be there, isn't it? So these patients with diabetes on insulin will have these vascular complications and involvement. So naturally, that they'll pose more severe risk for developing MACE when they are posted for non-cardiac surgeries, isn't it? So that's why this is again important, because many of you would not have given importance to this on insulin.
Yes.
And this is nothing to do with type 1. It is type 2 diabetics only on insulin. Okay. So what is the next one?
Sir, patient with serum creatinine more than 2 or 2.
Yeah, again, we actually discussed last class also. Why it is again important to say that serum creatinine more than 2. When actually serum creatinine starts increasing after the patient has developed some nephropathy.
So in long-standing hypertensions, like more than 10 years.
No. I'm not telling you that. So regarding the renal functions, so how much of renal function to get affected for the creatinine to start rising?
Nearly 50%.
Yes, very good. So unless, till 50% of the renal functions are affected or the GFR is affected, there won't be much rise of the serum creatinine. So once more than 50% of the renal functions and the GFR is affected, so then only serum creatinine is start rising. So that means this patient is almost maybe grade 3 or grade 4 of the end stage renal disease, isn't it? We always grade it by grade 1 to grade 5. So it may be already grade 3 or grade 4 end stage renal disease. That means they'll have more involvement, because we know that any chronic kidney disease will affect the coronaries also, because the accelerated atherosclerosis is very common with the chronic kidney disease, isn't it? Even ESRD, or even after the patient has undergone a renal transplant also, many of the drugs that we give as immunosuppressants also will produce an accelerated atherosclerosis. So these are more likely to have developed more atherosclerotic lesions in the coronaries and are at more risk for developing major adverse cardiac events. That is why that serum creatinine more than 2, that is always there. What is the normal serum creatinine, Deepak? Sorry, Vinod?
So 0.8 to 0.5 to 1.
1.4, isn't it? So
Yeah.
that is the normal, depending on the age. So if the patient is old age, then the creatinine will be, upper normal limit can be 1 also, because creatinine depends on the muscle mass. As the aging starts, the muscle mass starts coming down. So that is how the creatinine level, you can say in a 70-year-old man, if it is more than 1, you can say it is raised. So again, that is why we always multiply in Cockcroft-Gauld's equation. for females with 0.83, isn't it? Because, females will have a less muscle mass. So naturally you have to decrease the GFR based on the muscle mass. Okay. So that is why the serum creatinine is a very important clinical risk indicator. So that's why it has been included in the revised cardiac risk index. Okay. Anything else?
6.
How many risk factors you have said? Now,
6.
one is the surgery,
Yes.
depending on the severity of the surgery. Second thing is history of congestive cardiac failure, history of ischemic heart disease, then history of cerebrovascular disease, and diabetes mellitus on insulin. And the last one is the patient with serum creatinine more than 2. So 6 revised cardiac risk indices are there. So based on that, what can be the incidence of MACE? Harish, can you just tell about? Suppose the patient doesn't have any of these risk indices. He doesn't have even one risk index is there. So he has got a 0 RCRI. So what is the probability of this patient developing MACE?
It's 0.6 to 0.1%, less than 1%.
It is 0.4.
4.
Isn't it? 0.4, negligible. So if he has one risk index,
0.9.
Yeah, 0.9, very good. So if he has 2,
4%.
6.6. And if it is 3,
11.
Yeah, more than 11. 3 and above, it is more than 11. So that means as the RCRI increases, the count increases. So as also the MACE incidence of MACE also increases. So that's why this is one of the factors, the clinical risk factors, which is used for risk stratification of these patients. Now, this is the latest risk stratification we use. Also, you can have, if the patient undergoes the non-invasive CT coronary angio. So I just told you about the calcium scoring. So the calcium scoring is 0. It's a very high negative probability of patients developing any kind of MACE. So absolutely, you can say very, very minimal. So that has got a high negative predictive value. So if it is anything up to 100, there is always a risk is there, though mild. 100 to 400, moderate, and then anything above 400 can be very high risk of developing MACE. So this also can be included in risk stratification nowadays, if the patient undergoes this. Okay, now another very important thing here is the algorithm you can be asked about. So 2014 algorithm is there for accepting the patients or not to accept, whether to do any of the non-invasive cardiac testing. So this also we did not discuss. Let us discuss about this before actually we go for optimization of the patient and then going in for anesthetic management. Can you just tell about this algorithm that is commonly used under a very simple algorithm? So every day, routinely, we can use this algorithm to know whether patient can be taken up or patient has to be postponed, surgery has to be postponed, any requirement of optimization is there, or any non-cardiac, any non-invasive testing to be done. All these things you can know by a simple algorithm that was introduced by ACC/AHA guidelines of 2014. Can you just talk about this? What is it is a stepwise, isn't it? What is the first step?
So any patient with risk of coronary artery disease, so we'll see whether the patient is posted for emergency surgery or elective surgery. So
first step is always patients with cardiac disease. You can say cardiac disease. Yes. Posted for emergency surgery. Already we discussed about classification of emergencies, isn't it? Or surgeries. So emergency surgery, urgent surgery, then time-sensitive surgery, and also elective surgery. So suppose life-threatening, limb-threatening emergency surgery, if the patient is posted, what we can do? Should we
clinically assess the patient? We'll take up for the.
So you'll have to accept. But before accepting, risk stratification. Yeah. So that is very important. You stratify the risk because you have to talk to the surgeons, you have to talk to the patients, you have to talk to the patient's relatives. You have to tell them about the risk of a patient developing major adverse cardiac events. where the patient may also require post-operative mechanical ventilation, and the patient may also require invasive monitoring. So all these things based on the risk stratification, isn't it? So that is why the risk stratification is very, very important. So you can do some of the tests also if you have time. Even now a transthoracic echo also can be done very rapidly. So as an anesthesiologist, now you are supposed to learn about transthoracic echo also. So you can know about the at least basic things about what is happening inside his heart, isn't it? So that can be a part of risk stratification when you are assessing these patients when they are posted for emergency surgeries or in step 1. Plus, the perioperative surveillance that is also added there, isn't it? What do you mean by perioperative surveillance?
A patient will be monitored throughout the perioperative period.
No, every patient will be monitored. Don't you monitor every patient, whether he comes for an elective procedure, even MAC, when he comes for monitoring anesthesia care, you are monitoring. So what do you mean by perioperative surveillance here? Intense monitoring. That is what is very important. Intense monitoring. You may even require to go for invasive monitoring like central line, arterial line, even Swan-Ganz, pulmonary capillary wedge pressure monitoring. So all these things. I just want to tell you about this one thing about one of our own Indian anesthesiologists, of course, based in US. So this was done in 1983 because till then it was said that you have to postpone patients with a previous myocardial infarction for at least 6 months. So after 6 months only you have to take up, because if you take them up within 3 months after a myocardial infarction, the chances of reinfarction rate was very high, more than 25%. And if you take them up between 3 to 6 months, the reinfarction rate would be anywhere above 6.6. And if you take them up after 6 months, the reinfarction rate would be less than 6%. That was again introduced in 1973 by studies done by Trehan et al. So again, Trehan is an Indian cardiologist, in US in 1973. But in 1983, Krishna Rao, L. Liter and Jacobs, they studied, and it was a very important study. And in that, what they did was, so when these patients were posted for emergency surgeries within 3 months of myocardial infarction, what they did was they monitored these patients intraoperatively with a Swan-Ganz, with an arterial line, with central vein, central venous cannulation, and they continued this intense monitoring up to 72 hours post-operative. And they found out with intensive monitoring and any changes that occur with any of these, either ECG, pulmonary capillary wedge pressure, or arterial pressures, they immediately started managing these patients. Suppose if there is the pulmonary capillary wedge pressure starts increasing, it will start increasing because if there is a myocardial ischemia is there, isn't it? So the left ventricular endostolic pressure will increase. So it is conveyed to the left atrium, and what we are actually measuring indirectly is the left atrial pressure when you monitor pulmonary capillary wedge pressure. So immediately, they could use some vasodilators to reduce the tension in the left ventricle, and they could manage. So by this, they could reduce the reinfarction rate to less than 6%. That's how the surveillance has been given a lot of importance. So that's why in the step 1 itself, it is so important that because risk stratification you are going to do. So once you know that these patients are at very high risk, then you have to go for intense surveillance, isn't it? Intense monitoring. So that is the first step, which is very, very important. Okay. From the second step onwards, patients who are posted for elective procedures. So this is, again, you have to understand, because this is very important for you for theory also, for your practicals also. Okay, now let us say the patient now is posted for elective procedure. Second step. What is the second step?
We'll look whether the patient is having acute coronary syndrome.
No, active cardiac conditions. You can say second step can be, you have to rule out patients having active cardiac conditions. And also we call them as the major risk factors also, isn't it? What are these active cardiac conditions?
Patient with congestive heart failure,
heart failure, untreated, not optimized, uncontrolled. Okay, one.
Life-threatening arrhythmias, including bradyarrhythmias, heart blocks, ventricular tachycardia,
ventricular VT, VF, and also,
Yes.
the
and
uncontrolled
atrial
atrial
fibrillations.
fibrillation. They
Uncontrolled
are called
AT.
as malignant arrhythmias. All these malignant arrhythmias, including complete heart block or second degree AV block, all these will come in the dysrhythmias, malignant dysrhythmias. Okay, the third one, active cardiac condition.
Ongoing ischemic.
A patient having recent myocardial infarction.
Okay.
So when do you say recent myocardial infarction?
Within 1 week of, within 1 month of,
No.
1 week,
days.
sir. Within 7 days, sir.
Yeah, within 7 days is recent, isn't it? So acute is within 24 hours. Recent is within 7 days of this. And that is again very important to know about, isn't it? And then it is an active cardiac condition. And plus coronary syndromes, acute coronary syndromes. Again, patient having unstable angina also is included. Of course, myocardial infarction is also included. So these are some of the active cardiac conditions. Suppose if you have to, you evaluate this patient, you have got enough time because this patient is an elective procedure. So you are evaluating this patient. So you have evaluated and you have found out that any one of these active cardiac conditions the patient is having. So can I accept the patient now for surgery?
We defer the surgery and
we have to postpone. You have to optimize this active cardiac condition and then only take up. Because if the patient has the active cardiac condition itself can be a life-threatening thing. If patient has got a VT or a patient has got uncontrolled AF or any of these complete heart block. And one more thing is severe valvular stenosis, severe aortic stenosis, severe mitral stenosis also including active cardiac condition. So these have to be first optimized before taking up. Okay, that is a step 3. What is the step 2? What is step 3?
And if the patient doesn't have any active cardiac conditions, we'll see whether the patient is posted for minor surgery or major cardiac events less than 1% or a elevated risk surgery.
There are only, ACC/AHA guidelines 2014. They have combined intermediate risk surgeries and high risk surgeries into elevated risk surgeries. Now they have classified only these two. One is low risk and elevated risk. What they have done is they have combined the clinical criteria of the patient plus the surgical risk, clinical risk and the surgical risk of the patient. Combining these two, they have classified these surgeries as the low risk surgeries and elevated risk surgeries. So the patient is posted for a low risk surgery. Can you just name some low risk surgeries?
Endoscopic.
Cataract
surgeries.
Endoscopic, minor endoscopic surgeries, breast surgery, superficial surgeries, breast surgeries. These are all low risk surgeries. So if the patient is not having any active cardiac condition, and if the patient is posted for a elective procedure which is of low risk, so we can straight away accept without even considering his meds or going in for any non-invasive cardiac testing. Okay, what is the step 4?
If the patient is posted for elevated risk surgery, we have to look for cardiopulmonary reserve in terms of meds. So if the patient is having more than 10 meds, straight away we can accept the patient.
Excellent. That is functional capacity.
Okay. If the patient is having 4 to 10 meds, moderate functional capacity, we can accept.
Still accept.
If the patient is having less than...
so more than 4. Now you see, that's what in ACC/AHA guidelines 2008, this was not there. In 2014, they have just have classified the meds also. Before that, it was only just above 4. Now they have above 10, excellent meds, absolutely no problem. You can straight away take up. And 7 to 10, again, good meds, good functional capacity, still you can accept. And 4 to 7 is again, you can accept. But definitely excellent meds, these patients will have very minimal problems, isn't it? And again, 7 to 10, probably slightly more risk. And 4 to 7, slightly more chances or incidences can occur. So that's how it has been classified as 4 to 7, 7 to 10, and above 10. So that is excellent, good, and moderate. And anything less than 4, the poor functional capacity. Okay, so now patients with poor functional capacity now, or you're not able to check for the functional capacity of this patient. You are not able to assess. So that will be step 5, isn't it? So what is this step 5?
We will risk stratify these patients based on least reverse.
Okay. Okay.
If the
So
patient
now
is
we'll have to actually, step 5 is whether these patients require any non-invasive cardiac testing, which probably may change your method of management. If they are not going to change your method of management, no need to do that also. So suppose if you think that by doing this non-invasive cardiac testing, so they are going to change your method of management, either surgical management or anesthetic management, then definitely you may have to subject them. So like already we discussed about the stress ECG or pharmacological stress echo, and even probably the perfusion scanning, all these. Okay. So, okay, now suppose you do these tests, what next?
If the patient is having
Positive.
a positive, then
look for RCRI, isn't it? So then you may have to think whether this patient really requires an angiography, and also he requires probably revascularization procedure before taking up one, or whether if the RCRI is also high, more than 2 or 3, whether to defer the surgery or conservative management without surgery, or you may have to go for a laparoscopic surgery. Type of surgery can be changed, or you can consult with the surgeon to reduce the severity of the surgery. So all these things have to be done, isn't it, based on this. So this algorithm is very, very important. So it is a good thing that we discussed in detail about this particular algorithm, and I keep telling about this particular thing for my postgraduates also. If there is any cardiac case comes, then I'll ask them to stratify the risk based on these stepwise, whether to accept, not to accept, whether to go for any other tests also. Okay, now after this, now can you just tell me about now coming to the optimization of the patient? What are the methods to optimize the patient before taking up for non-cardiac surgery?
We'll see a patient having any tachycardia, or he has been not start for beta blockers.
Very good.
Yeah, we'll start up the beta blockers.
Yes,
and
okay.
we'll console him, or we'll tell all the procedures what we are going to do that makes him less anxiety.
No, first thing is, you are going to evaluate, and then based on your evaluation, you are going to optimize.
Yes.
Based on how much the patient is, the severity of his disease, and based on that only, because by your evaluation only, you can definitely optimize the patient. And especially, if the patient is not on beta blockers, again, already we discussed which of these patients may require beta blockers to be started at least 1 week before, and whether he requires any other drugs like AC inhibitors, whether he requires an anticoagulant. So all these things we'll have to check for. And again, if the patient is on certain drugs like antiplatelet drugs, so which antiplatelet drugs have to be stopped, isn't it? So that is also comes in the preparation itself. And if the patient is on anticoagulants, again, that is another very important thing, because some of these patients with ischemic heart disease also having maybe an indication for anticoagulant therapy, like they have an atrial fibrillation, or they have a DVT, and they might have had a history of pulmonary thromboembolism maybe there. So they might have been placed on chronic anticoagulant therapy. So in the last class only, we had thought about also discussing about patients on anticoagulant therapy, and how to go ahead before taking up these patients. So what anticoagulant therapy majority of the times these patients can be on?
You can be on unfractionated heparin or low molecular.
Usually they'll not be on parenteral anticoagulants. Majority of them will be on oral anticoagulants. Chronic anticoagulant therapy, you don't put them on parenteral, because the problems associated with parenteral anticoagulant therapy. They have to be admitted to the hospital, and it has to be instituted. So oral anticoagulant therapy, they will be on. So majority of the times they can be on vitamin K antagonistic oral anticoagulant. So you have warfarin and acitram, and also non-vitamin K antagonistic oral anticoagulant therapy. Also NOVA, it is called as not NOVA, NOCA. So newer oral anticoagulant, novel oral anticoagulant therapy also that is there. So they are non-vitamin K antagonistic drugs. Can you just name them, one or two?
Rivaroxaban.
Yeah, rivaroxaban and dabigatran are most popular. Dabigatran is, that direct thrombin inhibitor, and rivaroxaban is a direct NA inhibitor. Okay. Now, if the patient is on any of these drugs, oral anticoagulants, so how do we proceed when the patient is posted for an elective non-cardiac surgery or even cardiac surgery? Okay. We are discussing about non-cardiac surgery. We'll just discuss about that.
Okay.
Patient is on either warfarin or acitram.
We have to
Elective surgery.
We have to stop warfarin and bridge with parenteral anticoagulant.
Yeah, again, stop. When to stop?
At least 5 days.
Yeah, at least 5 days prior, isn't it? 5 days prior, you have to stop. Warfarin, what is the half-life of warfarin?
12.
It is 48 hours. 36 to 48 hours. Acitram, it's about 24 to 36 hours. It is, lesser half-life when compared to, or shorter half-life when compared to warfarin. Okay. Now, why this you should know is, so once you stop these drugs, so usually what is the INR with which usually that is kept for these patients when you put them on anticoagulant therapy?
More than 2.
Yeah, about 2, isn't it? Again, depending on whether they have got a valve and an older valve, newer valves. So all those things are always there. So when some discussion is there on mitral valve problems, then more amount of discussion can be done regarding that. Anyway, usually about 2. So when you stop warfarin, now the risk of thrombosis and thromboembolic problem will increase, isn't it? So now what you do after you have done an INR, it is 2, and you have stopped from today. So should you repeat INR? When do you repeat usually with the warfarin?
48 hours.
After 48 hours, because we said that it is about the half-life is 48 hours. And with acitram, you have to repeat the next day itself because it has got a shorter half-life. Okay, so you have repeated. And when do you want to start the parenteral anticoagulant bridging therapy for these patients?
After 48 hours.
So, it is not after 48 hours. That's why I asked you when you have to do a INR estimation. So if the INR is less than 2, then you have to start them. Suppose if in a rare patient, even after stopping for 2 days also, if the INR is not coming down to less than 2, there is no point in starting on the parenteral anticoagulant therapy. You have to wait till the INR comes down to less than 2. Then only you have to put them on parenteral anticoagulant therapy. Okay, now parenteral anticoagulant therapy can be low molecular heparin or unfractionated heparin, isn't it? So again, this is very important for us to know which particular drug the patient is on. So for managing the patient intraoperatively, even our anesthetic technique and when to stop these drugs, and can we go for regional anesthesia, especially central neuraxial block or anything, isn't it? So now what you do? Now let us say that the patient is on unfractionated heparin. So it can be on low dose or high dose, depending on the risk the patient has, like prophylactic dose or therapeutic dose, even unfractionated heparin. So prophylactic dose is usually around 15,000 a day, like 5,000 units, BDR 3 times or maximum 4 times. It will be less than 20,000 units per day. So if the patient is on unfractionated heparin, so it is not more than 15,000 per day or not more than or less than 20,000 units per day. So what is the guideline?
4 hours, we have 4 hours pre.
If intravenously used, 4 hours.
Okay. So usually subcutaneous, majority of the times,
12 hours.
subcutaneous it is given. So it again depends, isn't it, how much that is being given. So if the patient has been given anything less than 20,000 units, less than 10,000, definitely 6 hours is enough. So 10 to 20,000, so ASRA guideline says that up to 12 hours you have to wait. And anything above 20,000 per day, 24 hours.
4 hours.
Yeah, this again is a very important. It is not just receiving. As long as he 10 to 20,000, probably 12 hours, and above 20,000, 24 hours, you have to wait. Okay. So then regarding low molecular weight heparin,
If the patient is on therapeutic dose, 12 hours we have to wait. If the patient is on therapeutic dose, 24 hours. If the
Yes.
patient is on prophylactic dose, it is 12 hours.
12 hours. So that is there. And once the patient is on heparin, any investigation you have to do before taking up the patient?
Coagulation.
The coagulation you can do, or APTT you can definitely do
count.
for unfractionated heparin, not
Platelet
for
counts.
low molecular weight heparin.
Platelet count.
count, isn't it? So HIT is a complication even with low molecular weight heparin. So it is always, if the patient is on this heparin for more than 4 days, so even sometimes, very rarely, even a single dose has produced heparin-induced thrombocytopenia. So a platelet count can be done, and then only the patient can be taken up for your surgery, especially if you want to go for central axial block. Again, so already we discussed for putting a catheter also, these number of hours have to be there, a gap. So okay, now once you have gone for a continuous epidural, so when we can restart the patient on this anticoagulant therapy, parenteral anticoagulant.
If unfractioned heparin is there, we have to give after 1 hour of the
after putting the catheter, placing the intraoperatively, you are not going to start, isn't it?
Yes.
Intraoperatively, you will never start. So usually all these anticoagulant therapy, usually majority of the times are started after 24 hours.
Oh.
Usually after 24 hours, you will start. So suppose if you are putting an epidural catheter for any other purposes, then at least you have to wait for 1 hour to give a top-up dose. Now, again, here, what is very important here is, now, when you can continue the catheter. Suppose the patient is on a therapeutic dose of low molecular weight heparin. Can I continue before giving starting the dose for him? Before actually you want to give the low molecular weight heparin therapeutic dose, you have to take out the catheter. After taking out, after 4 hours, you have to start the patient on low molecular weight heparin. If it is for prophylactic, you can continue the catheter. You can continue the catheter, and you can start giving in the post-operative period, usually majority of the times after 24 hours. So the last dose again, before you remove the catheter, should be for this thing is 12 hours for prophylactic and 24 hours for therapeutic, the last dose, before you take out. Because one thing you should remember, there can be more bleeding when you are taking out. When the catheter is inside, there can be a lot of adhesions can occur. When you blindly take it out, there can be more injury and more bleeding can occur. So that is why this 4 hours, 6 hours for unfractionated heparin and 12 hours for prophylactic low molecular heparin and 24 hours for therapeutic. So after the catheter has been taken out, so when do you restart? That is again, you said that 1 hour after that for unfractionated and 4 hours after for low molecular heparin. Okay, when do you restart oral anticoagulants? usually after 24 hours. Usually after 24 hours. And one thing again, if the patient is on a catheter, so take out the catheter before starting them on the oral anticoagulants. So suppose if the patient comes for an emergency procedure on anticoagulants,
will not put the central nerve, will not give.
no, first of all, these are absolutely contraindicated, central and axial blocks, that is there. So, but he is going to bleed intraoperatively, isn't it? So
Yes.
you have to reverse the effect of these. So if you have time, you can give vitamin K. When vitamin K will start reversing the effects of the vitamin K antagonists? How much time it will take?
48, 24.
Take 6 hours, minimum 6 hours. So suppose if you don't have that amount of time, then you have to give them fresh frozen plasma, isn't it? So fresh frozen plasma is the one which usually you give at in the dose of 15 ml per kg body weight, and you can manage these patients. And the duration of action of these anticoagulants applied through fresh frozen plasma is also limited. It is only 6 to 8 hours. So that is why you have to give a vitamin K also, so that after 6 to 8 hours, the vitamin K will start acting. So the patient will have less chances of bleeding. So that's why you give vitamin K, you give fresh frozen plasma, and the dose of fresh frozen plasma depends on the INR. Suppose INR is 7. Patient has been posted for emergency surgery. You have done an INR. INR has come as 7.
It's per
Should we
kg.
increase the dose of fresh frozen plasma or the same dose to be given?
Same dose.
Yeah, irrespective of the INR, fresh frozen plasma is same. So what is the amount of percentage of anticoagulant, the coagulation factors that increases with this 15 ml per kg body weight of fresh frozen plasma? What is the percentage of increase? And which is enough to prevent bleeding? It's about 30%. So when you give 15 ml per kg body weight of fresh frozen plasma, the increase of coagulation factors is by about 30%. It is enough to prevent intraoperative bleeding. Anyway, we would have given vitamin K also. How about for dabigatran and rivaroxaban? How long you have to stop them before going in for?
Dabigatran, we have to wait for 5 days, 120 hours.
No, 5 days in which type of patients? Because dabigatran, 80% of it is excreted through kidney and change. So in patients with renal
creatinine clearance
disease,
more than 30.
Yeah, then 5 days. Otherwise, 3 days. Usually for both dabigatran and rivaroxaban, it's about 3 days you have to wait. Okay, so that is about the anticoagulant therapy patient is on and how to manage. Because in the last sessions, there was a question regarding this anticoagulant therapy, how to manage these patients. Okay, now the patient has been optimized, but one method of optimization is also, I was telling you, is the going in for revascularization procedure, isn't it? Either CABG or going in for PCI, percutaneous coronary intervention, before taking up. That can be a part of preparing this patient, isn't it? So which patients require probably a revascularization procedure before taking these patients for non-cardiac surgery?
Triple vessel.
Now, if there is a strong indication for revascularization procedure, irrespective of whether the patient is posted for a non-cardiac surgery or a cardiac surgery. Sorry, irrespective of whether the patient is posted for a surgery or not.
Okay.
Okay. Whether the patient is posted for surgery or not, there is a strong indication, even if the patient has come to the cardiology department and they have done investigations and they have found out that yes, this patient requires a revascularization procedure, maybe a PCI or CABG. So that is an indication. As such, that is an indication. Okay. So if that indication is there, definitely that can be a part of your preparing this patient. Okay, that is one thing. Is there any other indication before taking up for non-cardiac surgery? The patient has
stress test is possible.
Unstable angina, acute coronary syndrome. Patient having acute coronary syndrome and posted for any
Sorry.
non-cardiac surgeries. Definitely is an indication before taking up, isn't it? So any acute coronary syndrome can be unstable angina, non-ST elevation MI or ST elevation MI. So that will be an indication for the coronary angioplasty or even CABG. So that is because that again it has got its own risk. So otherwise there is every patient need not be subjected for revascularization procedure. They can be optimized with pharmacological methods and can be taken up for surgery. Okay, now this patient has already undergone this about a year back, and already we discussed about the implications of that. And now, what are your goals for anesthesia in this patient? And what is the technique you are going to choose for this patient? She is posted for an elective umbilical hernia repair. And how you are going to proceed? What are your goals in any patient with ischemic heart disease?
Goals are not to cause tachycardia,
Okay.
not to cause severe bradycardia.
Okay. So one thing again, Vinod, I just want to tell you, for any patient with cardiovascular disease posted for non-cardiac surgery,
Yes.
always you should think about these 5 things. One is the heart rate, the rhythm, myocardial contractility, afterload, preload. Isn't it? So these 5 things, if you just think about these things when you are asked in the exam, so what are your goals? Just think about how to manage these 5 criteria or parameters intraoperatively. Then it becomes very easy to talk about the goals. Okay, regarding first is the heart rate.
Yes.
Said heart rate should not be
60 to 80 we have to maintain.
Yeah, ideal would be 60 to 80 because heart rate is there as far as the oxygen supply is concerned and also oxygen demand is concerned. This is one of the most important factor you have to keep in mind. Always maintain the heart rate to between about 60 to 80, even 55 to 60 is also fine. So why severe bradycardia you have to avoid?
Okay. Again, it reduces the cardiac output.
Yeah, very good. Because cardiac output
cycling.
depends on the heart rate.
Heart
Because
rate
stroke
and-
volume multiplied by heart rate is cardiac output. So a severe bradycardia can definitely decrease the cardiac output. The coronary circulation also will be decreased. So MACE can occur, isn't it? So avoid tachycardia, avoid severe bradycardia. Okay. Rhythm,
Normal sinus rhythm. We have to.
always maintain sinus rhythm. So because any abnormal rhythm, again, cardiac output can get affected. And any decreased cardiac output can affect the coronary circulation also. So then you have the problems. Okay, okay. Then myocardial contractility.
Avoid increase in myocardial
Yeah,
contractility.
any increase in
Right,
myocardial
depression should-
contractility can increase
Increase oxygen demand.
oxygen demand. So slight depression is always better. So you should not produce too much of depression because the cardiac output get affected. Slight depression is fine. So because you are using drugs like inhalation anesthetic agents, which also produce minimal depression, so that is fine. Okay, what about the afterload?
Afterload we should avoid. We should reduce the afterload.
Slight
Not
decrease is
slight decrease in.
A mild decrease is fine, isn't it? Because left ventricular wall tension has to be decreased. So afterload is very important. So that can increase the oxygen demand. So that's how mild decrease is fine. So any increase to be avoided as such. Okay, preload.
You have to maintain a preload and
Very
slight
good.
decrease in preload.
Yeah, mild decrease is fine because why too much of decrease preload can produce problems.
A decreased preload can again cause underfilling. It can cause hypotension. Again, patient coronary.
Again, cardiac output, because cardiac output is also preload dependent, isn't it, in every one of us. So if too much of decrease in preload, cardiac output will get affected, coronary circulation will get affected. Any increase in preload, why you should avoid in these patients with ischemic heart disease?
Increase in preload again will cause increase in endostolic volume and eventually endostolic pressure and decreases the coronary perfusion.
Coronary perfusion will decrease. So
the patient
can produce myocardial ischemia, which can lead to pulmonary edema intraoperative, isn't it? Okay, these are very important things. And especially regarding the blood pressure itself. When you're talking about the afterload, the blood pressure. So what are your goals regarding the blood pressure itself?
We should not reduce more than 20% of the basal blood pressure, what we call.
So always maintain the pressure normal, whatever the patient's blood
Yes,
pressure,
sir.
you have to maintain. Never allow the blood pressure to fall below 20%. With the mean arterial pressure, how much of mean arterial pressure always to be maintained?
Above 60.
Above 65. And in this, instead of mean arterial pressure, we should always talk about diastolic pressure. So never allow the diastolic pressure to fall much, isn't it? So, and do not allow too much of increase of diastolic pressure. Too much of increase in diastolic pressure can increase the left ventricular wall tension and also can produce increase in demand. So too much of increase should be avoided. Hypotension, decrease in diastolic pressure as such to be avoided. Okay, these are the goals. Okay, with these goals, what is the anesthetic technique you want to choose and how do you proceed?
For this patient, sir, I would like to go with combined spinal epidural.
Combined spinal epidural. Okay. So what is your first choice? What is your second plan or choice? And what is your third choice? Like that, because you always have to have that, isn't it?
First choice will
what are
be
the benefits of each one? And based on benefit risk ratio, you can opt for the best technique.
first choice will be epidural, sir, sole epidural.
Okay. Sole epidural.
Sir,
Okay. Okay.
second choice will be combined spinal epidural.
Okay.
Third will be we can go for general anesthesia.
General anesthesia. Okay. How about continuous spinal?
Segmental spinal.
These are some of the techniques that are there. Of course, you may not be routinely using. So it can be a combined spinal epidural. It can be a graded epidural, or it can be a continuous spinal also is there. And finally, you have general anesthesia is always there, isn't it? Now coming to combined spinal epidural, you said. So is there any problems with combined spinal epidural? Combined spinal epidural means what? You always first either through needle technique you go for, or you can go for a double segment technique, isn't it? First you place an epidural and in another space go for spinal. What technique you always use for in your hospital?
So we give first we'll place an epidural, then we'll give
okay, two-segment technique. That is called as two-segment technique.
Yes.
Whereas when you go with a needle through needle technique, it is called as a single segment technique. Where in the same segment, you're going to first identify the epidural space, then you put a spinal needle, puncture the dura, and you're going to give for spinal and then place the catheter. Okay, now any problem with your technique of combined spinal epidural in this patient? Regular combined spinal.
Yeah, we see the hypotension, bradycardia by giving spinal.
Because what is the level of block you want to achieve in this patient?
So T6.
Yeah, maybe T6, because yes. It all depends on the contents in the umbilical hernia. So if it's only a momentum, of course T6. If the intestines are also involved, probably slightly high up, T4 also may be required, isn't it? So it all depends on that. So okay, you wanted to have a T6 anesthesia with a spinal first and then epidural if required. So yes. Definitely with this spinal anesthesia, sudden sympathetic block, suddenly things can happen. The pressures can drop rapidly, isn't it? So with this, definitely you have the high risk for this patient, which is against your goals of anesthesia, which you never wanted a rapid fall of the blood pressure, isn't it? Okay. So will you still want to go for combined spinal epidural?
No.
Is there any other thing? For example, now let us say that this patient is posted for hernia repair.
Yes.
The umbilical, not umbilical hernia, inguinal hernia, a male patient.
Yeah, I would like to go with combined spinal epidural.
There, would you like to go for combined spinal epidural? What kind of combined spinal epidural? Is it there is specific combined spinal epidural for that kind of a ischemic heart disease patient posted for inguinal hernia repair?
No.
You can go for what is called as a lodospinal with graded epidural. Now that is becoming very popular. Lodospinal with graded epidural, even in patients with cardiac diseases. Lodospinal means you don't go more than 1 ml of bupivacaine heavy.
Okay.
Always give just 1 ml of bupivacaine heavy, even in patients coming for cesarean sections with severe cardiac diseases. This being nowadays being advocated. So low dose spinal with graded epidural, otherwise called as sequential combined spinal epidural. You are sequencing. So first you give, you put a catheter, you also give 1 ml of your bupivacaine heavy, 0.5%. So turn the patient or bring the patient to supine posture. So check the level of the block. Invariably, the level of the block will be around T10 or just below T10. It will not be higher. So the number of sympathetic segments block will be much less. So naturally, the hemodynamic changes that occur will be minimal. But the advantage here is the sacral anesthesia and analgesia. When you use an epidural, you may not have enough of sacral analgesia because you are going to put an epidural catheter at lumbar area L23 or L34, and you are going to push the catheter. Invariably, the catheter will go up. The tip of the catheter, you are placing it 3 to 5 centimeters. Somewhere it may be T12. So there is a long distance for the drug to reach the sacral fibers, and the sacral fibers are very thick fibers, and they may not get enough of the local anesthetic. Invariably, there may be a decreased amount of sacral anesthesia and analgesia. The same thing even in labor analgesia also. So that's how when you go for a combined spinal epidural, low dose spinal with epidural, especially the sequential combined spinal epidural. So the sacral fibers are also blocked by your spinal 1 ml. So the patient will not have any patchy anesthesia when you are using epidural. Afterwards, you can grade the epidural based on the number of segments you require to block. Already you have blocked up to T10, and you want to block, already we have discussed to calculate how much of the drug that is required to block each segment. So based on that, the number of ml you can give and then block. Okay, this is called as a combined spinal epidural, wherein you go for a sequential combined spinal epidural or low dose spinal with epidural. Okay, so the other technique is also there, where a dural puncture epidural. Must have heard about dural puncture epidural. Only you are puncturing the dura, you're not going to give any drug. So when you just puncture the dura and you are using your epidural, because the epidural drug can easily seep into the intrathecal space, and you will have a better sacral analgesia. So that is also can be one of the things you can use if you are going in for the requirement of sacral segments to be blocked. Of course, in umbilical hernia, you don't require these things. But what I'm telling is, suppose if you require when sacral segments to be blocked, then a dural puncture epidural can be a safe technique. Only problem with combined spinal epidural, dural puncture epidural is a PDPH when compared to a continuous epidural, isn't it? So suppose you think that, okay, this patient had taken a spinal before and had severe PDPH, then definitely you don't want to go for any of these techniques, either dural puncture epidural or low dose spinal with epidural. You would be going in for a graded epidural, isn't it? So how do you go ahead with a graded epidural? Because that was one of the doubts asked in the previous session.
After placing the epidural where the segment we want the level,
Okay.
we'll calculate the segment level and take the volume. If we are blocking 6 segments, so 6 ml if we are taking, then in that 3 ml we are giving and as a graded and watching for the hemodynamic any changes. If there was no any hemodynamic changes, we'll go ahead with the other 3 ml.
No, first 3 ml you are going to give the test dosing, isn't it?
Yeah.
Whenever you want to place an epidural, always the test dose you have to give.
Yes.
That is because you are going to give high concentrated large volume of local anesthetics. Suppose if the catheter tip is placed intravascularly or intravascular, or if it is intrathecal, you can produce a total spinal. So you want to prevent these catastrophes. So you always give a test dose, isn't it?
Yes.
Who proposed this test dose? In which year? Test dosing. We always say 3 ml, 2% lidocaine with 1 in 2 lakhs adrenaline, isn't it? Routinely in the exam also you'll be telling. So why I'm asking is an Indian is also there. That is the reason why I wanted you to know about. Any people, Indian contribution, you should always remember.
Venkatramana.
No, no. It is Batra. Moore and Batra. Moore, Dr. Moore and Dr. Batra. So they introduced this in 1981, long back. 1981, this was introduced. Mainly, it was introduced for epidurals of cesarean sections, long back. So they advocated 3 ml of 1.5% lidocaine with 1 in 2 lakhs of adrenaline. So 15 micrograms of adrenaline. 1 in 2 lakhs is 15 micrograms, 3 ml. Each ml is 5 micrograms. How do you calculate this? How do you know that 1 in 2 lakhs each ml is 5 micrograms? Harish? These are the basic things you should always understand things. How do you know 1 in 2 lakhs is 5 micrograms per ml? So 1 in 2 lakhs means 1 gram in 2 lakhs ml. Just remember, 1 gram in 2 lakhs ml. So 1 gram is how many milligrams? 1000 milligrams. Each milligram is 1000 micrograms. 1000 multiplied by 1000 divided by 2 lakhs. Isn't it? It will be 10 divided by 2. So 10 divided by 2 is 5.
Right.
So each ml contains 5 micrograms. So, if you want to prepare anything like 1 in 10 lakhs, 1 in 20 lakhs, so you should always, this is the basic thing you should always know about. Okay. Now the test dosing. So first you always give the test dosing and know whether it is intravascular or intrathecal, then only you give subsequent dose. So like that in graded epidural, you just give the first test dose and then make sure that the catheter is properly placed in the epidural space. And then first dose, you can always give 5 ml. 5 ml of local anesthetic. Then you have to wait for at least about 5 to 10 minutes. So assess the level and afterwards you can go for 3 ml increments based on the level you want to achieve. So every top up you wait for about 10 minutes. If you are using bupivacaine. If you are using lidocaine, you can wait for 5 minutes because lidocaine, it acts when compared to bupivacaine. Why it, Harish, rapidly acts, lidocaine? Onset of action is faster when compared to bupivacaine. So suddenly these questions will crop up in the exam also. Because entirely depends on the pKa, isn't it? Diffusion coefficient. The pKa is close to the plasma pH. Then, more number of molecules will be in the unionized state. It is the unionized particles only can penetrate the bilipid layer of the nerves. And they have to go in because, the receptor for local anesthetic is present inside the nerve, isn't it? It has to enter the nerve and then only it can occupy the receptor for local anesthetic and can produce the block of the sodium channel, isn't it? So that is why. So because the pKa of lidocaine is 7.8, pKa of bupivacaine, ropivacaine, levobupivacaine is 8.1. So their onset of action is delayed. So when you are going for a graded epidural, when you're using bupivacaine for graded epidural, wait for 10 minutes for each top up. For lidocaine, wait for 5 to 6 minutes before giving each top up. So that's how you can always do. Now again, coming to the test dosing in this patient. So should I use adrenaline for test dosing in this patient or should I not?
Better to avoid. It can increase in tachycardia
if it is intravascular.
Yeah, so that is one thing again in many of these patients, in patients here, also you have to avoid. Suppose you give, okay. Now, suppose the catheter, let us say that it is intravascular and you have given, will there be an increase in heart rate in this patient?
If patient is on beta blocker,
yes, patient is on a beta blocker. So this is another very important thing you should always understand. The patient is on a beta blocker. When you give the test dose with adrenaline of 15 micrograms, there won't be any heart rate response. Normally, you expect a heart rate response within 30 seconds of more than 10 beats or 10 to 15 beats of heart rate increase, isn't it? So there won't be any increase. So this is one thing. Don't think that, okay, I've given the test dose and there is no increase in heart rate, let me give. So Actually, it may be intravascular and it can produce problems. So what is checked in a patient with who is on beta blocker after using test dosing with adrenaline instead of heart rate?
BP,
You should check for
blood pressure.
pressure increase. How much of increase in systolic blood pressure you say is positive for intravascular placement?
10% increase.
10 to 15 millimeters of mercury. Why, there can be increase in blood pressure in these patients with adrenaline. Though 15 micrograms of adrenaline may not produce actually the alpha effect. It produces more of beta 1 and beta 2 effect. So normally with this low dose, you have a more heart rate response than the blood pressure response. But in a patient who is beta blocked, what happens to the alpha receptors?
Upregulate.
They'll have predominant effect, not upregulation.
Yes, sir.
They'll have predominant because they are always balanced. Both alpha and beta receptors are balanced, like sympathetic, parasympathetic. Even these receptors also balanced. So one will be trying to dilate, other will be trying to constrict. Beta 2 trying to dilate, alpha is trying to constrict. So the vessel wall will remain normal. So suddenly now the patient where the receptors are blocked, beta receptors are blocked. So when you give adrenaline, it preferentially will act on the alpha. Unopposed alpha action, there can be sudden increase in the blood. So this you have to look for in a patient who is beta blocked and you want to check for intravascular placement. So ideally in this patient, you don't use adrenaline at all. So if you're not using adrenaline, how do you know that it is not intravascular placement?
By giving fentanyl.
So you can use 100 micrograms of fentanyl and look for what?
Patient complaints of any itching or sedate.
Itching. Everybody need not have itching.
Or nausea.
The patients may have slight dizziness.
Dizziness, yes.
And sedation.
Yeah.
If you give. But in many patients, this 100 micrograms of fentanyl may be contraindicated, isn't it? Don't unnecessarily give that high amount of fentanyl because it can produce again respiratory depression. So is there anything else? Suppose if you have a precordial Doppler, you can place the precordial Doppler and inject about 1 ml of air rapidly.
Okay.
So precordial Doppler is qualitative. So it will just say that air has entered. So this you can do. But if you don't have any of these things, always aspirate before you inject. One thing, always be in communication with the patient when you are giving top-ups. Always give not more than 5 ml. Never keep a 10 ml syringe with you when you are giving top-ups. Always use 5 ml syringe because when you are communicating with the patient, when you are observing the patient, you can detect early the signs of toxicity, isn't it? So, and always aspirate. By aspiration, almost 80 to 90%, you can definitely detect whether it is intravascular if you aspirate blood before giving. So, okay. Now, these are all very important things regarding the test dosing. So, even with lidocaine also, I could have discussed more regarding the test dosing, where to check. Because, lidocaine, what lidocaine you are using? Is it isobaric, hypobaric, hyperbaric? For test dosing.
Isobaric virus.
Using isobaric, what is the specific gravity or density of what lidocaine, what we use? It is 0.999. That is at 20 degrees centigrade. So, the specific gravity of CSF is 1.0005 to 1.0007, isn't it? So, it is hypobaric. So, if you are putting the catheter in sitting posture and giving the lidocaine in sitting posture, where it will go? Suppose if it is intrathecal.
Will go down.
Will it produce any motor blockade? Will it go down? It will not go down. It will go up.
Correct.
Hypobaric. Again, you don't know, isn't it? So that's why there's a lot of controversies regarding this test dosing. So that's why it is very important to think that every dose what you give is a test dose. And keep observing the patient when you go for the epidurals. Okay, so these are some of the things about epidural. What are the benefits of this regional block, what you said about epidural, continuous epidural? graded epidural for these patients with ischemic heart disease?
One will be having analgesia. There will no airway manipulation with that increases stress.
Okay,
And-
very good.
Post-operative analgesia also.
Yeah. So positive findings mainly is post-op analgesia.
Yes.
So intra-op also, because you are going in for a graded epidural, it won't reduce the pressures much. So patient will have very good anesthesia, very good analgesia. So the patient's heart rate may not go up. But main problem is patient is awake.
Awake.
Any awake patient is
Stressful.
anxious,
Yes.
isn't it? So that is very important. So you have to sedate the patient when you go for this technique. So I was telling you about of course, the problems associated with regional blocks, mainly central axial block is again, the hypotension can occur. We don't know how these patients will react, which you wanted to avoid. That can be against your goal. Any hypotension can produce tachycardia also, isn't it? Which you wanted to avoid. So these are some of the risk factors are always there. And I told you patient is awake. So you have to sedate the patient. If they sedate the patient again, patient may hypoventilate, hypercarbia, hypoxia. So all these problems are also there. These are some of the negative points regarding the epidural. So continuous spinal also I told you. So again, the advantage about continuous spinal when compared to a single shot spinal is you are going to give incremental doses. So you are gradually producing ascending of your block so that the patient will not develop any kind of severe hypotension. Just like graded epidural, you can also go for continuous graded spinal also. So okay, now these are some of the advantages and the risks of regional blocks. Of course, in this patient, you can definitely, that can be your first choice, a graded epidural or a combined spinal epidural, which is again low dose combined spinal epidural or dural puncture epidural, you can go for. Okay, suppose let us say that you had planned for this and unfortunately the patient is not agreeing for regional anesthesia. Is one of the strongest contraindication for regional anesthesia is patient acceptance, isn't it? If the patient refuses, it can be a contraindications. And other things are also maybe there. Maybe there may be some infection, local infection. So you are not able to go for regional anesthesia now, or the patient also has more problems as far as her cardia is concerned. So she has got maybe some contraindications like the patient also has got an ejection fraction which is low. So now you thought about GA. So can you just tell about how do you go ahead and then give GA? Before that, the pre-medication, I told you any anesthesia, then again you start with previous day you go to the patient and then you can give a pre-medication in the previous evening and the next day. So you can just tell me about the details about how do you go ahead and then give GA for this.
Sir, in the previous day, I will take a consent from the patient after explaining this thing. And
What is that called as?
Informed consent.
Yeah, that is in the exam, you should always tell about informed consent. There is nothing called as high risk consent, low risk consent. There is nothing like that. You are going to get an informed consent. You are going to talk everything about whatever the risk the patient is about to have, and then you take the consent of the patient for that particular anesthesia. You are also going to explain little bit about the surgical things also, though the surgeon would have explained, you also can explain. Okay, so that is very important. So informed consent. Yes, again, anything else?
I would like to give 0.5 mg alprazolam to my patient in the previous day. And
so what is more important, pharmacological pre-medication or psychological pre-medication?
Psychological is very important.
Yeah, almost 75% you can allay the anxiety by your developing a good rapport, explaining everything to the patient and telling the patient that you are always with the patient, even in the post-operative period, you are there with the patient to look after. You're going to decrease the amount of pain in the post-operative period. So all these things you are going to explain to the patient. With that, patient can have a sound sleep in the night, isn't it? Of course, pharmacological is also important. So you want to give a mild benzodiazepine. Benzodiazepines are the best anxiolytic. Okay. Anything else on the previous evening?
We'd like to continue our medication. She is on amlodipine. I'd like to amlodipine, I would like to continue.
So you will instruct her, isn't it?
Yes.
To take these drugs in the morning. Okay.
And I would like to keep her Nilpar oral for.
That is another very important thing. NPO instructions.
Yes.
So informed consent, NPO instructions, do not forget. Okay. So already we discussed about NPO instructions. Then okay, that evening is over. The next day the patient is going to come.
So
She has been shifted to your pre-anesthetic holding area.
I would like to reassess the patient. I would like to reassure her.
Okay.
I would like to take her inside after reassuring. I would like to check intravenous line. And
there is no intravenous line. Don't assume that intravenous line will be there for every patient. Your hospital, they may be putting an intravenous line in the ward and then sending, but you don't assume. In the exam, you always think that you are going to start an intravenous line in the pre-op holding area or inside your OT. It all depends on in particular institution like. So okay, you are in the pre-op holding area. So or the patient, you want the patient to be shifted inside, right? So how do you start an IV line? No, any precautions you will have to take. That is what I'm asking you.
I will give local with insulin to put.
No, because any pain can increase their heart rate,
yes.
Isn't it? Any increase in heart rate you want to avoid. That is your goal.
Yes.
So could you have used something before getting the patient into the OT?
Emla cream.
Isn't it? So that is very important. So Emla cream is very important. So analgesia at the site of your cannulation, because cannulation itself can produce pain, and this is very important in this patient. You should not produce any pain, so which can increase the heart rate. So Emla cream you have placed, okay, but unfortunately there you could not get the light. You had a double puncture. Is it common? It can occur. So now what?
I will use local infiltration and.
Yeah, what local infiltration? 2%
lignocaine with the insulin syringe.
Yes, very good. With adrenaline, without adrenaline?
Without adrenaline.
Why without adrenaline?
It can cause vasoconstriction.
Yes, very good. That is one thing. And with adrenaline, the onset of action is delayed. Why with adrenaline onset of action is delayed?
Because of the absorption is less.
No, you want it to act there, it will be acting. You don't want it to absorb. Why it should be absorbed for systemic effect? You don't want. You want the local effect. So because adrenaline contains one of the preservatives is sodium metabisulfite. It produces local acidosis. So that is the reason the onset of action gets delayed. Because already we discussed about pKa and that is very important. That's why unnecessary you don't want to wait, isn't it? So you can give plain lidocaine with a syringe. So suppose if you think that even pricking that can produce tachycardia, any other method without pricking? So you can use 50-50 oxygen nitrous oxide. So also can be used. So that is almost like an Entonox-like, isn't it? So you have nitrous, you have oxygen, you can hold the mask, or you can ask one of your assistant to hold the mask. So how long you have to wait after starting your oxygen and nitrous oxide to start an IV line? When it starts effectively producing analgesia?
30 seconds.
Correct.
30 seconds.
You are guessing correctly. So onset of action is just 30 seconds. So peak analgesic effect will be there in 30 seconds. So you can start. So these are some of the things which you should always remember. You may not have a 26 gauge needle or insulin needle, isn't it? So just ask one of your assistant to hold the mask. Ask the patient to take some deep breaths. So patient will not even know that you have put an IV line with an 18 gauge needle, cannula. Okay, you have placed the cannula. Next what? So you are going to connect the patient to monitors?
Yes, I will.
I will. What monitors?
I will use 5 LEDs.
Preparation of the OT is again important. I did not go into details about that because of lack of time. Already we have spent 1 hour and 36 minutes. So, okay. So Hope you have kept everything ready, including a defibrillator.
Yes.
Okay, right.
And I will use 5-lead ECG, and I will use NIBP monitor, and I will use pulse oximetry for this patient.
Okay, non-invasive monitoring, isn't it? So invasive monitors, when you are going to use invasive monitors?
If my patient condition requires invasive monitoring.
So two things you should always tell in the exam. So one is severity of the disease the patient is having, and second is magnitude of surgery. So that will dictate to go for the invasive monitoring. So severity of the disease. If the disease is so severe, so naturally, suppose the patient is having a left ventricular failure and so optimized, his ejection fraction is about 30% or 25%. Definitely, I would like to go for a invasive monitoring like a direct arterial line, isn't it? A second thing is the magnitude of surgery. Suppose the patient is posted for a major vascular surgery or any major intrathoracic surgery, intra-abdominal surgery. So again, these are the two things which you should always keep in your mind when you are asked, when you are going in for invasive monitoring. So severity of the disease, magnitude of surgery. Very easy to tell in the exam. Okay. Now, again, coming to the ECG. So you said that 5-lead ECG. So which particular lead you want to have the monitoring on your screen?
I would like to monitor lead 2 and chest lead V5, sir.
V5. So V5 means where do you place the electrode?
Just lateral to the
Left side in the anterior axillary line.
Yes, anterior axillary line, isn't it? So V5 position is 5th intercostal space, anterior axillary line. So this positioning of these electrodes, you should always remember the chest positions, where V1, V2, V3, V4, V5, V6. So invariably, suddenly you will be asked in the exam. So you might not have given importance to this, but you should always remember about it. So V5 for
ischemia.
Yeah, ischemia, especially the left ventricle, isn't it? Because the left ventricle is more prone for ischemia. That's why you want to monitor the ischemia of the left ventricle. So lead 2 for rhythm.
For rhythm.
Why lead 2 for rhythm? Why not V5 for rhythm?
Right coronary artery supplies.
No, lead 2. Lead 2 also you can have lead 2 and the V5 together. You can have the sensitivity will increase if you are using only V5 for ischemia detection. So it is about 69% sensitivity. If you are combining lead 2, the sensitivity will increase to 86%. So if you also combine a V4, the sensitivity will be nearly 100% of detecting intraoperative or perioperative myocardial ischemia. So with only V5, if you are monitoring, it's about 69%. With lead 2 and V5, because you're also monitoring for the right coronary artery also. So that will give you 86%. And if you are also monitoring V4 also, that is nearly 100%. So that is, you should always know about. And rhythm, why lead 2 for rhythm? In which limb lead, all the waves are better represented. PQ, RST. P wave is so important for rhythm disturbances. It is always the lead 2. Because lead 2 is right arm to left foot, isn't it? Right arm to left foot. So that is same axis of the heart. It is parallel to the axis of the heart. So because it is a sum of lead 1 and lead 2 is lead 2. So that's why all the waves are better represented, especially the P wave is very well represented in lead 2. That is the reason identification of the P wave, whether it is present, absent, whether it is abnormal, normal. So it is very important for any rhythm. So that's why lead 2 and V5. So, okay, you can also go for Dover's technique. We'll not discuss about that. You can continuously monitor the 12 leads using only your 5 electrodes. That is the Dover's technique is also there. Easy technique is also there. We'll not discuss today because of lack of time. So already Azam is worried about the time is already we have spent.
No, sir. No, sir. Not at all, sir.
And if you have got only 3 electrodes, so again, you have to go for a modified leads. That is, you must be knowing about CC5, CS5, CM5 leads. So all those things better to know about. We'll not discuss in detail about this position of these electrodes. Okay, V5 and lead to for rhythm and myocardial ischemia. Okay, so neuromuscular junction monitor.
Yes. Yes.
Are you using or not using?
We don't have any institutes.
Okay, ideally in this patient, is it required?
Yes.
You want to be 100% sure that the patient has completely come out of neuromuscular blocking agents after the surgery is over when you are taking out the endotracheal tube.
Yes.
Because if there is a residual neuromuscular block, what is the problem in this patient?
There can be hypocapnia.
Hypoxia, hypercapnia. So both can produce increase in heart rate and can lead to myocardial ischemia or infarction in the post-op. So that's why it's very important. That also can be one of the non-invasive monitors. Then CAPNO.
Yes.
Yes.
ETCO2 is again very important. Already we discussed in our previous classes that you have to maintain normocarbia. Any hypoventilation, hyperventilation, both are dangerous intraoperatively in this patient. So you have to prevent. So depth monitoring, anesthesia depth monitoring. Suppose you have everything at your disposal. Is it important in this patient?
Yes.
Why?
You don't want lighter planes of anesthesia. Lighter planes
of anesthesia can produce tachycardia, hypertension, all the problems. So ideal would be, if available, you can go for even anesthesia depth monitoring, like BIS or entropy, you can definitely use. Okay. Anything else?
Temperature monitoring.
Temperature monitoring, very important. Both hypothermia and hypothermia again can produce problems. Hypothermia can lead to dysrhythmias especially. Body curve gets shifted to the left also. So that is another problem with hypothermia. So shivering. Patients can have problems. And post-operative shivering, increased requirement of oxygen. Okay. Okay. Anything else? You have used all non-invasive monitorings. Okay. Now, what is the fluid of choice you're going to start for this patient?
I'd like to start with ringer lactates.
Okay, ringer lactate, balanced salt solution. Avoid normal saline. It has got its own problems. Okay. Now, what pre-medicants you will be using?
I'll be using. I would like to avoid glycopyrrolate, sir. It can cause tachycardia.
Routinely now, no glycopyrrolate for anybody, unless it is indicated. Otherwise, no glycopyrrolate. In olden days, they used to use anticholinergics because ether was one of the common inhalation anesthetic agent. Ether is an irritant. It produces quite a bit of release of secretions. That is the reason we used to use. Now there is no role for anticholinergic agents unless there is a definite indication for using it. Okay, and here you don't use it because increase in heart rate you want to prevent. Right.
I'd like to give 2 microgram per kg of fentanyl.
Okay.
And I would like to give 1 mg of midazolam.
Okay, right.
So now after that, I will pre-oxygenate the patient for 3 minutes with 100% oxygen. So okay. Once after pre-oxygenation is done, I would like to induce.
So what circuit you are using? What circuit you are using for pre-oxygenation? I just asked.
Circle system with.
You are using circle system with absorber, right? Okay. Are you using some amount of CPAP for this patient, for any patient for that matter? Will it improve the pre-oxygenation? CPAP.
Yes, sir.
With PEEP. Will improve.
Yeah. No, PEEP, when the patient is breathing spontaneously, you call it as CPAP.
CPAP.
So definitely it will improve the FRC. Yes. Once the FRC is improved, more reserve will be there. Isn't it? So you can definitely use. So pre-oxygenation is very important. And now is the induction.
My patients.
Any other probably pre-medication nowadays many of us are using, which can definitely help in these patients. You can use at least 10 minutes before as an infusion.
Dexmedetomidine.
Dexmedetomidine. Any role for dexmedetomidine?
It will
For patients
reduce
with
the heart.
ischemic heart disease.
It will reduce tachycardia and it will reduce the preload. I mean, hypotension. It causes minimal hypotension.
Okay. As long as you don't rush it. Give it over 10 to 15 minutes, the bolus dose, or you can go for only intraoperative infusion also. So there are a lot of advantages of dexmedetomidine is there. So one is, reduction in the heart rate, and, the plane of anesthesia can be definitely deepened along with the other drugs. So you can balance it out. So depth of anesthesia will be very well maintained. So, and again, it won't have any post-operative problems, like it won't produce any respiratory depression, unlike your fentanyl or midazolam, is it? So that there is, you can definitely use. Are you using routinely?
Yes.
And also intraoperative blood loss also will be decreased because it maintains the blood pressure also. Shooting up of blood pressure will not occur intraoperatively. So there are many advantages. So definitely you can use. What is the dose of dexmedetomidine you can use?
Microgram per kg per minute for 10 minutes infusion, so followed by 0.3 to 0.7 microgram per kg.
You can definitely alter your dose intraoperatively if you want to use, or even a single dose you can give, isn't it? So that is there, right? Now, before giving your propofol, anything else? Oh, sorry, induction agent I wanted to ask. So in this patient, what induction agent?
So in this, my patient has normally ejection fraction normal function. So I want to use propofol 2 mg per kg, right, in incremental doses.
Okay. Suppose the patient has got ejection fraction on the lower side, about 30% or less than 30%, then
probably I'll use etomidate.
Etomidate may be a better choice in such situation, isn't it? If the that's what I told you, that initially only the history only you know whether the patient has got the good left ventricular function or poor left ventricular function, so that you can, even then only you can think what the induction agent I should use. Or should you go for high dose of fentanyl with opioids, fentanyl with midazolam?
Yes.
For this patient?
This patient we don't request.
Let us say that this patient also has got a poor left ventricular function, but posted for umbilical hernia repair.
We can go with the opioid, high dose of opioid and midazolam.
Now, what is the dose of opioid fentanyl you will be giving for induction?
10 to 15 microgram per kg.
25 to 50 micrograms per kg body. And what about the midazolam? How much you will be using?
0.1 to 0.2 milligram.
Yeah, 0.15 milligram per kg body. So high doses. So will they have prolonged duration of action?
Yes.
Yes.
And do these patients require post-operative mechanical ventilation when you give such high doses?
No, they will request.
But the patient is just posted for umbilical hernia, you want to. So that again in the exam, you should be very careful in answering.
Okay.
So you should say that no, this patient, suppose the patient is posted for a cardiac surgery where prophylactically post-operative ventilation is done. Then definitely you can go for high dose of opioid with benzodiazepine combination for inducing these patients. But the patient is posted for an umbilical hernia repair, why do you want to go for high dose? So you always go for etomidate, isn't it? Okay. So otherwise, propofol is best. So suppose the patient is around 40% ejection fraction, not very much low. So you want to go for propofol or etomidate?
I'll still use propofol. So
then propofol. Why propofol may be a better drug?
So it has better airway reflexes blunting effect, and it can cause minimal decrease in heart rate. And
so what is most important with the propofol? Difference between propofol and etomidate in
airway blunting,
ischemic heart disease.
Airway blunting will be better with
airway or sympathetic response to
sympathetic response.
No, there are two things. There are two different things. Airway reflexes are different. Autonomic response is different. You should be very clear when you are answering in the exam. So when you suppose I want to put an supraglottic airway device, then I can say that yes, airway reflexes are better blunted with propofol, so there won't be any laryngospasm or bronchospasm. So that is airway reflexes. So when you're talking about sympathetic response to intubation, so better attended by propofol when compared to etomidate. So that's why propofol may be a better drug. Suppose in this patient with 40% ejection fraction, would you just give propofol regularly like any other patient, or would you
We'll give in incremental doses.
in the otherwise called as a sleep dose, isn't it? You go for a sleep dose. What do you mean by sleep dose? How do you give sleep dose?
We'll keep talking to the patients and slowly we'll inject. Once the patient loses the verbal command, we'll stop.
That is almost every day you are doing that. Loss of verbal command is more important, or loss of eyelash reflex is more important?
Verbal.
Eyelash reflex always, eyelash reflexes are lost in the second stage, early second stage. So then you know that the patient is completely unconscious. Verbal commands in the first stage itself. So it is always better to go for loss of eyelash reflex. So what you do in case of sleep dose, sometimes you are asked in the exam, you calculate, okay, now this patient, based on the age, you will calculate the propofol dosing, isn't it? So the patient is 20 to 40, you will go for 2.5 milligram per kg body weight. 40 to 60, you go for 2 milligram per kg body weight. 60 to say 80 milligrams, you go for 1.5 milligrams. And 80 plus, you can even go for 1 milligram per kg. In adolescents and slightly younger children, you can even go for 3 milligram per kg. So that's how, based on the age, you calculate. Okay, you have calculated the dose of propofol. You take that amount, slowly you give 50% of that, and continuously monitor the eyelash reflex. Wait for one arm brain circulation time. Arm brain circulation time is time from where you are injecting into the IV line, reaching the brain. It has to go through the pulmonary circulation, left heart, and reach the brain. That is called as arm brain circulation. It is usually about 15 seconds. So just wait for that. And afterwards, you give 10 milligrams increments, waiting for about 10 to 15 seconds each time till the eyelash reflexes are lost. So that is called as sleep dose. So that you are not going to produce so much of myocardial depression or hypotension with propofol. Okay, before giving propofol, anything else?
If I'm planning for intubations, I will probably give 1.5 mg of lignocaine with.
Now, whether you plan for intubation or you don't plan for intubation, before propofol, you have to attenuate the pain response of propofol, isn't it? If you just give like that, the patient will howl with pain, and the heart rate will increase. You will see already ST depressions in the ECGs, isn't it? So very important that. So definitely, and here, if you're planning for intubation, definitely the suppression of the intubation response is also important. So you can give 1.5 milligram per kg body weight. Otherwise, if you want to just upturn the pain, you can go for a venous tourniquet and just give 20 milligrams of lidocaine is sufficient with a venous tourniquet. And afterwards, you can give propofol. This is the best method. But here you are planning for endotracheal intubation, or you are planning for supraglottic airway device?
For supraglottic.
Yeah, advantage of supraglottic airway device is also there. So when do you select a supraglottic airway device in these patients? Is it depending on the type of surgery?
Yes, it is depending. If the surgery and if full stomach is there, if the surgery is more chances of aspiration, then I would like to avoid.
No, if the surgery is a prolonged surgery,
yes,
supraglottic airway device may not be ideal, isn't it? So if it is a short duration or intermediate duration, about 1.5 hours maximum, then you can still go for supraglottic airway device. And again, full stomach, absolute contraindication. You should always tell, not even Procil, second generation supraglottic airway devices. And in ischemic heart disease patient, what is the advantage of going in for supraglottic airway device?
The neuroendocrine response we can avoid by using supraglottic.
So the response will be much less, isn't it? You are not using the laryngoscope. The pressure is very, very important. If you increase the pressure, more nerve endings get activated, increased incidence of hypertension and tachycardia. So supraglottic airway device, absolutely fine. So that you can always go for. But suppose if this patient is planned for laparoscopic umbilical hernia repair,
and still go for.
You want to go for a supraglottic airway device, or you want to go for an
endotracheal? We'll go with endotracheal.
Yeah, then better endotracheal intubation may be better. It all again depends on the surgeon also. the surgeon is quick enough, you can still go for a supraglottic airway device because the benefits are more in these patients. Though we know that when you produce pneumoperitoneum, the airway pressures will increase. There can be more leak. But if you are using second generation supraglottic airway devices like an iGel or a ProSeal or LMS Supreme, still fine. But okay, this patient you wanted to go for endotracheal intubation. So how do you obtain the sympathetic response?
I will give 1.5 mg of lignocaine with preservative-free lignocaine 90 seconds prior to intubation, or 0.5 mg per kg esmolol.
What is most important to prevent the
Tachycardia.
intubation responses?
Scopy times and less than 15 seconds, smooth scopy.
Yes. So these are the first things you should always tell in the exam. One is gentle laryngoscopy. So if you use more pressure, then definitely more response will be there. Gentle laryngoscopy. Second thing is duration of laryngoscopy should not be more than 15 seconds, as less as possible, because more the time you take, more response will be there. Third is the depth of anesthesia. So the patient is light, response is very high. See that the patient is sufficiently deep enough when you are. So these three things first you tell. Afterwards, your lidocaine, whether you want to go for esmolol or any other drugs to suppress, even calcium diltiazem has been used, isn't it? So these three things first is very important. So deep plane of anesthesia, so short laryngoscopy duration and intubation duration. And the third thing is, what is the third thing? So don't go for more pressure, gentle laryngoscopy. Okay, so you have avoided all these, you have intubated the patient. Now you want to maintain the patient. How do you maintain the patient? Now, I did not ask you what relaxant, muscle relaxant.
I will give 0.1 mg per kg of Vicuronium.
What is this 0.1 milligram per kg body weight of Vicuronium?
Induction dose.
Induction dose. It is twice the ED95. Isn't it? Okay. You wanted to intubate the patient. Why not succinylcholine?
Succinylcholine can again cause tachycardia.
Tachycardia. Succinylcholine will produce bradycardia, tachycardia.
Severe bradycardia and
dysrhythmias. And severe bradycardia can occur in a patient who is on a beta block. And there are only definitive indications for succinylcholine, isn't it? So routinely you need not have to use succinylcholine. Okay, there is a big thing we can discuss almost about 15-20 minutes about succinylcholine itself. Okay, you have given Vicuronium 0.1 milligram per kg body weight. You have intubated. Now, how do you maintain this patient?
I would like to maintain the anesthesia with 40-60 mixture of nitrous oxide and oxygen with inhalational agent of isoflurane.
So, any contraindication for nitrous?
Yes.
Suppose if they are doing laparoscopic surgery,
laparoscopic it is contraindicated.
You should avoid, isn't it? Because the bowel distension can occur, they may have problem one. And in patients with pulmonary hypertension,
Yes,
again you have to avoid, isn't it? In these patients. Okay. So, but nitrous oxide, why do you want to go for 40% FiO2? Usually, what is the percentage of FiO2 you can have?
Anything more than 35%.
30%. So don't go for higher FiO2 also, because we know that oxygen-free radicals are again dangerous for many of these patients, especially patients with ischemic heart disease. You don't want to go for unnecessary higher FiO2. Okay. So then if you think that the nitrous oxide is contraindicated, then you can go for air with option of FiO2 of 0.3 FiO2. Okay. Okay, right. Then avoid intraoperatively, you should always avoid hyperventilation. That is the most important thing. So already we have discussed how to set the tidal volume and how to set the rate, isn't it? So see that with these things, 1 minute ventilation is enough. So you can always have 1 minute ventilation. Continuously monitor the ETCO2. See that the ETCO2 is between 35 to 40. So maintain that. Never hyperventilate. All the problems can occur hyperventilation. So intraoperatively, again, avoid hypothermia. So you have to maintain normothermia. That is one thing. Always maintain deeper plane of anesthesia, and better to have a gas monitoring, anesthesia gas monitoring. If you have, you can maintain a MAC of 0.8 to 1 MAC continuously, isn't it? Higher MAC also, don't go for higher MAC. So that can produce myocardial depression, inhalation anesthetic agents. Already we were discussing about inhalation anesthetic agents. They're very good because they produce very good preconditioning. And how long this preconditioning, ischemic preconditioning, get extended with inhalation anesthetic agents? It can extend for 6 to 8 hours, even after stopping. That is why they are quite advantageous. But you have to be very careful. You don't give higher than 1 MAC, because though you may be using sevoflurane, isoflurane, or desflurane, anything higher than 1 MAC can produce myocardial depression. And among these three, which inhalation anesthetic agent you would like to use?
Isoflurane, which causes
Isoflurane, because theoretical possibility of
coronary stitching.
Isn't it?
Yes.
So it's only theoretical possibility, but if you want to avoid isoflurane, then which one?
Desflurane.
Desflurane, what is the effect of desflurane on the heart rate?
It decreases.
Decreases desflurane. Desflurane increases the heart rate. So you wanted to avoid any increase in heart rate, isn't it? So which is remaining now?
Sevoflurane.
Sevoflurane. Maybe sevoflurane may be ideal, thinking about all these problems with isoflurane and desflurane. How about halothane?
Halothane is arachnogen.
Halothane definitely you want to avoid, isn't it? Dr. Azam, I'm slightly rushing through because already we have spent 2 hours.
No, sir. Please continue, sir. This is the most interesting part of the discussion. Thank you.
Okay. So inhalation anesthetic agent, so you have to be careful. So better probably sevoflurane, because sevoflurane doesn't have these problems of increase in heart rate or producing coronary steel, and also its blood gas solubility coefficient is just 0.63. So recovery also can be faster, and it is also soft on the upper respiratory tract. So multiple advantages are there. So you can definitely go for that. And you can go for low flow. I think you are usually going in for low flow technique. So with the sevoflurane, what is the minimal this thing you will be going in for?
If it is not more than 2 hours, 1 liter can be used.
2 MAC hours. It is not just hours, MAC hours. So what is the MAC you are using, and multiplied by the number of hours is called as MAC hours. Usually if the MAC hours are not more than 2, that is one of the guidelines that was given, you can go for 1 liter. If it is exceeding 2 MAC hours, then 2 liters with low flows. Okay, so let us see that everything is fine, and suddenly you are finding some ST depressions. So, diagnosis of perioperative myocardial ischemia. So this is commonly asked for you, the exam. And how do you manage perioperative myocardial diagnosis and management of perioperative myocardial ischemia?
Any change in preoperative ECG changes like ST depression, ST elevations?
Okay.
As new onset changes. The most common causes will be tachycardia, hypotension.
So how much time, after ischemia, you can see in the ECG? Usually, is it rapidly you can see in the ECG after the patient has developed ischemia? It may take nearly 90 seconds to 2 minutes. So which one rapidly can know whether the myocardial ischemia, which particular monitor? So transesophageal echo.
Echocardiography.
Transesophageal echo. Routinely, you don't use transesophageal echo. So of course, there are some indications for using transesophageal echo also. So in high-risk patient, definitely you can use, provided you are an expert in that. And second thing is, intraoperatively, if there is a myocardial ischemia occurs and there is severe hypotension or problems are occurring, then also you can place a transesophageal echo to know what is the cause for hypotension, how to manage, isn't it? So TE is the one which can, any change in the wall motion abnormalities, suddenly they start occurring, then you know that it can be due to myocardial ischemia. It is rapid. Okay. Whereas pulmonary capillary bed pressure, it takes about 25 to 30 seconds before the pressures start increasing. So these are some of the things you should know about. Okay. So now you are seeing ST depressions in this thing, and you think that perioperative myocardial ischemia is occurring. So how do you manage?
So we should try to find out the cause for whether there is any supply demand. What is the most common cause?
Most common, otherwise myocardial infarction, how do you classify? What are the different types of myocardial infarction?
Type 1 and type 2.
Type 1, type 2, type 3, type 4, and type 5, isn't it?
Yes.
There are 5 types. So type 1 is
Plaque rupture.
Plaque rupture.
Type
Type
2
two
is
Plaque rupture going and blocking. That is type 1. Type 2 is
Oxygen supply demand.
supply
Imbalance.
demand problem. That is usually more common in the perioperative period. Non-perioperative period, type 1 is more common. Type 3 is sudden cardiac death in a patient who is having ischemic heart disease. So that is type 3 myocardial infarction. Type 4 is again classified into 4A and 4B. 4A myocardial infarction that occurs in patients where they are undergoing a PCI, percutaneous intervention. 4B is stent thrombotic patients. Patients having a stent like this patient, suddenly developing a thrombosis and developing myocardial infarction. And type 5 is myocardial infarction occurring during CABG. So these are 5 types, but most common perioperatively is supply demand imbalance. Okay, now how do you assess now this patient?
We'll check whether the patient is having any tachycardia, hypotension,
Yes,
any reversible causes.
What are the most common cause of myocardial ischemia intraoperative?
Lighter planes of anesthesia.
Very good. So I keep telling my students that any problem that occurs intraoperatively, always first cause if you say lighter planes, you are always correct. Whatever it may be, whether it is respiratory bronchospasm or myocardial ischemia. So that is what you should always understand. So lighter planes. So first thing is you can deepen the plane of anesthesia. That is there. And if there is any tachycardia being the cause,
Analgesia could be pain. So we have to
give adequate analgesia.
Hypovolemia. So, or any blood loss.
Try to know what is the cause for tachycardia. So sometimes even after treating or knowing about all the causes and treating the cause, still there can be an unexplained tachycardia. So if it is an unexplained tachycardia, then what you use?
Esmolol short acting.
Esmolol you may have to use, isn't it? 0.5 milligram per kg body weight bolus, followed by 100 to 300 micrograms per kg per minute infusion. Okay. Suppose if there is hypotension is the cause.
If hypotension is treated with crystalloids,
again you'll have to know why hypotension is occurring. Is it because of the inhalation anesthetic agents that they are producing, or is it because of the bleeding? Because most common cause, these two are the most common cause perioperative. So if it is bleeding, then you have to go for definitely fluids. And if it is because of inhalation anesthetic agents, slightly reduce the inhalation anesthetic agents. So usually it may get corrected. Suppose sometimes there can be unexplained hypotension.
It can be.
Then you may have to go for using vasopressors. So which vasopressors may be ideal?
Dobutamine.
No, dobutamine is an inotrope. It is not a vasopressor. So you should always know which is an inotrope, which is a vasopressor. Vasopressors are, you have mephentermine, ephedrine, metaraminol,
phenylephrine.
Phenylephrine may be a better choice because
tachycardia is also
it avoids
is avoided, isn't it? So would you increase the FiO2?
Yes, sir. Yes.
Why FiO2? How it is going to help?
To increase the oxygen content.
Yeah, already we have discussed, because the dissolved content will increase. Okay, immediately, suppose if it is persisting, would you send for any biochemical test?
Yes, troponin I, troponin D will send.
Yeah, that is again very important thing if it is persisting, and very important to prevent hypotension, because any persistent hypotension for more than 30 minutes or cumulative hypotension for more than 2 hours can produce myocardial ischemia or infarction. So this you have to be very sure that you should not produce this even in the postoperative.
Yes.
And myocardial ischemia and infarctions are more common in the postoperative period between 24 to 72 hours. That is why it is said is, intraoperatively you are managing any monitoring, effective monitoring will be there. You're monitoring the blood pressure. You're not allowing the blood pressure to either go down or going too much high. So all those things. But in the postoperative period, you are not intensely monitoring the blood pressure, especially after 24 hours. So you may be monitoring once in 3 hours or 4 hours. And that is the time when the patient can have a sustained hypotension. And I told you, any sustained hypotension for more than 30 minutes can produce myocardial ischemia or infarction. So it is very important. And another very important thing again here is extubation. So extubation is also very important. So you have to take care to prevent response to extubation, and make sure that the patient has been given very good antiemetic, prophylactic antiemesis, not to produce postoperative vomiting, and maintain very good post-op analgesia in this patient. You can even put an epidural if the patient is posted for an upper abdominal surgery or any other surgery where epidural can be placed, and post-op analgesia. And maintenance of very good post-op analgesia using a balanced technique, using multimodal analgesia is very important in these patients, isn't it? So extubation response has to be attended. You can use again 1.5 milligram per kg body weight of lidocaine before extubating. And there are methods like even Bailey's method you can use, wherein you can extubate the patient deep with putting a supraglottic airway device also. So all these methods you have to take care in the post-operative period also, isn't it? So monitor these patients at least for 24 hours, even though you think that the risk may not be high. So monitor him, this particular patient, for 24 hours in your post-anesthesia care unit, and then only you can send the patient to the ward. So these are all very, very important things to know about. And intra-op fluid management again is very important. So there are 3 methods of fluid management, isn't it? Restrictive, liberalized, and goal directed. So ideal would be to go for
Goal directed.
Goal directed. Again, goal directed depends on the severity of surgery and severity of that is magnitude of surgery and severity of the disease. If both are very low, severity of the disease is low, magnitude of surgery is low, you can go for either restrictive or liberalized. It doesn't matter much. If any one is higher, magnitude of surgery is very high, or the patient has got very severe disease, or both are there, severe disease with high magnitude of surgery, then personalized goal directed fluid therapy to be given. Okay, you can use your flow track, or you can use your any of these stroke volume variation and pulse pressure variation, systolic pressure variation, or also if you have a very sophisticated Massimo pulse oximeter, length variability index, and non-invasive. So that is very easy. You don't require a invasive monitoring. Length variability index also. So these are all the important things. So we have already spent 2 hours, 15 minutes. I think Dr. Azam also has got some queries from many of the people also. Just discuss.
Yes, sir. Thank you, sir. Thank you so much. I think anesthesia itself, we should divide into 3 classes, sir. 1.5 hours each. You can go on and on.
Yeah, correct. You can definitely discuss so much. Yes, anesthesia itself.
Excellent, sir. I mean, I have never heard so much depth from, just too good, sir. Thank you so much once again.
Thank you.
Sir, can we take some questions, sir?
Yeah, sure.
Yeah. Yesterday's little bit of spillover questions were there.
Yeah.
Dr. Satish was asking, good evening, sir. Can you please repeat the formula for estimation of hemoglobin increases after a blood transfusion?
Okay. So do we have the time for the explanation? Okay. Yes. Normally, the packed cells is usually 300 ml packed cells. So the hematocrit of packed cells is 60%. So 60% means if you convert it to hemoglobin, you divide it by 3, you get the hemoglobin. So 60% hematocrit means 20 grams of hemoglobin. So 20 grams of hemoglobin will be there in 100 ml of packed cells. So you are giving 300 ml of packed cells. So how much we are giving total hemoglobin to the patient is 60 grams. So 20 into 3. So when you are giving this 60 grams of hemoglobin is added into the blood volume of the patient. So blood volume is usually calculated. For male, it is 70 ml. For female, it is 65 ml. So you just know that what is the blood volume. So let us say that the blood volume is 5 liters. So you are adding the 60 grams into 5 liters. So that means 5 liters you have added 60 grams. So we are calculating the hemoglobin per 100 ml. So if it is 5 liters, it is increase is 60 grams. Per 100 ml, how much increase? So 100 ml divided by 5,000 multiplied by 60. So 60 multiplied by 10 is, how much? 60 multiplied by 100 is 6,000 divided by 5,000. So that will be 1.2 grams. So roughly that is the reason why we always say 1 packed cell volume, if you give, it increases the hemoglobin level by 1 gram. So it all depends again the blood volume. Suppose the patient's blood volume itself is about 2,500 ml. Then actually the hemoglobin increase will be 2 grams. It will be double. So that's how you can always estimate the amount of rise of hemoglobin. You are muted there.
Yes, sir. Yes, sir. Sorry, sir. Yeah. Thank you, sir. That clears most of our students' doubt. Sir, the other thing what you said was, how do you make out which is the dominant artery was one question asked, sir. And why the LAD is called as a widow artery?
No, that already I have explained because, LAD supplies most of the left ventricle. And if that gets blocked, the patient invariably may die. And majority of the things, males are more commonly having ischemic heart disease. And if the male person dies, his wife becomes a widow. That's why it is called as a. So you cannot make out unless you do an angio, which is dominant.
Okay, sir. Sure. Thank you, sir. And Dr. Arnab Banerjee's yesterday's question, how do we calculate safe apnea time, sir?
Safe apnea time, it all depends on how much the patient has a reserve. If the patient has very high reserve and his oxygen consumption is very low, so then, safe apnea time can be, once you pre-oxygenate the patient, it can be 7 to 8 minutes, provided you pre-oxygenate the patient properly. Yes. Okay. So in those patients where, for example, now a pregnant mother is there, or a patient who has had a trauma and has lost a lot of blood, so these patients will have less amount of reserve, so less apnea time they can have. So that's why we go for modified rapid sequence induction. We even ventilate them when we are actually going in for rapid sequence induction. Isn't it? So that's how you know about the patient. It is always, individual patient, depending on the respiratory disease, the cardiac disease, the amount of hemoglobin, so the amount of the reserve the patient has. So it all depends on those things.
Yes. So it cannot be constant for every patient.
Definitely not. Definitely.
Yes, sir. Yes, sir. Sir, can you please explain the graded epidural, just for the clarity of the students?
Yeah, graded epidural, you gradually increase the level of the block so that gradually increase, because an epidural itself is a segmental block. Yes. In a segmental block, definitely the amount of sympathetic block is much less. So the amount of hemodynamic changes are also much less. But still, you even do not want even that amount of hemodynamic changes in these patients where that can produce problems. So then you go for a graded epidural. So first you give the test dose of 3 ml lidocaine with, it depends on whether adrenaline you can use or not. That already we discussed. And afterwards, the first dose you can give is 5 ml of either lidocaine or bupivacaine. If you're going for graded epidural, it is always better to go for bupivacaine because bupivacaine takes its own time to act. So naturally, the hemodynamic changes will be much less when compared to lidocaine. That is why bupivacaine, you can give the first dose 5 ml and wait for 10 minutes, assess the level of block, and afterwards you can go for 3 ml increments to attain the final maximum block. So wait for 10 minutes every time.
So first dose will be 5 ml, sir.
5 ml.
It will be 3 ml of alcohol.
And for graded epidural, you should have sufficient time.
Yes.
And the surgeon should not be sitting on your head.
Yes. True, sir.
Yeah, that you have to discuss with the surgeon beforehand on.
Yes, sir.
Yes.
Thank you. Dr. Rati's yesterday's question, sir. What is the cutoff level based on platelet count on epidurals and spinals?
That is always there, 1 lakh ideal for epidural. For even any central neuraxial block, ideal would be, it should be more than 1 lakh. But since, the benefits of central neuraxial block may be much higher than GA, so we can still go up to 80,000 platelets, we go for epidural, and up to 50,000, we go for spine.
Spine. Sure. Thank you, sir. Sir, Dr. Eroka Mani, sir, regarding ST segment depression and its duration intraoperatively and postoperatively. So I think you have spoken about it, sir.
Yes.
And other thing was Dr. Arnab Banerjee was asking, sir, how will we precisely control the level in spinal like T4 or T6? Based on the table tilt, it may always be up or low, question mark.
Now, one thing I want to tell you about the intrathecal, this thing, majority of the times you may not have good control over it. You all must have experienced, even Dr. Azam will always work for me, because in a patient we want very high spinal, it will become very low. In a patient we want very low spinal, it will go very high up. But anyway, we have major criteria and minor factors which can influence the spread of the local anesthetic in the CSF. So once you know these major factors, minor factors, you can definitely control these major and minor factors. Is a major factor, that the volume is very important, the concentration is very important, then the varicity is important, the position is important. These are the 4 major criteria. Minor criteria, there are many things like pregnancy, obesity, age of the patient, level of the table, yes, and even size of your needle, the size of the needle. There's so many things are there. So
it's difficult to control the level precisely.
All these things in your mind, and then you can definitely apply all these factors, and you can get a proper level of it.
Yes, sir.
But still, I still say that many times it may not be under our control.
Absolutely, sir. Like in fact, today itself, sir, we had a very obese patient for a total abdominal hysterectomy, and we gave about 4 ml, thinking that, okay, though she was obese and all, still the block never reached what the level we wanted. So it is very difficult.
4 ml can produce total spinal.
Absolutely, sir. Sometimes
in an obese patient, where
yes,
the intrathecal space is so narrow.
Yes, sir.
But it is very unusual that it has. Yeah, you must have given in sitting posture.
Yes, sir.
And
Sitting.
if you have taken slightly more time in order to bring the patient to lying down, that also, because I told you that that's a major factor, position and varicity.
Yes, sir. Though we put her down very fast, immediately.
Okay.
Yeah,
that is what you don't have absolutely any control.
And sir, moreover, they say in obesity you reduce the spinal volume dose.
Yeah.
Which is actually not helped in this patient. So, as you say, totally agree that there is no precisely we can control the level.
Yeah, because I still want to tell you one of my experience. I had given during those days we were giving lidocaine.
Yes,
intrathecal. In a morbidly obese patient, I had given 1.5 ml. It produced total spinal. I had to intubate. I had to ventilate her for 1.5 hours. She was totally unconscious, not breathing. So after 1.5 hours only, she started breathing. She came out well. Absolutely, there was no problem. She had an arrest actually with 1 point, because total spinal,
Yes, sir. Yes, sir.
That and that to a doctor's wife.
Oh.
So
no
everything was fine, and I asked her to come up. We did not do the surgery. Surgeon never wanted to continue the surgery. So it was abdominal hysterectomy. We told him that you take it was in Ballari. So asked the medical officer to take her to Bangalore. He said, no, sir, you have to give anesthesia and the same surgeon has to do surgery. So then I told her to come after 3 months. I gave her all diet instructions. She came back with 10 kg increase. Then I gave her GA and then managed. So that's why I was telling you 4 ml can produce total spinal.
Yes, sir.
Yeah.
Sir, other question from same Dr. Arnab Banerjee. Sir, suppose in patients like MS where we don't want tachycardia, should we give test dose question mark? Because if it accidentally intravascular, then there will be tachycardia and catastrophe can occur. So what should we do in
Already that has been discussed.
discuss?
In
Yes,
this patient also we discussed.
it is patient to patient. You cannot take every case as a Dr. Kurichin Arnasalam, kindly repeat the sleep dose of propofol. Yes, sir. I think there was a little break in the internet. If I'm not sure.
Okay.
Sir.
So sleep dose of thiopentone and propofol. In our days, we used to use thiopentone. Then also the sleep dose used to be there. So you just calculate the total dose that is required for the patient. So depending on the age of the patient, I said about propofol. So once you calculate the total dose, what you have to do is, anyway, you are pre-oxygenating the patient. You look for the eyelash reflex. You just give half the dose first. For example, okay, the total dose you wanted to give is about 140 milligrams. Okay, so out of 140 milligrams, slowly you give 70 milligrams, and then wait now for one complete arm-brain circulation time. Arm-brain circulation time is from the place where you are injecting. The drug has to act on the brain, your drug. So that is why it has to go to the first right heart, then go through the pulmonary circulation, then go to the left heart, then through the aorta, then carotids, and then reach the brain. So this is called as one arm-brain circulation time. Usually in a normal cardiac output patients is about 15 seconds. So in patients with older age group, with stenotic, mitral stenotic patients and all those, there can be slow circulation. You may have to wait for longer, 20-25 seconds. Otherwise, just 15 seconds is okay. So just wait for 15 seconds. Check for eyelash reflexes. If the eyelash reflexes are still preserved, now you give 10 milligram increments. So 10 milligrams increments, again wait for 15 seconds. Check for eyelash reflex till the eyelash reflexes are last. That will be end of your giving propofol. If you are using thiopentone, same thing, but 25 milligrams increments you have.
Okay. Thank you, sir. And Dr. Satish was asking, sir, can we use metoprolol to control heart rate in patients with no ejection fraction like 30%? Is esmolol preferable?
So then definitely, because esmolol you have a better control. Because esmolol is very short acting, almost ultra short acting when compared to metoprolol. So it is always better to go for esmolol than metoprolol, because metoprolol has got a longer duration of action.
Yes, sir.
And also, its effects on the myocardium.
Yes, thank you, sir. And Dr. Muthukumar Rajgopalan, I think this is a very simple question. Why not ketamine and propofol to avoid hypotension in induction?
No,
Ketamine and propofol.
No, better don't try things. And as a postgraduate, never tell ketofol, all those things in the
Exams.
So, because unless it is there in the standard textbooks like Miller or Parash, it is better not to tell in the exam. So you can try many things. That is always there. So, but it has to be standardized and it has to be, safe. So it is always better to go for only propofol.
Yes.
And if you think that ejection fraction is low, and it's better to go for etomidate.
Thank you, sir. And last question, sir, by Dr. Naresh Kumar. Sir, can we use lidocaine both during intubation and extubation for suppressing the response?
Sure, definitely. That's what I said also.
Yes, sir. You did mention that. Yeah, sir. I think by this.
Sir, I have one doubt.
Yeah.
Okay, Vinod.
Sir, one patient coming for torsion of testes, sir.
It's an emergency.
Yeah, emergency. But 3 days back, he has stopped clopidogrel.
Okay.
Yeah, and one side of the lung is fully fibrosed, where he is maintaining saturation of 92 with 6 liters of oxygen.
Right.
So what anesthesia would we prefer?
No, you see, any patient, always you should think about the benefits and risks.
Yes.
You have to weigh the benefits and risks. Now, if a patient has got severe respiratory disease, suppose the same patient has come with an acute attack of bronchial asthma, and the surgery you have to take up as early as possible. And if you put even a supraglottic airway device or an endotracheal tube, the patient is going to have an intraoperative bronchospasm, and it definitely can have a lot of problems. So in all those such patients, the benefits of regional anesthesia would definitely outweigh the risks of regional anesthesia, especially if you have already 3 days are over. And that too, if you are using a thin gauge needle like 27 or 29 gauge needle, the chances of epidural hematoma will be very minimal. And I told you, every day after stopping this clopidogrel or aspirin, 10% of the platelets will generate, isn't it? So by that time, already 30% of the platelets would have generated. Or let us say that the patient is still on clopidogrel.
Yes.
Now you think that GI is absolutely contraindicated.
Yes.
Then definitely you can give platelet supplements and then go for spinal. If you think that definitely GI is can produce definitely very serious complications, then you can go for platelets. Again, you have two kinds of platelets, isn't it? So single donor platelet, random donor. A single donor platelet, it is about 250 ml. It can increase the platelet to 30 to 40,000. And 30 to 40,000 increase is definitely and all these are good platelets, functioning platelets, isn't it? So because you know that clopidogrel has got only a half-life of 6 hours.
Yes.
So already the clopidogrel will not hardly be there in the circulation to suppress these platelets. You can still give one single donor platelet, or you can go for random donor about 4 to 5. Random donor platelets will increase the platelets by about 5 to 8,000 per packet. That is 50 ml. Random donor platelets, each sachet is 50 ml. Single donor is 250 ml. So you can definitely use this. That is what you'll have to think about that particular individual patient. What are the risks and benefits of each technique? And you have to individualize everything for that particular patient. You cannot generalize things.
So what about explaining the risk of epidural hematoma in such cases to the relatives?
Yeah, definitely. And you can, because we have given spinal here only.
Yes, sir.
Such patients only, we given spinal, but monitoring is very important in the postoperative period, because, the risk is still there of spinal hematoma. So, but the risk is very, very minimal as long as you go for a single prick and then you take a thin gauge needle. You're not going for an epidural. Epidural will produce more chance of epidural hematoma when compared to a thin gauge spinal needle. But still you can explain things, and you can also explain things that giving GI is hazardous. That is very important. And you have to document everything in the case sheet. Why you have chosen spinal.
One more. Sir, in which patient would we choose that CT coronary angiography?
So routinely it is not required as such. But suppose you know that in a patient you want to go for, probably this patient may require intervention, coronary intervention before taking up. He is quite, you think that definitely this patient may require a coronary intervention before taking up. So, or you think that this patient, unnecessarily, if I go for an invasive procedure, invasive, angiography itself has got its own risks. It is said 1% risk of death is there. 1%. 1% is not small. 100 patients, if we are just doing angiography, 1%, one patient may die, isn't it? So non-invasive testing is simple. Now it can be, now they are even thinking it can be a regular use for risk stratification in every patient with ischemic heart disease. So you just subject him for, but if you're using contrast, again, you have a problem, because contrast-induced acute kidney failure can occur. Without contrast also it can be done. So, and then you can score the calcium scoring. And based on the calcium scoring, you can, I told you, suppose if it is 0, you know that absolutely no problem at all. If it is anything less than 100 also, the mild risk is there, 100 to 400, and anything above 400. Probably anything above 400, you may require patients to be subjected for PCI or CABG before taking up.
Thank you, sir.
Anything else, Dr. Vinod and Harish?
Thank you.
Thank you, sir. Thank you so much.
Thank you once again, Gurudatt sir. On behalf of the students from all over India, my humble submission to you for taking time out for 3 continuous days, your precious time. You have let gone everything of your your home, personal, everything. Thank you so much, sir. And I'm always in debt to you for this, sir. Thank you so much, sir, once again.
Thank you, Dr. Azam. Thank you, Vinod and Harish.
Yes, sir. So before you
Thanks
get off,
for
sir,
Thank you.
before
Medinet people.
yes, sir. Medinet, yeah, Mansa and Surendra and Mahesh are here. Thank you so much.